She came for Dr. Suma.
Okay.
And you said you might be, I think, leaving in January. I think 31st January was the last, I think.
Yeah, I joined, I think, on 8th.
Right. So that's what they're saying.
I think which they have made up for the pediatric ophthalmology. Yeah.
Good morning, sir.
Good morning. How are you?
I'm good, sir.
Yeah.
I think, Sonia, you can change the title. It's coming Abhimanyu Parasar. You can change your name.
Okay. So I'll have to log out for that, no?
Yeah, log out and you can log in again.
Okay.
No, please don't log out. Don't log out.
Then
Just a minute. Abhimanyu, what's your name?
Sonia Sharma.
Sonia Sharma. Just a minute.
Okay.
It's Sonia or Niya?
Sonia.
Okay. It's very simple. No need to log out. Just right click on your name and there is and tab on rename and you will be.
Okay. So Abhi, right now it's mentioning Sona Sharma.
Oh,
It's
just a minute.
Sonia.
Just a minute. Just a minute. Now it's fine.
Yeah. Thank you.
Okay, man.
A very warm and pleasant good morning to one and all. I am Darshita Suroi, Vice President of Optometry Students Association. Team OSA feels really greatly honored and join me in sharing pleasure of having you all with us and express their gratitude. With the idea of embodying technology and culturing excellence in eye care, we shall begin with our first session. Session 1 is orthoptics and vision therapy. I am delighted to welcome Dr. Swati Fuljale, serving as an assistant professor in Dr. RP Center, AIMS, New Delhi. She has a professional experience of more than 15 years. She is a reviewer of articles of national and international journals and has many national and international publications to her credit. She is currently the co-chairperson of Bachelor of Optometry in AIMS, New Delhi, and has always supported the vision and mission of this course. Over to you, ma'am.
Thank you, Darshita. Good morning, everybody. Good morning, sir. I hope I can share my screen, right? Yeah. Yeah, so I would be basically talking about binocular vision evaluation and would be touching upon the normal, the protocol that we follow here at RP Center, and also about, latest advances, because the focus has been shifting now to more advanced way of evaluation, or I would say more a more cortical assessment, more of an visual cortex kind of an assessment, more towards the comprehension and cognition of vision rather than just evaluating the vision. So as we all know, binocular vision is a supremacy of man in animal kingdom. We are the ones who are blessed to have this kind of vision rather than the lower animals like birds or prey specifically, who have laterally placed eyes to get more panoramic view rather than us, or the other predators who have frontally placed eyes to get more binocular view. So this diagram is just to show this same, that how a binocular and a monocular view is seen. So with a laterally placed eye, it's a mainly uniocular visual field that one can see with each eye, while with the frontally placed eye, it's more of a binocular field which we see with our both eyes. So binocular vision, as we all know, is the fusion of the image that each eye sees individually to form a single image, a single clear image that is in the brain. So the whole visual system down from the eye, that includes cornea, retina, optic nerve, and the visual tract along with the cortex, has to be in a perfectly integrated to have a proper binocular single vision. Otherwise there will be various issues. So what is the role of binocularity in in day-to-day life. That's what it is very important. We take certain things for granted. We feel that, oh, this is all is a normal phenomena. We don't realize the importance of binocular vision in our day-to-day life. So something as simple as pouring liquid into a cup, catching a fast hitting or a fast moving object, judging how quickly a car is approaching while crossing road or while driving. So these are very, very simple tasks which are, where the binocularity has important role. We don't realize it unless we lose it. So once a person has lost it, then only you realize that how difficult it is to perform a daily activity in absence of binocular vision. So it has both the components, the sensory component as well as the motor component. The sensory component is something which is, in the cortex, where the actual fusion of the image occurs and where there is other higher visual functions. While the motor component is the component which is driven by extraocular muscles and their nerves. So to begin with, I'll first discuss how to evaluate the sensory system. So as we all know, Worth had classified binocular vision in 3 grades. So number 1 is a simultaneous perception, where each eye can see an image simultaneously and they're not seeing it at 2 different images. Then the fusion of that perception to form a single image, and also the stereoscopic vision is the 3rd grade of binocular vision. But apart from that, the focus is now shifting to the higher visual functions other than just assessing these 3 components of binocular vision. So there are, with the development of technology and digital screen, we have this kind of issues, the accommodation related issues, convergence related issues. We are seeing that commonly in children. Then post trauma, there can be other issues like visual motor integration issues, visual perception issues, the processing of speed, the visual processing speed, how quickly can a person perceive something. Then according to that, the visual memory also, how well can you remember whatever you have seen. So all these things are now being taken into consideration, although this is not the core part of ophthalmology or for that matter optometry. It is important to be aware of all this. Why? Because we feel that the binocular vision is just limited to having fusion and stereopsis, but it's not the same. There may be certain subtle changes in the brain which may lead to all these disorders, and it's important to be aware of all this. So how do we investigate the sensory problems? So we have tests which assess the presence of simultaneous perception, whether the retinal correspondence is normal or abnormal, where there is a suppression or not, whether the 2 images can be fused, and at the end of that, whether the stereopsis can be perceived or not. So before any test is undertaken, it is essential to assess the visual acuity, which has to be best corrected visual acuity after the appropriate refractive correction. Then you also need to check the fixation in the squinting eye, whether it's a eccentric or central, then also the type and the amount of deviation. So this type and the amount of deviation is a motor component of the examination, and I would be dealing with it later on. So for retinal correspondence, basically the tests are based on 2 basic principles. One is the assessment of relationship between the fovea of the fixing eye and the retina stimulating in the squinting eye. So there are various tests like Begolini's, red filters, and Aptophore test, Worth dot test, and other tests for the same. The other principle on which these tests are based on is the assessment of visual directions of each fovea individually. So in one you are testing the 2 eyes simultaneously, in other you are testing the each eye individually. So as we all know, there are various slides on Synaptophore. This we all are aware is a SMP slide, which one has a solid object and the other one is a hollow object. Depending on the size of the object and the size, its substance at the nodal point, we can have foveal perception sites, parafoveal perception slides, paramacular perception slides, and peripheral perception slides, depending on the size and the degree its substance on the nodal point. Then these are the fusion slides, where you have two similar slides which are absolutely similar with each other, except for the some differences which are there. So as you can see in this particular slide, in one slide the butterfly is missing, while in the other slide the tail is missing. So when a person sees this slide, he can fuse it as a complete picture in form of a cat with both butterfly and the tail. So these are fusion slides. Then the next are the, I'm sorry, I did not mention this. There are stereoscopic slides also available in the Synaptophore, which are there and which help us to assess the stereopsis qualitatively. It does not quantify the stereopsis per se, but you can still assess the stereopsis qualitatively on Synaptophore. Then you have Bergolini striated glasses, which are the just micro cylinders which are perpendicular to each other. And these glasses are non-refractive. They do not have any power. And this is how you interpret them. So if you have a cross response in absence of squint, then you know it is a NRC. But if you have the cross response in presence of squint, then you know that you have an harmonious ARC. Similarly, if there is a central scotoma here, then you know that there is a foveal suppression. And absence of one of the line, whether it's is 35 degrees or 145 degrees, whichever, will tell you that which eye has the suppression. Similarly, on the same principle, you have Wirth 4-dot test, where you have two green dots and one red dot and one white dot, and it can be done for both near and distance. If patient sees all four dots in absence of any manifest squint, then the patient has NRC, while the presence of all four dots in presence of a manifest squints will tell you an abnormal retinal correspondence, which is harmonious. The patient may see, then there is a possibility that patient may see 5 dots. In that case, you know that the patient is perceiving diplopia. If patient sees only 3 green dots, then it's a suppression of the right eye. If patient sees only 2 red dots, then it's a suppression of left eye. The other test which is commonly, not so commonly done, but is possible, is red filter test, where red and white lights are used, and patient is asked to to fixate as a small light source. If there is a crossing over of the red and white light, then you know that there is a presence of exotropia. If it is uncrossed, then there is a presence of esotropia. If there is a pinkish light, which is kind of a mixture of red and white light, then it tells you that there is normal retinal correspondence. But if this pinkish light is seen in presence of manifest squint, then that is a sign of abnormal retinal correspondence. If only single light is seen, that means that there is a suppression. Similarly, we do this Herring-Bilchowski after image test, which is one of the most dissociating tests in orthoptics, and it is done with the help of battery-powered camera flash, which is used to produce a vertical image in one eye and an horizontal image in other eye. The center of the flash is covered with the black occluder, which protects the fovea. So this is how one can get response. If the cross response is seen, it means that there is NRC irrespective of the type of the squint, whether it's ESO or EXO or ortho. So a cross response is suggestive of NRC. An asymmetrical cause, as you can see here and here, is suggestive of ARC. So if it is uncrossed, it is ESO. If it is crossed, it is EXO. It is as simple as that. If one of the line, whether the vertical or horizontal, is missing, then that tells you that there is suppression in one eye. This is just to show that how you can measure the angle of anomaly if it is there in cases of abnormal retinal correspondence. So if your subjective and objective angles are equal, which you can measure on Synaptophore, or you can measure it with the help of prism bar cover test also. If they are equal, then you know that you are dealing with normal retinal correspondence. If your subjective angle is less than the objective angle, then it is I'm sorry, it is a sign of abnormal retinal correspondence, and the difference between the two is known as angle of anomaly. So the other test, which is not frequently used or probably kind of not seen nowadays, is a foviofoveal test of Cooper's, which is again used to check the retinal correspondence, and it determines whether the two fovea have common or different visual directions. At the same time, it also permits the quantitative analysis of the angle of anomaly, as you can do it on synaptophore also. So in this case, the patient will fixate with the normal eye on the Medoc scale, and the observer would observe in the other eye, will observe with the visuoscope in the other eye, where the patient is asked to look at the asterisk and the point that is corresponding on the Medoc scale, which the patient is seeing with the other eye, can be corroborated with the amount of the eccentric fixation. Similarly, a 4-prism base out test is a very quick and sensitive screening test to assess whether there is a bifoveal fusion or there is suppression of one of the fovea. It is based on the principle that the prism will suddenly displace the image and that the eye will have to move to refixate at the fovea. So as in this case, when you put the prism on the normal eye, there is shifting of the image and the normal eye will shift towards the image to maintain the image on the fovea. At the same time, the other eye will also shift. So if this eye will adduct, this eye will also abduct due to Hering's law. But I'm sorry. But if you have the normal, if you have the foveal fixation in the other eye also, then this eye will quickly shift, it will have a macrosaccade to refixate the image on the fovea. And once the prism is removed, the normal eye will come back again to take the fixation. At the same time, there will be a movement in the other eye, which will again be on the reverse direction to correct the to put the image back again on the fovea, right? So this is a very sensitive test to assess a very small amount of suppression in cases of, specifically in cases of microtropias. You can also assess the depth of scotoma by using graded density filter bar of Begolinis, and you can also chart the extent of scotoma by using prisms as well as synaptophore. Now, the third and the highest order of binocular vision is stereopsis, which is kind of a seeing object in third dimension, or in simplest words is a depth perception. The physiological basis of the stereopsis is that the two eyes see slightly different images with each eye, but are able to fuse them and perceive them if they lie within the Panam's area of single binocular vision. So that is the basis of the stereopsis. So if we have various tests for stereopsis like TNO test, Titmus test, Randott test, Frisby-Davis test for near, while for distance we have Frisby-Davis distance test and distance Randott test. Each of these tests are based on different principles, but the basic principle remains that the dissociation of two eyes, either with the help of Polaroid glasses or with the help of colored glasses. However, Frisby-Davis distance as well as Frisby-Davis near test are the only two tests that those are based on the real depth perception, where you have to move figures and the patient actually can perceive the depth that which of the figure is popping out. So that was about the sensory status. Now we also need to examine the motor status, which should be routinely done as a part of workup of binocular single vision. So you need to look for head postures, any facial asymmetry. Then you need to check for both ductions as well as versions. At the same time, also check for vergence, which is very, very important, especially in cases of cortical visual impairments, where you just don't have these problems. You may have higher visual functions problem. So you have to check for vergence also. Then measurement of deviation, which can be done with the help of prism bar or with the help of synaptophore. Then you can do diplopia charting. You must do, in fact, if you have a case of paralytic squint, to know the which gaze has the maximum diplopia. Also Lee's charting. Then also don't forget to do, as I was trying to emphasize, this the version and accommodation with the help of RAF ruler or normal scale, whatever is available. So these are the normal fusion amplitudes, and any problem in any of these fusion can cause multiple problems, especially the accommodation problem and convergent insufficiency kind of problem, which are coming with the increased use of digital screen in kids. Then this is what I was talking about when I was talking about that the higher visual functions can get affected if are the part of binocular vision. These functions are the part of binocular vision, and they can get affected in various ways. If there is ischemia, cortical ischemia, or if there is trauma, or in children, particularly children who have attention deficit disorders, children who have cortical visual impairment disorders. So these are the common problems that are seen in those cases, and even if we may not be the first person to assess them, we should at least be aware of them, because we don't want to dismiss a child's complaint or a patient's complaint after saying that your vision is normal, your fusion is normal, so you're not dealing. So rather than kind of dismissing them, it's important to know that these kind of problem can also occur. So you have something like visual perception, which is the ability to interpret, understand, and define the incoming visual information. So even if the patient may be able to see something, he may not be able to interpret, comprehend, and understand that thing. So that problem can be there. We call it visual comprehension problem. Visual closure problem is something when as a normal person, when we see an object and a part of object is hidden, we can still figure out that this is particular letter or the particular object. But patients who have visual closure may not be able to perceive this as a complete image and will not be able to tell. So this is also one of the important problems. Then spatial orientation, it is the ability to recognize the person or people in relation to the position. So your orientation of space is what is dysfunction in this kind of problem. Then visual memory. So even if one sees, one can remember, yes, this is what we saw. But in patients of cortical problems like occipital cortex infarctions or any traumas, you may have a problem where patient is able to see but is not able to remember that stimulus. Then integration problems can also be there. There cannot be any quick communication between eye and hands. Hand-eye coordinations are impaired. Visual cognition problem is to use the visual problems, is to use the information to assess the problem and make decisions, or to plan our day-to-day activities in that way. So all these are the problems of higher visual functions, which we all need to be aware of. With that, I think these are the various problems, or these are the various complaints a child may come with when they have higher visual problems, like they are unable to complete a puzzle or unable to do dot to dot. So we all are seeing that in our education system now. The system is focused rather than rote learning. The kids are now encouraged to do all this to understand how their visual cognition is developing. So these are the common complaints parents can come up with, that that they don't understand the concept of in, out, under, over, above, and all those. There's a problem in differentiating B, D, Q, and P, or reversing numbers or letters while writing, losing places on pages while reading or writing, remember the difference between left and right, forgetting where to start reading, sequence remembering, and all these problems can be their common complaints of a child. So if you have a child who can come with this kind of problem, just let's not dismiss the child. Let's try to understand his problem and deal with them accordingly. I think that would be from my side. These are the other kind of problem, incomplete drawn pencils or stencils and other stuff. These are day-to-day problems one can have. Thank you.
Thank you so much, ma'am, for such an informative and comprehensive talk. We'll have the Q&A round in the panel discussion. Now we are moving on to the next talk. It's with a great pleasure to address Dr. Pradeep Sharma, our ex-professor and head section of pediatric ophthalmology, strabismus, and neuro-ophthalmology and oculoplasty in Dr. RP Center, AIIMS, New Delhi. He has reviewed various awards and honors for his excellent contribution in this field. He has over 175 scientific articles in national and international journals or books, and more than 200 scientific presentations to his credit. He is a passionate teacher and excels in teaching and mentoring us. Over to you, sir.
Thank you, Darshana. It's a pleasure to be joining you. It's been very nice to see the organization. I was seeing the promo and I was really impressed by the promo that you have created in the short span of time. You have done a wonderful job, and I wish you all the luck for the success of this year's venture too. So all the best to you. So today I'll be talking about innovations in amblyopia treatment, the binocular approach. As we know, and carrying forward from Dr. Swati's thing, we have to be concerned about binocular vision and stereopsis, and that is the new goal post for all of us, whether we are ophthalmologists or optometrists or with the parents of the child. The goal is to get back the binocular vision and stereopsis. We are not just treating sight or strabismus, but we are restoring binocular vision and stereopsis. As Dr. Swati has already mentioned, that we have two eyes. In the lower animals, they give us a wide binocular field, but for the higher animals, it is giving us better stereopsis. And that is happening in the cortex. The right eye and the left eye inputs are coming together, and in the layer 4C, above that, they become binocular. And that is how the two sides come together. It's like, to give a social analogy, two strangers come together, let's say, and they would be developing a normal harmonious marriage, so to say, if they develop a good 6x6 vision and with good binocularity and stereopsis. But if they have each one dominate and live for their own careers, they may be living separately or divorced situation, just like two couple in a family, which is very dominant. It would be a situation like 6-6 vision in each eye, but nothing common between the two, and so no binocularity. On the other hand, there may be a couple which is one-sided, and it's one the couple is doing very good, the other one is totally annihilated. So that would be like amblyopia. What is amblyopia basically? Amblyopia is a developmental anomaly of vision. We do not get born with 6x6 vision. We develop it gradually in the first 9 months of our life, and then a little more gradually up to 6 years of life. So to say in a simple language, I would say vision is a language. And like all the other languages, we learn the languages best in our first 5 years of formative life, that is in childhood. If we were born in China, we would have learned Chinese very easily. But if you are transported now to China, you would have a tough time. You can still learn Chinese at any age. So same way, vision can be improved at any age, but it will be best done in the first 5 years of our life. How do we assess the vision in these children? We had seen that a child who's an infant is somewhere around 6/24 vision on the Teller Acuity cards. And if he has a cataract or a squint or a refractive error, the vision deteriorates very drastically if it's a unilateral thing. So nowadays we know the amblyopia may be segregated into 3 types. The one which is having the stimulus deprivation, the D-amblyopia, the one which is having to do with the strabismus, that is the S-amblyopia, and the refractive errors which cause amblyopia are the R-amblyopia. We have now also developing automated application using the gaze tracking and deep convoluted neural networks, which we had presented in American Academy of Ophthalmology at Chicago in 2018, using the laptop to assess the visual acuity in children. This is how it works. I won't go into the details of it, but basically coming back, the stereopsis is a function that both the eyes are giving us a vision which is binocular. Now, Dr. Swati had already mentioned the various tests, and I would not go into them. Just to say that there is a very simple bedside test which I would like to talk about. That is the modified Lang's 2-pencil test. Now, this is something which a child can even do it at any age, maybe just 2+, 3+. Here you have to just play with the child, and if he can do this touching of the 2 tips, it is only possible when both the eyes are functional together. If there is a strabismus, high refractive error, or cause of poor vision or amblyopia, this will not be functional. So this is something which we can do. A tale of 2 children. If a child has a refractive error, and if he is the one who is a little more aggressive kind, he may try to use his accommodation and get an accommodative esotropia, and then finally land into an strabismic amblyopia. On the other hand, if he is the kind of lazy kind who would like to rather see the blurred vision, he may go into a bilateral isoametropic amblyopia. So both the two situations are possible. How do we treat them? And amblyopia, where are we at the present stage? Occlusion for the last over two centuries has been the mainstay of treatment. And the problems which have been are the compliance. Second is the regression of visual acuity after we stop occlusion. And of course, the stigmatization in the school age period. It has been potentiated by the use of active vision exercises. Other alternatives like penalization and pharmacological modulation, including levodopa or cetirizine, have been used, and we had published one paper on the levodopa use in 2004 in JPOS. The MOTA study by Stewart has shown that there is something known as a concept of occlusion hours. 120 occlusion hours is leading to about 1 logMAR improvement in visual acuity. So that is the thing about the thing. What are the changing times telling us? The mouses and have changed nowadays. We have the mouse which is digital, and we are making use of this digital technology to improve the amblyopia. There are 3 different kinds of intervention. One is the monoocular perceptual learning, in which you occlude one eye, and the eye which is open is given perceptual learning. This can be enhanced by the use of video game plays, the VGP, or there is another option in which dichoptic perceptual learning can be done with the help of the digital platform. Active vision exercises definitely help improve the amblyopia. So in conjunction with occlusion, one can use, and there are other special tests also which are there, which can be made use of this. We had done a study and shown that active vision exercises definitely improves or enhances the effect of occlusion. What about the binocular vision stimulation? This is actually a new paradigm which has come up in the last decade. And here we have seen that the binocular video games can be used to improve the visual acuity. The child will love. But one has to remember, we are moving from iPads to iPads in the technological sense. The improvement in binocular visual acuity was shown in our study that it is as good in cases of anisometropic amblyopias. Mind you, we are talking of anisometropic amblyopia in this study, and occlusion was as good as binocular video games. This article was presented at San Diego American Association Pediatric Ophthalmology and Strabismus conference in 2019. The stereopsis was better, and obviously because in occlusion we are working against the stereopsis, in this technology this is going to improve the stereopsis. Dichoptic customized action video games are also available for treating adult amblyopias, as some study has shown with Murthy's article in Vision Research. This is not something new. Remember, in older orthoptics also were doing anti-suppression using synoptophore or chiroscopes or stereoscopes and using stereograms. So this is not something new technology. We are just using the old wine in new bottles, and that is with the help of the technology that we're making use of the dichoptic video games, the VTS4 or the Oculus VR games. The VTS4, as some of you may be using in the setups, this is both having a diagnostic and therapeutic advantage, and you can give binocular vision exercises for amblyopia also. We have been working on Oculus-based vivid vision. You can see this is how the virtual reality can be used to give exercises. We can modify the stimulus to the weak and the strong eye to put them at par so that they can be matched. So the signal strength has been reduced for the strong eye. Until they come together. So we understand now that occlusion is definitely a mainstay, specifically if the disparity in the visual acuity of the two eyes is too much. Now, if the vision in one eye is 6/60 and the other eye is 6/6, obviously you cannot give them binocular dichoptic exercises because the disparity cannot be salvaged. It's like matching a car with one side having a tractor tire and the other side having a cycle tire. So you cannot probably ride that car. You need to come together. So maybe occlusion can be started with in the initial 1 or 2 months, get the visual acuity improved, and then we can switch on to the dichoptic games to improve upon further. Remember, whenever we are learning about amblyopia, we have been taught that in amblyopia therapy, the cause has to be first removed. Many people have asked me, sir, you do it for cataracts, you do it for refractive error, but we don't do it for squint. You are usually treating squint after the amblyopia therapy. This is not correct. In reality, the moment you give an occlusion patch, you are removing the squint. Practically, the amblyopic eye becomes straight unless there is something like a strabismus fixus or a restrictive squint, which case we would do a squint surgery first. But otherwise, occlusion itself corrects the squint momentarily for that period of occlusion. So we are again correcting the cause first. But when we are going to use the binocular therapy or binocular approach, we would have to be correcting the squint. So what I would suggest is do an occlusion, improve the visual acuity, and then whatever squint is left over, you would have to correct it before we can switch on to the binocular modes. And as we know that there are various types of strabismus that may be there, we need to align them in time so that we can give the binocular advantage to these children. Some of these squints may be just requiring glasses, like an accommodative esotropia, which may be bifocals at times, or those which have a non-accommodative squint, we may have to operate. And that is what we can do it for different types of children having different types of strabismus or squints, and align them to the binocular alignment so that we can then give them treatment. Similarly, near distance disparity can also be there, which we have to be careful about in squint surgery. But the important thing to remember for you is it has to be a timely realignment. Even not for adults too, any squint can be harming the binocular vision. It has been seen in this study that in even adults, if they have had a misalignment for more than a year, their binocular vision gets compromised. So we need to treat them in time. These complex strabismus also we can take care of and align the eyes before we can re-stimulate their binocular vision. So this is, and so is the case for nystagmus. So what we are saying is that any type of squint, if there is a misalignment, it can harm the binocular vision and cause amblyopia. We need to be having a squintellectual approach to correct this. So to cut short, I would say binocular approach with the help of dichoptics improves amblyopia and also the stereopsis. And remember, the bottom line is we are not just treating sight or strabismus, but we are restoring binocular vision and stereopsis. Our mission, as always I have been saying, it is spreading sight and happiness for kids the world across, maintaining the stereopsis and restoring the loss. And we can have a happier world with all these children realigned and restored stereopsis. That was also the topic of my NAP lecture in 2016 when I was invited by APOS in Vancouver. I talked about the pursuit of stereopsis, and I would like to end my talk with this. Thank you all. Thanks. Once again, the American Optometry, the AIMS Optometry Explorer, and wish you all. Thanks.
Thank you so much, sir. Thank you so much, sir, for this informative and very comprehensive talk. Our question and answer round will be in panel discussion. Now we will move on our next talk. Recent trends in convergence insufficiency management. I am glad to respectfully and cordially welcome Ms. Preeti Sharma. She is pediatric optometrist and specialized in pediatric optometry and neurooptometry. She has also presented her work in various international and national conferences, published articles in peer-reviewed journal. Over to you, ma'am.
Thank you so much. A very good morning to all of you. And first of all, I would like to thank Dr. Swati and Pradeep sir for such a wonderful and informative presentation. As sir and Dr. Swati already talked about the binocular vision, so now it would be easy for me to make the understand how the binocular vision is important, and it plays very important role in treating various conditions such as convergence insufficiency. So as we all know that the prevalence of convergence insufficiency is very higher, around 45% in population. So we will be discussing in my further slides some recent trends in convergence insufficiency treatment. So when it comes to identifying or diagnosing the patient of convergence insufficiency, the first things that comes to our mind is malingering. And why malingering? Because sometimes patient may complain of asthenopic symptoms, which is correlate with the uncorrected refractive error. So first of all, always we should correct the refractive correction before diagnosing anything. So, but there are several instances where research has supported the prevalence of Vergen's problem as an important area, which affects the working potential of individuals. So, if the goal is for two eyes to not only appear straight but work together for the best performance in school, work, driving, or sports, etc., then our role as an eye care professional or vision therapist become more important. So these are the some routine binocular vision problem in which convergence insufficiency is a most common cause for asthenopic symptoms. So so we will be discuss first of all definition of convergence insufficiency. What is convergence insufficiency actually? So convergence insufficiency is the inability to maintain binocular function while working at a near distance. So typically, one eye will turn outward when focusing on a word or object at a near, basically in intermittent exotropias. In process of this, patient may develop asthenopic symptoms like headache, eye ache, double vision, difficulty in concentration, etc. So there are some etiology behind this. So basically, primary or idiopathic, maybe wide IPD or inadequate functional development. So some precipitating factors like general disability, psychologically instability, overwork, or any worriness. And refractive error is very important area. So uncorrected myopia and hypermetropia should be corrected. So presbyopia is another factor, and muscle imbalance like exophoria or intermittent exotropias. So consecutive convergence insufficiency, like following recession of medial rectus or resection of lateral rectus. So these are the some convergence insufficiency clinical sign and symptoms in which there are some convergence insufficiency type of condition like exophoric or esophoric. So in like 80% of exophoric patient may complain of asthenopia due to their poor fusional vergence for near or distance. In or 3% of esophoric same. In such patient are mainly have vergence problems. So that is why they complain of asthenopia. In such patient, they'll have a low positive fusional vergence, low near point of convergence, low ACA ratio, and NRA will be low. So these are the common symptoms of convergence insufficiency like difficulty in concentrating, difficulty in reading, headache, tiredness, blurred vision, double vision, sleepiness, and etc. So if we refer to our clinical data of convergence insufficiency, pure CI is less seen, and maximum convergence insufficiency patient presented with other secondary cause of symptoms like convergence insufficiency with accommodative excess, convergence insufficiency with accommodative insufficiency. And convergence insufficiency is not always a primary factor which can cause the problem. There are other associated factors also which is supporting and causing the CI. So in our clinical data, headache was the main symptoms of convergence insufficiency. As we can see, there is a percentage of 50%. And during this pandemic period, everyone has to be on digital devices for long due to their work profile or school homework. And in this period, the accommodative anomaly also playing a role to have a convergence insufficiency, and patient may experience near blur or difficulty in focus changing from near to distance. So we can say that only convergence insufficiency is not causing the problem. There are also associated factors should be corrected to treat convergence insufficiency. So there are the treatment aim. So first will we eliminate any factor affecting clarity of stimulus, like any refractive correction. For myopias, we need to give full correction to compensate the condition by restoring a normal accommodative convergence relationship. Correction of low degree of astigmatism, particularly oblique type of astigmatism, which can also cause same symptoms like convergence insufficiency. Correction of low degree of hyperop, which does not necessarily make convergence more difficult, but it may have opposite effect by clearer stimulus and can result in improved convergence. And facilitating sensory fusion and maintaining binocular alignment, enhance fusion amplitude, reducing episode of intermittent exotropia. So there are the treatment of convergence insufficiency. These are the options. So optical correction. So correct optical correction or refractive error is very important, and it plays a key role in treating a convergence insufficiency. And vision therapy exercises in make sure the patient does office exercise or home-based exercises for convergence insufficiency. And when all exhaustive VT exercises fail to, so base in prism can be tried to relieve the symptoms. Relieving prism should be avoided in young patient because sometimes what happened, the patient should be dependent on the prism and they does not use their actual fusion potential. And surgical treatment also, so or associated with exophoria or intermittent XT for near, if it is more for near, like more than acceptable range to treat the to treat convergence insufficiency. So in such condition, we need to go for surgical option first. Then after that, if required, then we need to go for fusional exercises. So convergence insufficiency, also accommodative stimulus exercises, minimal plus power to achieve comfortable and clear vision is advised along with the VT exercises or prism therapy. So understanding of physiological diplopia is very important, and it is primary key to start fusional exercises. Once the patient is able to appreciate the patterns, maybe that could be with the help of Brock string or two pencil or barrel card in the free space. And once the diplopia elicited, Vergen's control activated and prism activated. So with the help of prism bar, aperture rule and synoptophore, etc., help to improve the fusional vergence. So therapy works by providing stimulus to teach brain to unify information from two eyes. So it is important to reach the correct diagnosis before starting any treatment, as orthoptic exercises cannot be used to treat all convergence anomalies. An example being secondary convergence insufficiency, where the underlying medical cause needs to be managed first. So all patients at baseline should have a refractive carried to ensure any refractive error is appropriately corrected before any orthoptic exercise are considered. So moving towards an example, an elderly patient, 26-year-old software engineer, came to our clinic with an intermittent exotropia of 40 prism diopter. His control was very good for near as well as for distance, and he was maintaining good fusional amplitude in free space. But he wanted to get rid of his squint, so we decided to surgery. And before surgery, we've planned a Fresnel prism to break the fusion completely. Because of many times, if the fusional amplitudes are good, chances of consecutive esotropias are increases. So after giving prism, as we can see in the picture, he was manifest exotropia of 60 prism diopter, and he can and be done the surgery on the same angle. But after the surgery, he was still 20 prism diopter of residual exotropia, which was manifesting due to his poor fusional amplitude. So that means it was a fusional amplitude or fusional vergence which was helping him to control the exotropia before the surgery. But due to prism, we relaxed fully and land up to convergence insufficiency type. So after that, we decided to start fusional exercises to improve the fusional versions at office. And after doing office-based therapies and along with home-based therapy, he was maintaining good fusional amplitude with NRC in free space. And after that, he was very happy. So according to the vision therapy clinic protocol of our institute, the subject requiring fusional versions therapy undergo a combination of office-based therapy and or home-based therapy. In office-based therapy, subjects does any 3, and in home-based therapy, any 2 exercises from the following list. So these are the potential cases for fusional exercise, like patient with convergence insufficiency, symptomatic heterophoria patients, intermittent exophoria patient. Like if eye turns part of the time and it's straight part of the time, then the possibility of vision therapy aligning the eyes without establishment surgery is about 80%. And the chances increases. If an eye was previously aligned with the surgery and then turn again, the chances are still good that vision therapy can help to realign the eyes. So these are the some fusional versions exercises like Brock string, prism bar, aperture rule, mirror stereogram, vectogram, synaptophore. Normally these exercises we does in our clinic, and if required we can give for a home-based therapy. So nowadays there are advocacy of computer-based versions therapy for convergence insufficiency, like amblyopia. There are various software there are various software program developed and marketed by different resources. But the limitation of these exercises, they are mainly designed for newer and they require supporting angular classes or colorful classes. So and which may many times break the fusion, and it may not help in basically in intermittent exotropia or large angle of exophorias. And to treat the convergence insufficiency patient should maintain good fusional versions in free space. So this is the basically limitation of this computer based exercises. So these are the some home-based therapies which normally we give to the patient for convergence insufficiency or any other problem, like lifesaver card, stereogram card, free space fusion card, Brock string, flipper, near activity book, and HTS. So concluding, a combination of prism and fusional vergence exercises can restore fusion control in patients who have experienced a long-term disruption of fusion. So we as a clinician or vision therapist should understand the role and limitation of the available treatment option, and we should plan the exercise or we should plan the fusional exercise according to that. So for binocular vision therapy exercise provides a role of establishing normal sensory processing. Thank you.
Thank you, ma'am, for this wonderful talk. Our question answer round will be in panel discussion. Now we will move on our next talk, vision therapy. I am extremely honored to have this opportunity to address Optom Sonia Sharma, currently serving as Senior Consultant Optometrist at Dishti The Vision Care Foundation, Care, Faridabad, India. She had developed online game with IIT Delhi to treat amblyopia and worked on various projects at Dr. Swaroff Charity Eye Hospitals. She had published various research papers and participated in many paper presentations. She has received gold medal for her excellent academics in 2005 at Sahai Hospitals and Research Center, Jaipur. Over to you, ma'am.
Good morning, everybody. Today in this symposium, I'm going to present on Introduction to Vision Therapy. I'll be covering what is vision therapy, who all
Sonia,
are benefited from it.
Sonia ma'am, your PPT is not visible.
Sorry, now is it visible now?
No, ma'am, you do one thing. Please stop share, open your PPT, and then share it again.
Okay. Is it visible now?
Yes,
Is
Sonia.
it visible now?
Yeah, it's visible.
Okay. So I will be covering what is vision therapy, who all are benefit from it, presenting complaints and the involved program. So what is normal vision? We all feel normal vision means 20 by 20. So is it only the 20/20 vision which we should say normal? We all are concerned not only with how small a person can see, but how he or she performs in everyday life, like for driving or writing, reading, studying on computer or reading a newspaper. So these are also important. So it's not just only the 20/20 vision which is important, but other visual skills also plays a very important role. So let's understand how the visual demand changed with the time. We all have healthy eyes. Our vision and the way it was 10,000 years ago. What did we need our vision for 10,000 years ago? To hunt for food in order to survive and to keep away from being hunted. So in both the condition, distance or intermediate vision was required at that particular time. But 500 years ago, printing press invention happened. Then 150 years ago, factories and crafts has come. And with the advent of computer, our linear visual need increased. So nowadays, most of the children use gadgets for fun. We use smartphone for taking pictures, chats, communication, etc., where near vision plays an important role. So we can say today's world is digital world, especially after COVID-19, gadgets use has been increased and we are totally dependent on it in so many ways where the children need to do online studies, conferences, bill payments, chats, and so on. So our near vision demand has increased. And because of these near activities, like our visual system, although like was designed by evolution to be more for distance viewing than near, and we all know like near vision tasks make up most of our work nowadays. So earlier we used to play more outdoor games, but now nowadays children prefer more indoor games than outdoor. In fact, parents also look happy and feel safe if kids are in home than outside due to environmental factor and from safety point of view also. So, and due to more near visual demand, visual stress has increased, and evidence suggests that near vision takes our stress tasks are stressful to the individuals. Like there can be synopic symptoms like headaches, straining in the eyes, blur vision. So these there can be these visual issues. Is it easy to read this? So it can happen in case of poor visual function. So you are able to read sometimes, but it blurs sometimes. So there'll be an intermittent blur. So there can be a binocular vision problems. So what are we looking for? We are looking for accommodative dysfunctions, oculomotor dysfunctions, binocular vision problems, amblyopia, and strabismus. So let's understand more about vision. These are the part of vision, like binocular vision, mobility, reading, visual memories. Where you can see binocular vision means where we are looking for version, stereopsis, fusion, depth perception. And for the mobility, we look for acuity, contrast, visual field, space perception. For visual memory, you need to look for faces, objects, environmental things, and for reading, acuity, contrast, visual field, and eye movement. So these are the components of the vision where you need to look for these things. It's not only the visual acuity, like 20/20, which you are looking for. So this is an optometric model in pyramid shape where the ocular health, refractive disorders, and acuity assessment are the basic thing and needs to examine in detail first. Once we assess the basic things, then needs to look for higher visual skills, which are like change of the focus, alignment of the eye, binocular vision, ocular motility, and then at the top of it, there is the higher visual function, which is visual processing, as Dr. Swati already has been discussed about the visual spatial skills, visual motor skills. So basically, we need to look for the ocular health, and then if that is fine, then we need to look for the other visual skills also. So this is a randomized clinical trial of treatments for convergence insufficiency in children. It was a prospective, masked, placebo-controlled, multi-center clinical trial in which 208 subjects between the age of 9 to 18 years were randomly assigned to home-based therapies, pencil push-up therapies, home-based pencil push-ups with computer vision therapy, office-based vision therapy or orthoptics, and placebo office-based therapy. So in this, the patients were tested at the eligibility examination and by masked examiner after 4, 8, and 12 weeks of treatment had been completed during the 12 weeks treatment phase. And the long-term follow-up was assessed at 6 and 12 months after the completion of the active therapy. And here you can see the vision therapy was more effective than the other therapies. Like you can see here the CI symptoms reduced from 32 to 9.5, NPC improved from 13 to 4.5, and positive fusional versions improved from 12 to 31. So it is proven like vision therapy is effective. So who benefits from the vision therapy? The children or patients who are having learning related vision problems, who are having poor binocular coordination, strabismus and amblyopia, stress induced visual difficulties, visual rehabilitation for special population, who had some issues like brain injury, ischemic or hypoxia, sports vision improvement. I'm not going into the depth because it is already covered in the earlier topics. So what is involved in a vision therapy program? A progressive program of vision exercises or procedures, and it generally conducted in office in session of 30 minutes, and then sometimes supplemented with procedures that done at home between home-based and office-based. So vision therapy program can be used as a anti-suppression therapy, convergence exercises, accommodative therapies, oculomotor therapies, and amblyopia therapies. So for suppression, we can use to eliminate this. We can use gyroscope, vectogram, red-green strip, synaptophore. So basically, gyroscope, it's an apparatus that is used to present an image to one eye, which must be drawn in a space visible only to the other eye. So it improves binocular vision, as Dr. Pradeep Sharma already discussed. Vectogram, in this, this is the vectogram. In this, basically, these are the polarized slides. Allow a child to work with a variety of targets to frame. So by using this, we can improve central or peripheral vision, flat fusion or stereopsis fusion, and convergent or divergent squint eye position. Red-green strips, these are the bar readers. These are the tools used as an anti-suppression therapy, where the bar are either polarized or composed of anaglyptic or red and green material. And the reader is used with different filters and help to partially dissociate the image. And the patient may or may not to see words when the filters are applied. So, and may be instructed to blink rapidly or to shake the bars when suppression occurs. So you can use it in that way. and the synaptophore for everybody knows. So there is a auto flashing light which we use to improve the anti-suppression. So for the convergence, so for the convergence, we can use Bloch string, prisms, aperture ruler, mirror stereogram, synaptophore, and the vectogram. Where the Bloch string, I feel, is very useful tool, and it's very simple to use it. Once the patient understands how to use it, how to bring the eye in or out, this is the wonderful tool. And because in the free space, the subject learn how to control the both eyes together. So the Bloch string exercise, it's to train for accurate binocular fixation basically. It improves the vergence, whether it is convergence or divergence, and it helps in developing the ability to voluntarily converge. Also stimulates the accommodation also, because you need to keep the target clear also, and it is based on the physiological diplopia. Where the prism therapy, it is for improving the fusional vergence, fusional control, and you can use it in either way, for as a base in or base out, as per the condition. So in convergence, the base will be out. Aperture ruler, this is the aperture ruler. The aperture ruler trainer is an instrument used to train vergence. The instrument can be used with either one or two apertures, and image is placed some distance behind the aperture. The single aperture is used to encourage the convergence. And here you can see this is the single aperture. Here you can use the double aperture also, but for convergence, there will be a single aperture. And this technique has the advantage of dissociating vergence or eye movements and the accommodation. So synaptophore, for that we use the convergence slides, fusion slides. We put those slides, and for example, a tree and a kid. So we instruct the patient like to look at the distance through the tubes. So on synaptophore, and we ask the patient to appreciate one tree with two kids. If there are two trees, that means the fusion has break. Or if there is a one kid with one tree, that means there is a suppression. So that will be the trigger, that because sometimes in intermittent squints, it happens sometimes eye goes into the suppression rather than appreciating the double vision. So you can tell to patient, if there is a one image disappear, that means the one eye is only being used. So you can instruct in that way. Then for accommodation therapy, we can use lens flippers, loose lenses, hard chart. So flipper, basically you are checking the amplitude of the accommodation and the facility. Speed of the accommodative response, you can check under the binocular condition, because if there is a blur, the speed of the reading will be very slow. If it is clear, the speed will be very good. So especially for the kids where they are not able to tell you what is blur, what is clear, you can judge them by assessing the speed of the reading. And the loose lenses also can be used. The objective of this therapy is to restore normal accommodative amplitude and the facility. It requires age-appropriate reading material and loose lenses. So once you're done at a distance of 40 centimeter, and you can do at a near or closer to that also, it based on the principle of negative relative accommodation and positive relative accommodation. Then the hard chart, this is a hard chart. Basically, we are using it to improve the ability to sustain the accommodative state of the eye, and increases the speed of the accommodative response under uniocular or binocular condition. It tells you about the status of the eye, and it is based on the accommodative facility. So then for ocular motor therapies, you can use pegboard rotator. This is the pegboard rotator, Marson's ball, and flashlight tag you can use. So basically the pegboard rotator, it's the rotator. The rotator is a tracking instrument used to develop eye tracking skills, eye-hand coordination, and visualization ability. The child is asked to place golf trees in a rotating pegboard, and as the child's skills improve, the speed at which the pegboard is rotating is gradually increased. So it also helps in improving the eye-hand coordination. So basically we use this for special population also, as well as to improve the saccades pursuits in case of squint. So swinging ball training, it is to improve an eye tracking, that is saccadic and pursuits eye movement. It helps to improve accommodative facility, and it enhances the eye-hand coordination and perceptual skills for directionality. So in different directions, you can use it and you can move it. So then the flashlight tag, the objective of this therapy is to improve the speed and the accuracy of pursuits, eye movements, and the patient follows your flashlights, keeping his superimposed on you. So if you don't have any instrument, you can just use a torch for this and you can improve these skills. So the home therapy is again a very important thing, because once you improve the versions or the visual skills or skills pursuits, it's not sufficient. It's just like a patching, like once you improve the vision, but you need to gradually taper off. In the same way, once you go for office-based therapy, once the condition improve, you need to keep them on home therapies to maintain the condition. But yes, initially every day you need to instruct them to do the exercises, but later on they can gradually taper off it. But as a maintenance therapy, they might need to do once in a week, even after that also, just to maintain. So for the home-based therapy, you can use stereogram cards like CAT card, everybody knows. But nowadays, free space fusion cards available, because it tells to pay, because it is more helpful than the CAT card, because there are two colors, circles, red and green. So whenever patient appreciate only one color circles, that indicates one eye only being used. So this is how patient itself can understand whether the patient is using both eyes together or not. Then the Brock string, flippers, and anti-separation exercise kit, like we have designed earlier when I was in Shroff Hospital. We have designed this kit where they have divided into stage 1 and stage 2 on the basis of child's age. You can go for this thing, and they need to do the tracing, tracking, coloring, so that can be used with the help of red filter. They need to do this. So for home therapies, this can be given. Then for amblyopia therapy and separation, you can go for fill in the O games, rice and tweezers, and computer-based program, as Dr. Pradeep Sharma already explained. So because it is always, it will be always benefited if we go for active therapy along with the passive therapy. That is more helpful. So advances in the occupational therapy and physical therapy, there is a tremendous advances have been made in the last 40 years. And the healthcare professionals understand that the human brain is capable of tremendous change, recovery, and development. So patients who suffer strokes or other traumatic injuries to the brain and nervous system receive extensive rehabilitation. Dr. Swati already has been, explained very nicely, and teach them how to coordinate movement, breathe, speak, and or walk. So you can train them in that way. So the vision is such a vital sense, and there is a one research which has been proven, like whatever we learn, almost 80% we learn by seeing through the eyes. So that's why it is very important. Vision should be good. Our skills should be very good. And it's always better to improve it as soon as possible. As sir already told, it's always better to improve the vision first, and then we go for, and the vision should be corrected, and then we go for these therapies. So why don't more eye care professionals take advantage of the marvelous team that have been and are being made in the other rehabilitative therapies? So it's always better to go towards this also and learn about the vision therapies things also. So vision is a complex process. An individual with good visual acuity and healthy eyes can still have a vision problems. So let's understand that, because it's not necessary that usually if we don't have knowledge about it, we feel child is malingering, but they can be visual skills issues, although the visual acuity is 6/6. So optometric therapy is an effective treatment of many vision problems. The evaluation of individuals with learning difficulties, that is attention, ADHD, dyslexia, should include thorough optometric analysis as part of the multidisciplinary approach. The American Association continues to support quality optometric care, education, and research in the area of vision therapy. So if we go towards the research, as earlier everybody thinks vision therapy is nothing, it doesn't improve, it's a fancy thing, but now the scenario has changed. And the extensive research related to strabismus and amblyopia, accommodative and non-strabismic binocular dysfunction, vision development, and the learning related vision problems is conducted at the schools and colleges of optometry and other clinical and research settings. These scientific studies support the effectiveness and the value of optometric vision therapy in the treatment of vision dysfunction. So these are the scientific support for different the more visual skills can be improved by simple exercise. Thank you.
Thank you so much, ma'am, for such an amazing talk. We'll have the panel discussion soon. Now I'm glad to introduce Optum Prem Kumar Singh, Senior Faculty of Binocular Vision and HOD in Optometry Vision Sciences at Dr. Shroff Charity Eye Institute. He has been awarded the Best Optometrist Award in 2014. He has various research publications on his name and have made number of clinical and research presentations in various conferences. He is a navigator of the flagship of knowledge for all of us. Over to you, sir.
Hi, good morning, everybody. Is my slide visible?
Yes, sir.
Okay, and thank you, OSA and entire team for organizing this wonderful conference. I know it's not easy to organize online sessions like this, but yes, it has been going till now very smoothly. We have heard all the speakers, and I'm sure broadly we are very clear about this, that we as the humans are really fortunate to have the luxury of binocular vision, and we really enjoy it in performing our daily routine. But things start changing when suddenly somebody loses that luxury or a binocularity because of various reasons. And if they start seeing double, then it becomes even more challenging for them. So let's think about some people like him, like her. She was a girl of 22, has been having the good binocular vision, but because of her intermittent exotropia, she used to have that intermittent double vision, as well as whenever she was trying to click her pictures, particularly the selfies, she used to have a squint in the eye. So for somebody at the age of 22, a female, how important the good pictures are going to be. Or an elderly of around 45, where we all understand that whole family actually is dependent on an individual like him, and how the family may get affected if he loses his binocularity or he starts seeing double following an accident, or if because of any other reason he sees double. He was a child, around 10, he got operated for the squint. Things were planned for his good binocularity at that age, as well as the cosmetic reasons. But somehow he'll end up with the consecutive things, and then he had a diplopia. So we planned something good for him, but somehow he was not happy. Although cosmetically he was very close to having no deviation residual, but he was still seeing double. He was seeing double, and that was troubling him a lot. An engineer by profession, he was basically we used to work on astronauts, where they have to match the Terrans, for which the 3D vision is very important, which he realized later on when he joined that profession, that he was not able to does his best because of that inability to have a good stereopsis. He was a professionally teacher and lost his binocularity following an nerve palsy. There was a small amount of deviation, and last 4 years, in fact, 3 years, he was just getting suffered because of that. He stopped going for the movies and enjoying outside with the families because he was not finding comfortable. In fact, his teaching profession was getting affected. So not only these, there are many more patients that we all encounter in our clinics very routinely. Because of various reasons, they lose that luxury of binocularity they have been enjoying. And somehow, we as the clinicians, they look for a solution from us. And that's how they see that how they can be helped in their problem. Think about more cases like we plan a surgery, somebody for a cataract. And on day one, we found that patient is 6'6" when we could see the vision of the operated eye. And the time he says that he's seeing double, see all the good things or the success of the surgery that the surgeon has done goes away, because patient is seeing clear with that eye, but he's seeing double. Or similar things happen when somebody gets operated for the squint. So the squint is not there. It's more as a much close to the ortho condition, but patient starts complaining about double. Things happen even with the glaucoma implants, sterilism surgeries, or scleral buckling. So many of the time we encounter these kind of patients who come and complain about the double vision problems. It could be various patients because of the nerve palsies, particularly at the elderly age, when when they are diabetic, and if it is not under control, or they are hypertensive when it's not under control. So we see a lot of patients who come and face these kind of problems or complain about these issues. And we can't plan surgery for them immediately. So we have to give them a sufficient time so that the nerve can regain its function back. And for that duration, the life almost stops for them. They're not able to work comfortably for their routine, what they have been doing, or they have to, as we have been following, they have to keep the one eye closed to have their work going on. So in these kind of cases, you can have a lot of, like the prisms could be a good tool where you can really help them in continuing with their routine things, making their other systemic issues which have been responsible for this, the acute onset of diplopias in the control, and they can regain their function. And if they're of course not able to do it over the period, then they can be planned for the surgery to make the eye straight. Similar things happen with different kind of nerve palsies. Even if you're operating them, many times you're not able to get the complete result. And there, in these cases, you can take help of the prisms, and along with that, the Vergence exercises, which help us in gradually tapering of the prisms. So road accidents are very common, where patients land up with these kind of either abnormal head posture, where they try to compensate the diplopias, or they may just complain about double and not having any abnormal head postures. So as you can see, this was a paper where they have studied the patients after the cataract surgery who had the diplopia complaint. And so measured with the patient in their paper, they could help with the help of the Fresnel prisms. So measured if them were the decompensated fovea, like patient had the fovea earlier, and after the cataract surgery, the fusion broke and completely, and they started seeing double because the deviation was manifesting. There could be extraocular muscles limitations or paresis, which are the reason for that, or many times it could be even the refractive errors and some systemic diseases that causes the problems. So most of the patient, as you can see here, up to 64%, they found that they could be improved with the help of prisms. But along with the prism, what we have experienced in our setup is, if you're keeping them on the Vergence exercises, that is much easy for you to gradually wean off the prisms, so the patient can be completely off most of the time. Even with they can manage the work very well without the help of any prisms even. I still remember even Dr. Kalam, after his cataract surgery, had the same issue. Maybe he had a 4 years earlier, and that got decompensated to tropia, and he used to have the double vision problem after that. So he was given Fresnel prisms. He was given prisms in the glasses, I remember, and somehow he could not. He was not very good compliant for the Vergence exercises at this stage. So he had to be dependent on those prisms whenever he was doing it. Mostly he was squinting for near. So he was given that help with the help of prisms where he could manage his routine work. And we all know how fond he was of reading and writing. So diplopia after SFIL, he was the one who had the similar issue, and then he was given. He was not prescribed the prisms. He was just kept on vision therapy with the help of prisms in the trial set, in the trial frame, where he was made to learn to. The visual axis were aligned with the help of prisms, and then he was encouraged to for his fusional vergence, and then he could gradually learn to control it, and then he could maintain that control, could see the thing single. I know he is a doctor from Muradabad. He got operated for a retina, and then he has a, because in usually these kind of cases, if the retinal issues has been there for a prolonged period, so they start dissociating with that eye. And after the surgery, when the vision becomes really good in that eye, and then they start appreciating that double vision problem. Because of that decompensated thing over the period, the eye deviates, may not be complaining the double vision till they are operated because of poor vision in that eye. And once the vision improves, then they start complaining. And they are the very good potential cases where you can really help them align the visual axis, bring the eyes closer, the alignment closer with the help of prisms, and then switch them to the Vergence exercise along with the prisms, and gradually you can plan to taper off the your prism power, and then they are able to manage the things very well without any help of the prisms. So after, as I said, after strabismus surgery, a lot of patients actually end up with the diplopias, or they may be even many times some small residuals, where you can again take help of prisms, gradually keep down Vergence exercise, then help them making the eye straight. In fact, Preeti mentioned in one of the very similar case in her presentation, where patient, particularly the elderly age, when they come for a squint surgeries, then we have to really see whether patient may not end up with the diplopias after the squint surgery. So prism adaptation test becomes an important tool in those cases, because if somebody has a large intermittent exotropia, as you can see here, and he's controlling so well even for this amount of deviation, so he has the tendency of controlling the squint over the period. And if you operate him for this angle, there are more chances that, because he continues to use that fusional Vergence which he has been using over the period, and then he may end up with the consecutive esotropia, although you plan your surgery as per the measurement you have been doing. So to relax the fusion completely, that becomes important to like overcome that part of consecutive. And then if required, you can take the help of Vergence exercise and letting them again learn to have that good fusion potential. So we all understand that compensatory and therapeutic prisms, what actually they are. You can you can rename them like diagnostic prism, relieving prism, or compensatory prism. They are quite similar. They have a same base, which help you reducing the work, where you are just relieving the symptoms or helping the patient in aligning the two eyes with the help of the prism, where the visual axis goes to the fovea of both the eyes. So patient is not putting on any efforts in this, where the therapeutic is the opposite to that, where you are making the patient's eye to work actually more, where they try to encourage the fusion. You are trying to move the eye away from the fusion, and patient tries to maintain that fusion. So gradually, by increasing the prism power or other therapies, you does that thing where patient is putting on you're making the patient to work more to learn to control it, and that helps in strengthening that particular fusional control. Patient even many times with the nystagmus or DRS, they have the limitations, and they have bad abnormal head postures, and because of whatever reasons, if the surgery is not being planned, so you can help those kind of patients with the help of prisms. Again, you can take help of yoke prisms in these kind of patients. So apart from diplopias, I take help of prisms in even many times in homonymous hemianopias, because even these are the patients whose life actually gets troubled. He was the one I remember still. At this age particularly, he said, I was most scared of walking on the street, because if he got stuck, any of the females, then it was an embarrassing situation, as well as people many times taken in a very different way. So he was really scared of moving independently alone when he had this issue of homonymous hemianopia. So to him, I gave the yoke prism, where the base is towards the blind area, where it helps you in shifting the image. As you can see here, this is what you expect. And suppose he has a homonymous hemianopia on right side, so you miss out the right side image. You're not able to see that. And then with the help of prism, base towards the blind area, and you can help them appreciate some part of the objects which are coming to the right side, and then you actually help them in becoming a little more independent, which accidentally, because of whatever reasons, they have lost that field of any particular side. So broadly, we see this is the functional vision, binocular vision is the goal of we as a clinicians for these kind of patients. And even the prism adaptation study research group has demonstrated that best results were seen in their patient when they had a PAT before the surgery, and where they advocated that the orthoptic exercises where you try to encourage the fusional vergence, even the pre-surgery or after the surgery, the results were much better in those cases. Here I have a small video of how we dispense the frontal prisms. I think this will be important for the students to understand. So you make your measurements in the clinic for the amount of strabismus, and you can make a trial for prisms with the help of trial prism, how he feels about it before you're cutting the or dispensing the final frenal power, or even prescribing the glasses. You can give them a walk-in trial to give them a better feel about that. And then if frenel is required, you can shape it to the size or shape of the spectacle lens by keeping it over it after deciding the power of prism, the base of the prism up, down, or you can even test compounding prism if the horizontal and vertical both the deviations are there. So in the single prism, you can give both the effects, horizontal as well as vertical. This is how you place it, and then you take help of the water to finally adhere it. So with the preferably running tap water so that there are no air bubbles into it, you can just stick it to that. It's more like a capillary effect which keeps the prism adhered. And then you gently press it so that all air bubbles comes out. And with the help of a soft tissue, you can just wipe up all the water droplets from this. So combined prism and vision therapy and surgical approach, if you see, can help in getting the results much better for all strabismic patients. So where the sensitive fusion ability at the time of surgery are critical for the good post-surgical results. Sensitive fusion basically acts as a glue which prevents the post-surgical drifts. Many times, because it was an XT for a longer duration, and we planned the surgery, eye has been made straight, and still you may have the exodrift in many times these patients. So even if you have a straight eye after the surgery, the vergence exercises help in like a glue in maintaining the result that we have got. And similarly, pre-surgical, as I said, where you can take help of prisms and divergence exercises to develop that fusion, where the post-surgical results becomes even like more appreciating. So a combination of prism and orthoptic treatment can restore fusion in patient who has experienced a long-term disruption of fusion. And for we as a clinicians, becomes even more important to understand the roles and limitations available for the treatment options. So surgery reduces the magnitude of deviation, or you can take help of prisms, where you align the two visual axes, make a bifocal fixation, and then gradually you put them on vergence therapies, where you can aim off for reducing your prism power and completely weaning off the prism power. Thank you. Thank you. So we'd like to have any questions from the audience now.
Thank you so much, sir, for this wonderful talk. Now we'll have the panel discussion round. We have few questions from the audience. The first one is, usually we use foveal slides. So when do we use macular and paramacular slides? The first query is, usually we are using the foveal slides. When do we use the macular and paramacular slides?
Okay, this question is for me.
Yes, sir.
Okay. See, depending upon the visual acuity of the patient, if patient has a good visual acuity, maybe 6/9 or better, you can choose the smaller targets, which is the foveal slides. But if the visual acuity is less, like maybe around between 660 to 618, you can take help of macular slides or if it is even less than that, you can take help of paramacular slides.
Thank you, sir. The next question we have is, if an old person loses one eye in an accident, will the stereopsis still persist since it is a binocular function?
Yeah, so if they see, as I said, the patient has been enjoying that binocularity and accidentally he loses that. So he may have a exo, ESO, vertical, whatever deviations. So he may not have a good stereopsis at that time because he's seeing double. But when you take a help of your prisms, where you are able to align the two visual axes and there's no diplopia, under that condition, yes, patient will again have a good stereopsis. And since he had that good stereopsis earlier, so he can have the same now. And he will be a good candidate to regain that function until unless there is not a limitation. And if over the period the limitation of the adduction movement starts improving, then simply with the help of your Vergennes exercise along with the prisms, you can help the patient in regaining his binocular functions and keeping the eye straight again.
Thank you so much, sir. The next question we have is for Optometrity. How does the latest technology is playing a role in convergence insufficiency management? Ma'am, please explain.
So the latest technology can be already we are giving office-based exercises like Synaptophore and a vectogram. These are the exercises which we are doing earlier. Nowadays, some people have advocated computer-based exercises. So this can help in managing the convergence insufficiency, because it has a Vergennes exercises. Simply they have given a divergence and convergence exercises. So these exercises can help in managing these kind of things. So these are the latest trend which nowadays everybody is following.
Yeah, to add on what Preeti has said, actually, you can even nowadays, as Dr. Pradeep also talked about that briefly, that virtual reality games are developed by the people, where these children have that feel of free space, and through that VR, that they see the side. Even the broadcasting is possible now with the help of virtual reality setup. Of course, things are a little expensive, so everybody is not able to afford it that easily. But yes, maybe over the period, even the cost can come down, and they could be more interesting for these kind of patients to practice and like keep them more engaged. Because usually these therapies start, these children start finding them boring gradually when we ask them to do that regularly. So a combination of, as Sonia was saying earlier, of broadcasting, which is one of the best one, where it can be done in free space, but having a broadcasting along with these BR kind of things where children find them more attractive and interesting for them, I think you can keep them more engaged and get better results.
Thank you so much, sir. Thank you so much, ma'am. The next question we have is for Optom Sonia, ma'am. What is near triad synkinetic reflex and why is it so important?
So as the name suggests, it's an association of accommodation, convergence, and the pupillary reaction which occurs when the person look at a near distance. So it itself is a complex system basically while we look at a near distance, because the moment we look at near distance and these three things are coming together. So what happens if one of them get effects, then other things will also get effects. So basically it's a combination, and everything should be in a good state. So if the accommodation get affected, then the convergence will get affected, or if the convergence gets affected, then the accommodation gets affected. So that's why it's a complicated thing, and in near reflex it happens. So that's why whenever we plan some therapies, why it is important, because when we plan some therapies related to convergence insufficiency or divergence issues or accommodative issues, so it doesn't come independently, it doesn't come just only as a convergence therapy, because the incidence of CI alone, CI or accommodative dysfunction is less. So it always comes with the association of other issues. Maybe the primary factor can be convergence dysfunction or accommodative dysfunction, but simultaneously other condition also comes with that. So we need to work for both the things. That's why these tools, have different importance. Like as I have discussed about the Brock strings, where we don't only control the versions, we also improve the accommodative status also. So even for the other instruments also, like it's not only the versions parts which you are taking care for, you are taking care for the accommodative status also. So that's why it is important to maintain accommodation as well as the convergence at variable distances.
Thank you so much, ma'am. The next question we have is again for Optum Prem sir. So please explain briefly how to prescribe horizontal and vertical prism over the same eye with one prism.
Yeah, I think this was expected question for me. If I've not got this question, I would have thought why people are not asking me this question. All of my students have this problem, like this query in their mind. How do you go for that? Okay. So when there's a combination of prism required, like you have a larger horizontal deviation and then some part of vertical deviation as well, then you can have a combination of it. And the method which I follow more preferably is the mathematical equation, which we all have read in our school time, that Pythagoras theorem, we call it, where there's a diagonal. So we call it hypotenuse, where there's a diagonal, square of diagonal is equal to square root of perpendicular plus base. Or you can even have a vector method through graphical representations, where you choose a scale, suppose you want 8 prism diopters, okay? So it's a simple way. You make a line, take the help of a scale, like for each centimeter, if you choose as a 1 diopter, so you make 8 marks, so 8 diopters, and then you have a vertical line as like a graph paper we used to do. Suppose you need 6 vertical prism, so you make 6 marks of 1 centimeter each, and then you make a square of it, and then you make a diagonal. So diagonal will give you resultant of vertical as well as the horizontal, and that distance you can measure with the help of a scale. And then tan theta you can calculate, or you can just measure that angle of diagonal with the base with the help of a d that we have, and that will give you the resultant power of your prism, which becomes your approximate power. So that you choose in the trial frame with the help of trial prism, and then you give a walk-in trial to the patient, and that help you in deciding the final power of the prisms. So either you can have graphical help, or you can even calculate mathematically, whatever you find more convenient for you.
Thank you so much, sir. The next question again for you is, how does the vergence exercises help with prisms in patients with diplopia?
Right. So as I said, so prism is helping you in aligning the 2 visual axes. So you need to have a foveal fixation. Suppose patient has exo deviation or EZO, or there's a vertical deviation. So you compensate that deviation with the help of relieving prism. Okay, so the visual axis gets aligned, and now you start working on encouraging the fusional vergence. So you go for routine vergence exercises. So where patient learns to control that much better now. Once the control improves, gradually you can start reducing the prism powers, weaning off the prism powers, and then which will help you in completely coming off the prisms, and patient will be able to control the deviation without the any prisms requirement, and he'll not be seeing double if he's seeing double. But the most challenging thing comes when patient is operated for a squint and he had a suppression and lands up with the esotropia, or residual exos are there. So since they have a suppression, there's no diplopia complaint. Even if you give a prism, it will not help them. There are in fact more chances if you give them prisms that the deviation may further increase, because patient is not preferring to use that type. But if we're seeing double, you take help of prisms, make them see single, align the visual axis, and you work on the fusional vergence exercises. That will help you like greatly. You'll find that patient is able to learn to control that, and then they can maintain that control without the help of prisms.
Thank you so much, sir. So this was the last query. Now we are concluding the session. Thank you all the speakers for such a comprehensive talk and bringing the whole orthoptics and vision therapy in a nutshell to this session. Thank you so much, sir. Thank you so much, ma'am.
Thank you so much. Thank you, everyone. Thank you, OSA. I know we all enjoy every year to coming back to OSA whenever we get the invitation. Thank you.
Thank you, sir.
Thank you, everyone.
So, skipping on to the next talk, we are grateful to have Optom Vibha Singh working as an assistant professor in Jamia Hamdard, New Delhi. She is pursuing PhD from National Institute of Medical Sciences, Jaipur. She has published many papers in national and international journals and has presented many papers in conferences. She is serving as the director of Sakshamta Foundation, providing eye care services to extreme rural areas. She is the one who installs a passion of learning within us. We welcome you, ma'am. Over to you.
Hello, good morning. Good morning, everyone. Hope my slides are visible.
Yes, ma'am. Your slides are completely visible.
Okay. So first of all, I would like to extend my thanks to OSA team, brilliant team for having me here. It's a great pleasure to talk on this interesting topic, modern visual science, visual psychophysics and its application. I'll try my best to do justice with your time. Thank you, team. So today here I'll be talking about modern visual science, visual psychophysics, and its application. It's an interesting topic, and as we all know, vision is one of the most active areas in biomedical research and visual psychophysical techniques. Techniques are a foundational methodology for the research enterprise, and visual psychophysics, which studies the relationship between the physical world and human behavior, is a classical field of study that has widespread applications in modern vision science. So, if I'll talk about this and talk about the introduction of the vision psychophysics, so from the earliest dawn of history, man must have wondered how the outside world become apparent to him through his eyes. He must have pondered what forces cause an observing eye to see an object. Why did the world look light or dark, or nature have such bright colors? Even though early man could not understand the concept of physics of light or that perception occurred in the brain, he must have understood that the eye was the organ of vision, and without eyes we were blind. So, thus the earliest concern of the Asian civilization of India, Babylon, China, and Egypt were certainly to attempt to restore or improve eyesight when it was failing even without understanding much else. So it was the Greek philosopher Hippocrates, Aristotle, and Plato who provided the first known theories concerning the eyes, its function, anatomy, and treatment. Originally, the Aristotelian idea was that rays of light emanated from the eyes for the illumination the world around. So when it was dark, the air became murky, so the rays could not penetrate. But a candle could burn off the opacity in the air, allowing sight to penetrate. And also, strangely enough, the Homeric Greeks lacked a word for blue, and Homer described the sea as a wine colored. Eventually, the Aristotle proposed that visual sensation passed from the eye to the heart, and which was at that time considered the center of sensation and psychic function. The brain was thought to be a cooling device, and this cardiocentric nature of sensation continued in the Middle Ages. So from this picture explains the Aristotelian concept of five senses projecting to the heart either directly or via the sensus communis in the anterior part of the head. And again, after that, Galen, a Greek scientist working within the Roman Empire, showed that the pressing on the heart in human subjects did not lead to loss of consciousness or loss of sensation, but severing the spinal cord in animals abolished sensory responses after brain stimulation. According to earliest ideas, the eye had a central crystalline lens which had a photoreceptor role. Furthermore, the belief was that optic nerve was hollow, and that a mysterious visual spirit existed in front of the lens. So this was all the earliest introduction from where the people started talking about the visual psychophysics. So visual psychophysics also is applies when we talk about the measurement of light. So light can be measured and is specified in two units. We all know that is radiometric units and photometric units. We consider light to be a form of visible electromagnetic radiation, and it's a part of the electromagnetic radiation spectrum between the wavelengths of 380 nanometer blue light, what we call, and 750 nanometer that we call red light. And electromagnetic radiation is emitted from a source in small packets of energy called quanta or photons. So this picture is very much familiar to all of us. In vacuum, as we talk or as we say, photon travels at a velocity of 3 into 10 to the power 8 meter per second, and the velocity frequency cycles vibration or per second of the photon, and the wavelength is related by the equation C is equal to NL, where C is the velocity of light in a vacuum, and N is the frequency in hertz, and L is the wavelength. So next figure will explain something more, and which is important to note that frequency is inversely proportional to the wavelength as the velocity of light is fixed. So this is the relationship between the wavelength frequency and the velocity. So this fundamental equation is important in relating energy and wavelength of light, because energy and wavelength are inversely proportional. This implies that short wavelength photons have higher energy. Furthermore, it is important to bear in mind that it is only photon energy and frequency which are conserved when light passes from one medium to another. So another important term is power. Power is defined as the rate of work done, that is the amount of work or energy output over a given time. And the watt is a unit for power. 1 watt is equivalent to 1 joule per second. So, and there the another terms comes radiometry. There are two parallel sets of units for measuring light. One is based on the psychophysical impact of the light on a human observer, the other on detection by physical radiometric devices. The two units are interconvertible, but sometimes only with difficulty. Measurement of light energy from a source can be specified in radiometric units. Radiometric units specify the amount of radiant energy present in light. All light measurement is derived from a radiant flux. Subsequently, radiometric units are defined with respect to direction and surface, and all photometric units are derived from radiometric units using the photopic luminous efficiency functions or the scotopic luminance efficiency function. If I'll talk about the photometry is the measurement of photometry is the measurement and specification of light relating to its effect on vision. The eye can be regarded as a radiant energy detector with a selective spectral response. And in a well-lit environment, it is maximally sensitive to light of about 555 nanometer and relatively insensitive to far red and blue light. The function describing the response of the human eye to different wavelengths is known as the relative luminance efficiency function. Measurement of light from a source can be specified in photometric units. Photometric units take into account both the quantity of radiant energy and sensitivity of the eye to the wavelengths of the radiation. If a patient's visual field are commonly examined in clinical practice, which we all do, the luminance of the background of the visual field analyzer are as follows. In Humphrey automated visual field analyzer, the figure is 10 CD per meter square. Goldman visual field analyzer have some other figure, and in the med amount automated visual field analyzer we have different figures, and from these values retinal illuminance can be calculated. In this figure, we can see the luminance of visual field analysis places the patient just above the mesopic light levels. So this is the photometric quantities illustrating flux, intensity, illuminance, and luminance. So the visual field is sensitive over a wide range of luminance. When a patient are asked to read the chart to measure their visual acuity as their visual system is functioning in the low photopic range, a convenient measure of retinal luminance is based on the unit of the Trolent. 1 Trolent TD of retinal luminance is produced by an extended source of 1 CD per meter square seen through a pupil of 1 millimeter square. About the luminance and illuminance calculation, when light falls on the surface, the luminance from this surface is proportional to its reflectance and the angle of incidence. About the psychophysical measurements, so the psychophysical methods and procedures are useful in determining the threshold and including visual field analysis. For a perfect observer, threshold is the point where the stimulus can just be detected or where you just cannot detect the stimulus. Humans are not perfect observers, and often threshold are defined in probabilistic terms. So for example, half the points presented would be detected and half would not. So under certain psychophysical techniques, threshold can be considered the point where 50% of the stimuli are detected. Threshold variability most likely depends on neural noise, and one aspect of visual psychophysics deals with noise and is termed signal detection theory, and this will not be covered here for the moment. So measurement of visual response can be achieved through several methods, and the methods include method of adjustment, methods of limits, staircase, and method of constant stimuli. So the method of adjustment involves asking the subject to either increase the stimulus intensity from non-seeing until the stimulus can just be seen, or to decrease the stimulus intensity until the stimulus has just disappeared. And the methods of limits involves presenting a stimulus well above threshold and decreasing the stimulus intensity small steps until the subject cannot detect the stimulus. This is called descending limits. So a variation of the methods of limits is the staircase method, which involves both the ascending and descending limits in a trial. Stimulus intensity is progressively increased until the subject reports seeing the stimulus. So at this point, the intensity value is recorded and the stimulus intensity is then progressively reduced until the subject reports not seeing the stimulus. So the method of constant stimuli involves the repeated presentation of a number of stimuli, and the threshold value of 50% lies somewhere within this range. And other psychophysical techniques are used to estimate the threshold and determine stimuli intensities to be used for presentation. So these stimuli are randomly presented. The percentage of detection is determined as a function of stimulus intensity. And next is adaptive psychophysical methods. So adaptive methods involve presenting signals based on the performance of the subject's previous response, while in forced choice tracking, a forced choice procedure is used. When subjects correctly respond 3 times, stimulus, interest, an incorrect response will result in a one-step increase in stimulus intensity. Intensity is increased by 1 step. So thank you for as of now. Thank you so much.
Thank you so much, ma'am, for such an amazing and wonderful talk about your this. So we currently do not have any query regarding it. So we'll be concluding the session here. Thank you so much, ma'am, once again. Team OSA is so grateful to you for
Thank
joining
you
us.
so much. Thank you so much. Thank you for giving us the opportunity. It's a wonderful to be in contact with you all, and you are doing a great job. It's every time it feels very pleasure to join with OSA.
We are highly obliged, ma'am. Thank you so much. So we'll be right back after a short break and beginning with a new session, Breaking In. Stay tuned with us. Thank you.
Hi, good morning, Rajesh.
Good afternoon, Rajesh sir. Good afternoon, Rajesh sir.
Hello, good afternoon. Hello, hello. Hello, good
Hello.
morning, sir. Good morning.
Good afternoon, sir.
Hi, Ashish.
Good afternoon. Hello. Good, the gang is ready.
Mr. Pawan, please unmute yourself. You are mute.
Yeah, unmuted.
Sir, my voice is audible, sir?
Yeah.
Yes.
Okay. Welcome back after break. I'm Bharti Dagar, Joint Secretary Optometry Student Association, AIMS New Delhi. Welcomes you in AIMS Optometry Explorer 2021 with the theme Embodying Technology and Cultural Excellence in Eye Care. Let's move ahead to our next session, Break In. I welcome Mr. Ashish Pandey, sir, for the topic Silver Lining and MNCs. He has done his master in optometry. He is an area manager in V Square Meditech Private Limited. We welcome you, sir. Over to you, sir.
Thank you so much. And very good afternoon to all of you. I'm
Good
sharing
afternoon,
my
sir.
screen now. Is it visible?
Yes, sir.
Yes, sir. Yes, sir. It is visible, sir.
Okay, so very good afternoon. Today I'm going to talk about rosy outlook in MNCs. So how we develop rosy outlook? So have a look. Having a positive attitude which brings about happiness, hope, and satisfaction. In the workplace, it improves productivity and leads to occupational success. And when complex task seems to weigh you down, a positive attitude helps you push on. So we have to always have a positive attitude. So when we start our career, we always have some images whom we consider them as an ideal for us. Just because of that, we think MNCs are right place to work, where we can enjoy great lifestyle. So first, whatever we have in our mind regarding MNCs, so is it true or not? So let's find out what the culture in MNCs. Corporate culture can provide a major boost to business performance. The culture reinforces a vision and value that instill pride in employees, tap into their motivation and inspire their behavior. It can raise customer and employee satisfaction. So what makes a company a multinational company? MNCs, basically, if we are talking about MNCs has facilities and other assets at least in another country than its home country. So like Zeiss is working in India, which is based in Germany. So similarly, what are the features of multinational corporation? Huge assets and turnover, international operation through a network of branches, unity of control, mighty economic power. They are very strong economic power, advanced and sophisticated technology, professional management, high-end products, aggressive advertising and marketing. We all are optometrists. Few MNCs which are in Indian ophthalmology. As all we know, Star Surgical, which provides ICL, Bosch and Lomb, there are some contact lenses, IOLs, and LASIK machines. Alcon, a big name in ophthalmology, Hoya, Johnson & Johnson, Zeiss, Essilor, and etc. So if we come to the SWOT analysis, what is the SWOT analysis? SWOT analysis is strength, weakness, opportunity, and threats. So if we talk on the strengths, they are process oriented, diversity. They believe each individual is unique, and of course, a better packages. And what are the weakness? So just educational expertise is not enough to justify your job. There is always a politics because there is number of employees who want to grow faster than you. So there always a politics and exploitation of people in a systemic manner. And what are the opportunity? We talk opportunity, there always a growth. And since we are an optometrist, we have technical knowledge about ophthalmology, we are the first choice. Training and learning. And what are the threats? Mergers and acquisition. Mergers and acquisition is the biggest threat. We can lose our job on that, and they can transfer to our other division and other city. These are the threats. And selfish promotion of alien culture. Since we are outsider and they follow their own culture. So this is the biggest threat of the job for the opportunities in the corporate sector. There are a lot of job opportunities for corporate sectors for optometrists. You can go to professional services. You can be application specialist where you can demonstrate the equipment, and of course sales. You can go to the sales. And what requires job technically very hardworking.
आवाज नहीं आ रही नेटवर्क इशू है.
Hello. Hello. Am I audible to you?
Yeah, Ashish, you are audible, but little bit your voice is breaking in between.
Okay.
Ashish, you are not audible.
Wait a minute,
Yeah,
sir.
yeah.
Let me fix it. So now now am I audible, sir?
Yeah, you are audible.
So we were talking about the SWOT analysis, if I'm not wrong. So what are the strengths in MNCs? They are process oriented, diversity. They understand each individual is unique, and of course there is a better packages. And what are the weakness? Only educational expertise is not enough to justify your job. There is always politics because there is number of employees who want to grow faster than you. So there is always a politics, exploitation of people in a systemic manner. And what are the opportunities? Of course, there is a lot of growth. And since we are an optometrist and we have technical knowledge about ophthalmology, we have the first well, training and learning. Mergers and acquisition. Mergers and acquisition is a threat to us because we can lose your or transfer to another region or transfer to another city. These are the again selfish function of alien culture. We follow their culture. Like someone is Japanese or culture. So these are the threats. So what are the job opportunities?
Thank you, sir. Thank you, sir. Your wonderful talk. Now, I would like to invite Dr. Optom Ajit Bhadwa, sir. He is a renowned optometrist in India. He graduated from the AIMS, New Delhi. He is the founder and director of the Opticube in the Vasant Vihar. He is the past president of the Asia Pacific Council of the Optometric India Optometric Federation. Also, the board member of the World Council of the Optometry, World Optometry Foundation, and Optometric Council of the India. He was also the clinical director of the Special Olympic Opening Eye Program in India. He will share the knowledge on the laying the foundation, sir. Over to you, Mike, sir.
Hi, good morning, everyone. I would like to compliment and say thank you to Optometry Student Association of AIMS. It's always a privilege to come back and speak to you students about our life experiences and about what we feel about the profession of optometry. And let me tell you, I think yours is the only, maybe the only Optometry Student Association which conduct an activity or a conference of this size and this magnitude, which makes me very proud of the institutions which we all come from. Giving you the background, I graduated in 1979, and this is making 42 years of my journey into this profession. Most of you were not born when I was already an optometrist. So I'll give you exactly how I feel about the profession. Like most of you, I came into this profession by default, not by an option, but just because I had no option. All of us want to become medical doctors when we take a medical subject, and same was with me. And fortunately or unfortunately, I happened to be an optometrist by default. And this is true for about 98% of the students who join optometry in India. Only 2% of us who have the optical background or somebody known optometrist in the family, they join by choice. Like my son who had a talk yesterday on telemedicine, he joined by choice and I joined by default. I did not belong to a family of opticians. But since I took on the profession, I realized that something which I did not make a choice happened to be a gold mine profession, a profession which gave me recognitions, a profession which gave me a choice to practice, profession which made me known, popular, a profession which made me an entrepreneur in time to come. And I realized that a profession which I did not want it to be in my initial 1 or 2 years happened to give me a kind of lifestyle which I never could have attained, even if I would have dreamt, or even if I ever got the medical doctorate degree of maybe ophthalmology or maybe any subject of medicine. To be frank, I'm not just boasting about it, but it happened to me just by default, or maybe I was just privileged. I was blessed to become an optometrist. And it happened at the same institutions at AIMS. And let me tell you, AIMS was the first institution in the country that came out with a degree course in optometry, which all of you call it B-Optom. It happened to be another degree at those times. Since I qualified from the right first day, I've never been unemployed. The day I got my result, I had a job in my hand. And the kind of job satisfactions I got right from the first day made me so much like the profession. And I call it not a profession, I call it a dynamic profession. Why I call it a dynamic? Because it has been ever evolving, ever changing, always gave me something new every few years. My subject is about the foundation. The foundation which this institution gave me was basic knowledge. But let me tell all the students here that the knowledge what you are gaining today is just your foundation, which, just like a foundation in a building you never see, but it gives you the strength. Likewise, this institution, whatever you are learning will give you the strength, but you may or may not use it in later part of your life. When I was a student, I learned about contact lenses, hard contact lenses, or maybe semi-soft contact lenses, which I rarely used when I graduated. When I came out in the industry, in the field to practice, I found myself in practicing on soft contact lenses, which I did not touch or did not see in my school days. And that has been ever evolving in the sense that by the time you will be learning soft contact lenses, you will find yourself that when you come out to practice, you'll be doing something entirely different what you are learning today. So you are in a profession which will be changing every time. And that's the beauty of the profession, that it evolves around an interesting subject of, why it's called optometry is coming from a Greek word. And if you divide it into two, it's called optos, means defect of eye and vision. And metry means measurement. So we are talking about our foundation lies around refractive error and low vision. That's our foundation. And this foundation gives you multiple and ample opportunities to evolve. Just like in a building, you make a foundation and you build anything over it. Likewise, we all have been building multiple dynamics, multiple career out of optometry. Multiple choices what we made came out of this profession. And I'll tell you, like somebody was talking about the professional services or maybe the silver lining in multinational companies. This may be just maybe 1 or 2% of you will go into that line of profession. 60% of you will be working with optical outlets. Maybe they're retail chains, 20% of them will be retail chains, and 40% of those will be standalone opticians. So 60% of you will be spending your life with, and this is not just a statistics in India, I'm talking about a global statistics, that 60% of optometrists, even in US, they work in either in retail or independent opticians or basically sell practices. Only 10% of you will be able to establish your own entrepreneur skills, be able to establish your own practices. And I was one of those 10% who started my own practice. And 10% of you will go into those private, setting up your own optometry clinics. And those clinics will again revolve around adopting new dimensions of optometry, or what you call the specialization of optometry, which I'll be talking to you shortly. So 60% there, 10% of you will become entrepreneurs, and 2% of you will go in professional management, and about 7 or 8% of you may go in teaching and research. And the rest, about 12, 13% of you will work with ophthalmologists. And let me tell you, the way the dynamics are changing, when I joined the profession, the optical jobs, working with opticians used to be the most highly paid profession or most highly paid optometrist job among optometrists. But today the position is slightly changed. Today you will get better remuneration if you work with ophthalmologist. You will be better. Private ophthalmology will give you better job. I'm talking of lucrative, I'm talking of salary point of view. You will get better career option from salary point of view working with ophthalmology clinics in the private sector. You will have many other options, like you may go 1 or 2% of you, as I mentioned, will work with MNC. They may give you better job, but better salaries, etc. But again, the professional satisfactions they all depends on exactly whether you want to take on that kind of profession or not. Once you have graduated, sometimes since we join the profession by default, not by choice, I would suggest that if you open your net, optometry has again 3 dimensions. One is building aspect, other is analysis or thinking, and third is giving. So there's a career test which you can take on the internet. You open Google and write the career test, and there are certain questionnaires you can write, and you can decide your aptitude exactly. What exactly is your aptitude in optometry profession? Where exactly you want to go? Whether you want to go in a profession of maybe instrumentation, maybe setting up a workshop, setting up a retail outlet, or maybe you want to go in a profession of teaching or profession of public health. So that may give you certain idea exactly what is your personal liking in optometry profession. So all the students who are student at this point of time and are thinking what to do should go for that career test and see exactly what is their strength, where exactly they want to be in near future. As I mentioned, most of us will be doing refractions, contact lenses, but how many of us have succeeded doing adopting different specialities? I would like to share is this, that contact lenses, which we just see as lathe cut or spin cast lenses or Bausch & Lomb contact lenses, Johnson & Johnson contact lenses, many of you will go on specializing in creating a niche market of specialty contact lenses. A simple refraction may not be sufficient enough to give you good bread and butter or maybe good kind of earning nowadays because of so much of competition from different sectors. But setting up a clinic of myopia control, adopting different lenses which are used for myopia control, contact lenses, spectacle lenses, certain medications which you may or may use in near future of time. So those are the areas like myopia control, specialty contact lenses, setting up of a dry eye practice. One of our former, our senior, Mr. Vipin Bakshi, has set up a great dry eye clinic. I would suggest that some of you should visit his clinic and see how a dry eye can give you a supplement income in your practice. Then areas like sports vision. No one in India no optometrist in India has set up any sports vision clinic, where optometrists in other countries, they work with sports teams, they work with athletes to improve their, clinic, to improve their reflexes, to improve their skills while performing. Like IPL team should have an optometrist with every team. Likewise, all tennis players I know, they have their own optometrist where they go for improving their visual reflexes. So setting up sports vision is a big area of a big specialty of optometry. And I would see that someone in near future takes on, and we are working with some sports clinics and see that we can bring in certain things for sports, because I come from, basically, I have more inclination for sports and love to do that in near future of time. Then low vision, which has been, which we are taught, which is ever evolving. You have seen one of your senior, Ms. Monica Chaudhary, has written a book on low vision. I mean, not just practicing low vision, many of you do practice low vision, but I would suggest that adopt new areas of specialties of low vision. Then areas like digital eye clinics, which you may not have seen here. Here we just see somebody, we talk about, patient comes to us, he has a computer vision syndrome or, some digital eye strain. But if you go to US, you will find optometrists setting up digital eye clinics. They have optical shops and they specialize in patients, treating patients who have digital eye strain. The number of patients who are coming up with digital eye strain are about 40 to 50% additions of patients which are having increased strain because of our increased demand on internet, on increased near vision work because of computers and mobiles. So that's an emerging area for optometry. Then you always work with the ophthalmologist. You can work with them in LASIK for the LASIK co-management. You can work with them for cataract co-management. And this is something with most of you who are working with any ophthalmologist, they are doing it already. So areas of optometry are ever changing, ever evolving. And what is fascinating to me, for me, is this, that in last 2 years, 3 new areas which are emerging, which I think all of you should be talking about. Number one area which is emerging in optometry is artificial intelligence and eye. Most of you, if you see your vision therapy, I'm sure that Prem talked about vision therapy, but vision therapy clinics today are again basically have changed from your synaptophore exercises to exercises which are based on artificial reality and virtual reality. So your dimension of treatment will not be just on your clinics, but it will be through your internet, through your telemedicine. My son talked to you about how you can conduct, just like the way we have changed the way we conduct conferences. There was a time when I had to go to AIIMS to to rush down and park my car and rush there to deliver a lecture. And today I'm casually delivering from my home. And that's the way the optometric practice is evolving. We don't need to set up multiple instruments. We don't need to invest so much in a clinics. By taking a small software, just question of 20,000-30,000, you can start a practice. Immediately you have a strong foundation, which you have learned in your institution. So areas like telemedicine, artificial intelligence, and third emerging area, which you will see, which we are not talking at this point of time, is 3D printing. All artificial eyes, your shell, what we use for prosthetics, you can do. You don't need to go anywhere. You can make them in your home without going anywhere. Your spectacle frames, you can start making your own frames without going to without ordering it from any of the lab or any of the distributor. You can start making your own frame. So the 3D printing is going to change your profession. 3D printing is going to change the way the medical practice is going on, not only in ophthalmology, but all over. You must have read this news of artificial cornea being created or transplanted using 3D technology, where the artificial corneas are now being printed by using 3D printers. So we need to. The good thing about the profession is this, that you are being challenged every day. Every day you are being challenged to learn something new. And I'm happy that, we are all ready to adopt those changes in our profession. And I talked to you when I delivered this lecture last year that I'll be able to make a frame, and not only one, but I have made multiple frames in the last 3 months, for not only for my patients, but for my friends and for my known people. And I'm still experimenting how we can build our own expertise to give best quality of frames to our patients. So I don't know how much time I have, but according to the salary, of what I would suggest is this, that a salary structure, if you look at, I tried to gather certain statistics from some optometry associations. And what I came to understand is just that about 50,000 what we get for a graduate. But let me tell you, for you in US today, it is among the first 5 top professions of healthcare. The optometrist salary is averaging about $120,000. They make about $55 to $60 per hour. And the things are changing in India too. Today, with telemedicine coming up, you will be seeing that many patients will love to do this eye exams at home, face-to-face on your computers too. So we'll be able to spend more time with the patients using the technology. So salary structure, if you look at among healthcare, it is quite good structure compared to the dentist salary we have in India at this point of time. I was just reading about dentist issues, and I realized that the Dental Council, they said that there's no dental college going to start for next 3 years. They banned all that because there's so much of oversupply of dentists in India that the salary of a first dentist is about 10,000, 11,000 rupees, which is shocking. Same thing is happening to the nursing. So we are privileged to be in a profession, though we did not make a choice. But I urge that any of you, all of you who have joined it, you are in the right place and happen to be in the right time, because we struggled for about 50, 60 years getting legislation. And by the time you pass out, legislation will be ready for you. It means you will get additional protection whereby not unauthorized people will be able to encroach in your field. And like your field is protected, I would suggest that you keep other fields safe as well, because you will have sufficient areas of healthcare to practice. So I would like to thank all of you to invite me to this institution's this conference every year, and I'll be glad to answer if any of you have any query questions at the end of the session. Thank you once again.
Initial expectations. Would it be turned?
Thank you, sir. Thank you so much for sharing this wonderful experience with us.
Now moving ahead, welcoming our next speaker, Optom Rajesh Vadhwa sir, who holds bachelor's and master's in optometry and has been honored with Lifetime Achievement Award being an educator and Fayekal Fellowship. Also awarded with Best Optometrist of the Year 1997 to 2019. He has credit of having introduced the prefix optom for optometrist, and he will cherish us with the topic exploring avenues for practice and business in ophthalmic dispensing for better revenue. Welcome you, sir. Over to you.
Thank you for the kind words, and I'll be sharing my screen. Okay, can you see my screen, please?
Yes, sir, you're audible and visible.
Okay, thank you. What I'm going to be talking today is retail for revenue in optometry practice. Ajit sir has very nicely put in the avenues where optometrist can go, and the corporate part has also been taken up. It will be easy for me to build on this. The question remains, do I have only a clinical setup where I do consultancies, or do I also keep a retail outlet? That's often been asked to me by various students and so we have two options. Ajit sir also talked about the lifestyle he got through optometry, and here we have two options. We have to choose one. You can see this is the room where any guest enters in the house, and on the left is the one which is in India for consultation only, and on the right is consultation plus dispensing set. What will be the lifestyle of this person? Selling consultancy versus selling product plus services, we see that this gentleman with the white shirt is the one with the money in pocket, and man in the black garment is taking away that money very smilingly. By not having our own dispensing unit, we are making others rich. And are we here to help others become millionaires, even if that opportunity was created by us? Prescription was given by optometrist and the money was earned by someone else. So let us see how this works further. Suppose we have consultation only. It's going to be great that it will be a cool, simple consultancy practice. Less paperwork and less compliance. So less maintenance issues also. But what is the price to be paid for this? Number one, optometrist's personal presence is required for every patient here. So every patient will need the presence of optometrist in case you wish to really go ahead with whatever comes up here in the clinic. Patient has to be seen by the optometrist. If optometrist is not in office, there is no earning. And in old age also, one keeps on working, and there is limited revenue per patient. You will be charging your consultancy fee, and that's the limit of what you will be taking. Other option. Now in this option, other option is within our expertise and service plus ophthalmic dispensing. Advantages are that there is unlimited revenue per patient. Every patient can just give you as much money as you can provide the product for. Our personal presence is not required for every patient interaction. And if Optom is not in office, some earnings will continue even in our absence. In old age, one can delegate more work to others. Two very important phrases used here, which we must re-emphasize. It is within our expertise to have a dispensing unit. And secondly, unlimited revenue per patient. These two factors must be encouraging enough. And what do we pay for that? Yes, we will be active all the while. We'll be running after deadlines. Spectacle is not ready. The lens has not come. This lens is not perfect, needs to be changed. Spectacle is loose, tight, has to be looked after. All those factors will come in. And more paperwork and compliance will be required. More maintenance issues will come up. But the reward is worthwhile. Now that AHP bill, as Ajit sir also mentioned, is almost there, and the scenario will change. Optometrists will be healthcare professionals, and the consultancy charges will become entitled to reimbursement in various offices. Charges for consultation will go up, and free eye exam with making of spectacles will be slowly gone. That will no more be there. After all, the clinic has its own expenses, and those will be met with by consultancy fee. But will that be enough for sustaining the practice? Let us look at a very hypothetical model of a very small practice, wherein we see what happens as we proceed with running a small clinical outlet. So we have here a small estimation, or optometrist has certain expenses, and these expenses are there to run the clinic. We have looked at monthly expenses. Taking example of a very small practice, we see that you pay either rent or the bank loan payment for real estate. We pay for electricity, we pay for staff, whether full-time, part-time, maintenance, insurance, licenses, accounts and compliance, stationery and consumer. All this put together, in other words, about 1.25 lakhs per month will be spent in just running a small practice. From here on, I will request you to do some mental mathematics along with me as I proceed. To earn this 1.25 lakhs per month, which will make us even, how much do we need to earn per day? Usually we say 30 days a month, but we work 26. So to simplify, let's say 30 days a month. So we need to be having consultancy income of about 4,200 rupees per day if we want to meet our expenses with no net earning. So this one phrase we keep here. If consultancy of rupees 4,200 per day is earned, we are at par with no net earning. So we put this up onto the next slide. There it goes. Now in calculations, we also want to earn at least 1 lakh a month, say. 1 lakh a month we want to earn over and above our expenses so that we can have a good lifestyle. What do we need for that? We need approximately 3,000 rupees a day extra. Now this 4,200 can be covered by seeing 9 patients if we charge 500 rupees as a fee. But that 3,000 extra will come from where? That means in order to earn 1 lakh extra, we need to see 6 patients more every day, which means total 15 patients per day we see who pay us, and then we will be earning that kind of money. But this is a very big challenge. Even in a very established practice, 15 patients per day is very big. Then where can the revenue come so that our balance sheet goes into green zone? So here we talk about how we go into the green zone now. For additional revenue, let us say a very hypothetical example, we sell a spectacle of 1,000 rupees with a gross profit of about 450 rupees, and for having a dispensary, you spend about 150 rupees per 1,000 of spectacles. Net, you earn about 300 out of the 1,000 spectacles. That means about 30%. Now for having 1 lakh income, we must have a sale of 10,000 per day so that we earn 3,000 per day. So progressive lenses can cost 3,000 plus, and premium frames can easily cost over 3,000. So we need to be selling at least 3 spectacles of approximately 1,000 each, and 1 spectacle of about 7,000 to make a 10,000 rupees per day sale. With this, what will be the result? Approximately 1 lakh per month of additional profit will come in, which we are looking at. We are not alone in this. Many professions have service plus product sale model. Architects are now providing turnkey projects. They take execution also, and they construct the building and give it to you also. So they are giving service plus product. IT solutions, they provide you with expertise, plus they give you software and hardware also they sell to you. We often talk about discount stores, but they are an opportunity. Unprecedented growth of these retail optical stores has been there, and most of these are discount corporations. They want to produce in bulk and just sell at discount and make money out of numbers, not out of quality in low quantity. In order to provide discounts, they do not engage highly skilled professionals to handle the huge volume of eyeglasses sold in such avenues. Now, widespread absence of optometrists in dispensary has led to a decline in quality of optical care delivered. And optometrist in this mode, where the bulk production is there, hardly has any role to select a frame or take markings or do anything. So the opportunity is we see a need to provide higher quality optical products and services. Generally accepted fact about people behavior in India is that so far, people would not wish to pay for services, although they are ready to pay for product. So if with our service we add a product, it's easier to earn, and it's very easy to communicate to the patient that the spectacles will be dispensed under supervision of a qualified person. Generally accepted fact is also that optometrists can assist in frame selection, measure segment heights, adjust eyewear, handle many other fundamental tasks, can do troubleshooting for patients, and do many other things. Optometrists should consider selection of lens to be part of the eye consultation while in the clinic itself. How that can be done, optometrist is the premier expert in ophthalmic lenses. Nobody else knows better than him. And coupled with data from eye exam, the optometrist is in best position to advise and educate the patient while still in the exam room. Through patient education, interview and discussion, optometrists can recommend products that will be best serving the purpose of the patient as a profession, the lifestyle, the need, the optical requirement, everything. Lens selection clinic can be, one can talk about lens design. You would need to take a lens which is progressive or bifocal or anything else, optional features, whether you need a special thin lens, you need stronger lens which doesn't break easily. Discuss about UV protection, anti-reflection, progressives, etc. To a child, we can consider giving multiple pairs because they tend to break glasses often and they go in for repairs often, so they must have a standby. If a patient does not want to follow or cannot afford it, one can easily help him with other options. Optometrists can guide, okay, leave aside this one feature and rest will be there and you can take this. Although experience is that they usually want expert opinion and they will honor it, they would not usually say no to what optometrists say. 2 points are food for thought here. Number one, how much is the difference of earning in two modes, consultation only and consultation plus ophthalmic dispensing? Quantifying this value is difficult, varies from practice to practice. We just took a hypothetical example. It may vary and it may be different in different experiences. But yes, that gives us a reason why we should have an ophthalmic dispensing unit along with the clinic. Number two, are optometrists needed forever? Ajit sir just told us how the world is changing and we must be prepared for the future. Could we think 20 years back that experts in VCR repair would not be required one day? We don't even hear about VCR, what to talk about the VCR repair people. So most of the needs of population have a perishable span of life, and we should continually expand our professional avenues by learning new skills, new methods, and change with time as technology progresses and new products come in. So inference is that optical department in optometry practice is simply an extension of clinic with a retail look and feel, while the goal in this department is to sell optical products and produce an excellent profit. That effort coexists nicely with the mission to develop and maintain a long-term relationship with the patient. That's what we all do. We have families as patients, not one single, and they keep coming for years together. Optical dispensing can generate more income for the practice than all other services combined. And optometrist does not have to perform the actual work in optical dispensing. Dispensing is truly a garden of jewels hidden in our backyard and just waiting to be encashed. So we decide for ourselves consultation only or consultation plus dispensing. And I give all credits to the OSA team who have created this wonderful platform. Congratulations, you people are
Thank you
really
so
doing
much,
well.
sir.
And as Ajit sir said, this is the only student association which has been doing it so regularly and so well. Thank you all. And my contact details are here. You can take a screenshot. In case you would wish to contact me anytime later, you're most welcome to do that. Thank you very much.
Thank you so much, sir. I'm confident that our audience have learned a lot from your wonderful presentation. Thank you so much, sir.
Thank you. Thank you. It's a pleasure.
Let's move ahead for discussion our topic, acceptation versus reality in eyewear industry, hospital, optical chain from an optometrist. To discuss, we have a panel of 4 optometrists, Mr. Pawan Kumar, optometrist and Dr. RP Center, AIMS, Mr. Ajit Bhardwaj, he is a director and founder of OptiQ, Mr. Rajesh Wadhwa, he is the owner of Wadhwa Optics, Mr. Ashish Pandey, he is the area manager in V Square Meditech Private Limited. Thank you all for joining us.
Hello.
I want all the panelists to share on your videos.
Yeah, good afternoon, sir.
Hi, good afternoon.
Yeah.
Hello, good afternoon.
Starting with you, Pawan sir,
Yeah.
what are expectation versus reality in hospital?
Okay, fine. Sir, as we know in today's scenario, we have a lot of young optometrists and they are very much career oriented. And they have lots of options available today. Like they can start their career from optical industry, professional services is MNC, hospital and research services, or work as an independent practice. Like Rajesh sir and Ajit sir already explained too much about the optical industry and the independent practice, and professional services in MNC is explained by Ashish. So like in hospital services, we have something different expectation, but the reality is something different. Like when we consider in hospital, the job preference for the optometrist, it is very easy and popular choice for the optometrist, because when the optometrist is interested in clinical and research experiences, and also that there are some other benefits that we have, like 9 a.m. to 5 p.m. job with no disturbance afterwards. And so we can give time to our family after the job. And we don't have too much travel, unlike in the professional services is MNCs. And however, when we look at the hospital as a whole, the different people have different expectation. In some cases, they are very true, but while in some cases, the reality is far from the expectation. Like firstly, some optometrist finds hospital job very convenient in terms of timing and the job profile. But the reality is that as the eye care awareness has increased tremendously with the time, and if you are working in the reputed hospital, this is so-called 9 a.m. to 5 p.m. job could be very tiring. As we have a large number of patients in the hospitals as compared to the other optical industries or something, due to which there are certain times when we are not able to even drink water during the office hours. Also, we have to be very precise and accurate while performing the procedures and investigations. So when we choose to work in the hospital sector, keep in mind that it is not that easy, go happy job, but requires our full attention, because our diagnosis and investigation will decide the treatment and the surgeries of the patient. As for example, if you overestimate axial length by 1 millimeter of a patient posted for cataract surgery, he or she will have post-op refractive error of 3 diopter, which is not acceptable. So the error in hospital needs to be minimized. And sorry to say that, but it is not like an optical industry where if you have prescribed wrong spectacles, we just to have the replace the spectacle lenses. Like I said previously, if the intraocular lenses in cataract surgery estimated wrongly, then we can't change the intraocular lens. And it is very tough to make the patient understand that he has to live with the glasses throughout life, who was preoperatively assured that he will not require glasses for distance after surgery. And secondly, the some optometrists find hospital jobs better as they think they can explore all the sectors of optometry and does not have to just stick to the refraction and the referral services. But as per my experience, when we join the hospital, it depends on the size of the hospital and number of the patients in that hospital. In a small hospital, the resources are very limited to only refraction and some small number of investigations. When we are associated with a large hospital, there are chances that we may have rotation posting. This will definitely help us in achieving our motive of having experiences in the all field of optometry. However, most of the hospitals prefer having same optometrists posted in the same department as they specialize with the time. But the biggest drawback in such cases is that we definitely will have a specialization in that field, but will not be updated in the other field, which is good also in the sense that deep knowledge helps us to master the subject and also to involve in the research services of that specific area. So I feel that as definitely hospitals are one of the best option if we want to continue our clinical and research experiences, but then we have to be well prepared for the hard work and dedication during the working hour. Thank you, sir.
Thank you so much, sir. Now coming to the Rajesh Wadhwa, sir. Sir, what are the expectations? Can you hear me?
Yes, I can hear you.
What are the expectations versus reality in retail, sir?
See, the point is, if we talk of a person entering retail for the first time, what we learn in our books is, as Ajit sir also said, it is the base to understand what really happens. Having qualified in a certain subject does not mean that we have become experts in that subject. Even for that matter, I remember Dr. G.N. Rao of LV Prasad Eye Institute saying that a new ophthalmologist who just comes out bypassing, we will not trust our eye to him for a cataract surgery, which is a simple surgery. Similarly, when a person comes into the commercial field from the institute, one would say, okay, give this person a high index lens. What does high index really mean? What will be the make? What will be the magnitude of index to be given? It can be high index, can be anything above 1.49, is above 1.523. Everything is, say, a high index. So then he would have also to know what are the coatings actually available. What are the commercial brand names which are available, which they will book into the order? How would they price it? What to give to whom? Which kind of frames are available? Lenses, frames, contact lenses, how to maintain a trial set inventory. All these factors plus our approach towards the patient is very different in a government hospital and in a private setup. While there, I remember one would not even use in a government hospital while calling the patient into clinic, one may not even use the prefix, a respectable prefix like Mr. or Miss or something. While in our private setup, that just cannot be. We are almost like into hospitality when we are in private. All these things have to be learned either in internship or the student who is come out should first few months work in a setup where he sees how it actually is done. And all these things cannot be published in books. These are practical. I think with this little approach, one would keep learning all life. Even today, we learn from every patient something new, and we get to improvise our system so that we can do better for the next patient. Thank you.
Bharti, unmute you.
Ajit sir, would you like to add something?
Okay, I'll you see, I think when we are talking about expectation and reality, one thing I want to tell all the optometrists is that don't pursue something because that is good. If you like the retail job and you feel there's a lot of money in it, don't join the profession because that profession is good. As I mentioned earlier, what is your aptitude? Are you really cut out for retail? Or are you cut out for a hospital job? Or are you cut out for a public health job? Or do you want to be a teacher? So you have so many avenues. So I would suggest that every optometrist is unique. And every optometrist is different from another person in the same hospital, in the same institution. So what are you looking for? Do you love teaching? Do you like to work in a rural area? So this all has to come from you. So don't start looking at what is good whether the hospital job is good or whether the retail job is good or whether MNC job is good. It may be good, but are you really cut out for it? That's the first thing you have to ask yourself. Second thing about, as Pawan said about hospitals, I want to tell you one thing. Yes, as I mentioned in my talk also, that the hospital job will be better paying job for optometrists in near future for certain years time to for some more years to come. And the reason is that you can practice many other aspects of optometry profession. You know, I'm listening to you all makes me very go back to 40 years back when I got into optometry practice, optometrist's first job. Let me tell you, today you're talking about so many avenues and so many choices. When I got my first job, you'll be shocked. My job was with none other than a good retail optical shop in Connaught Place called Bonton Opticians. And the job involved, they kept me, they gave me this good salary. And the job involved that I was to see patients only when ophthalmologists are not around. The rest of the time, I was supposed to look after the optical lab. My job was to mark center, mark axis, supervise that the glasses are made correctly. That was the job profile of an optometrist 40 years back. And when I started working and when I started showing my results when ophthalmologists were not there, gradually I saw there were 3 ophthalmologists they used to visit at Bonton Optician. They started reducing. And within 1 year, all the 3 moved away. So what exactly that indicates is that you have to create your own space wherever you are. If you are in the hospital, as you mentioned, the job may be tiring. You see, it is up to the administrations. Many good hospitals in the country, not in the country, but I travel extensively and I see how optometrist practice is done in eye hospitals and multi-specialty hospitals. Optometrists are not given appointment. Optometrists see patients only by appointment. They are not overflooded, because if you definitely overflood a number of patients there will be chances of more errors, which any good administrative person or any good hospital should understand. They give you the appointment that you must spend 30 minutes of your time with every patient. That is number one priority. That is why the patients are given appointments. There are slots available for optometrists. So you have to see that the hospital is not overburdening you, and you have to give that point of view to the hospital that if you overwork me, there will be chances of errors, which they will understand. There are more chances of growth in hospital setup, because I see overseas in multi-specialty hospitals, optometrists, they present their cases with other specialities. The other specialists will be sitting, you will be optometrist will be sitting, you will be asked to present your case, what you have seen best in last 1 month, and they will be sharing their cases with you. So you learn to become a totally healthcare profession in a real way and understand other issues of health along with optometrists. Same thing happens to the other healthcare care providers, which I seem that doesn't happen in India, because even in eye hospitals, ophthalmologists, they talk separately and optometrists, they talk separately, which is, I don't understand that why the difference is created within hospitals. Why ophthalmologists and optometrists don't sit together and discuss cases within the same boardrooms? That has to change, because ultimately that division is made by us, not by anybody else. So that change has to come within the hospitals. You have to see that there's a growth for yourself. Don't join a hospital which does not give you professional satisfaction. It doesn't have that kind of instrumentation where you want to work. It's better that you find a hospital where those instruments are. But if you want to work in a public health and see that, yes, you want to work with rural areas, you don't expect that there should be good equipment or there should be high-end equipment there. You need to work with, smaller equipments in the rural areas. So I would suggest that each of you have your own strength. Look at your own strength. What I'm good at. Am I good in teaching? Then go and join an optometry institution where the teaching is involved. Am I good in research? Go and join a hospital where you have the research facilities available for you. So I would start looking at the optometry should not look what Rajesh did or what I did or what Ashish did, but you look at your own way, own life, and create space for yourself within that area. And there are multiple avenues which all of you know today, and there will be many, many more opening in near future. And then that's my opinion on this, expectation and reality.
Thank you so much, sir. Coming to you, Mr. Ashish Pandey, sir. What are the expectations versus reality in MNCs?
See, as I earlier told you, expectations are always higher, and we have seen a lot of stalwart in MNCs who are doing actually good. But there is always a lot of pressures in MNCs. You have sales pressure, and there is always a pros and cons in MNCs, whether it is MNCs or in optical outlets. Where are you working? So you need to choose your profession where you enjoy most. So this is my feelings about that.
Thank you so much, sir. Sir, we have a question from the audience for Rajesh Vada, sir, for you. How to do financial management in newly opened clinic?
Well, financial management, the most important thing is, I would say, the optometrist must have some idea about accounting. So if nothing else, there are many online short courses of 8 or 10 hours total duration, which will give you an idea about how the finances work. And one could even learn how to do personal accounting. That also is about 8 to 10 hours of course with various softwares available in the market. Once you get an idea of that, then you grow into it and you'll get to know how the cash flow goes. What is negative cash flow? What is positive cash flow? What is good for growth? How would I know that on that particular day such bills are to be paid, and how would the funds come on that particular? All that becomes very simple and easy. It won't be difficult. So if you start organizing the mind, everything will start organizing on paper itself, and your finances will never be a problem if you've done within your means and how you manage your finance. Yes.
Thank you so much, sir. Coming to you, sir, Ajit, sir. What advice do you want to give to budding optometrists who wish to set up their own clinic?
Their own clinic is the most difficult task, is to set up your own clinic. Because as I mentioned, only 10% of people have that kind of inclination. Only 10% of people have mind or aptitude for business. Because unfortunately, in our country, in our curriculums, whichever we learn, business administration, business part of business ethics, accounting, interpersonal skill, how to talk to your customer is never taught. That is the essence of setting up a private practice. We just learn from experiences, and then we start to go into retail on practices. But what I think an institution need to see, that most of us are doing the job or are they earn their earnings by their own means, are self-employed. I was looking for this word. Most of us earn their salary, earn their income by their own effort. As a result, being in a profession where you don't have to depend on the government job or a job given by somebody else, it is very important that the optometry institutions, the curriculums, must have some at least 6 months course on business part, which is missing from our curriculum. So how to become an entrepreneur need to be incorporated in our optometry discipline, and I would urge that sooner the better, because we don't have government does not offer many jobs. If you see, the government has limited jobs, and those jobs are going to be even lesser and lesser in time to come. So we have to find this, and these optometry institutions must make sure that they prepare optometrists so that they can have that entrepreneurship skill, so that they can own their own practice. I would suggest that you must work with some opticians for some time. You must work in a hospital for some time, and just look at other colleagues who have done it, work with them, talk to them. And then if you feel that you have the attitude of that, then only going for retail, because this is the most difficult part. Doing business is not easy. Let me tell you, it's not easy. You may feel that, there's a lot of money, but the kind of risk, the kind of tension, the kind of strain, the kind of, the administrative skills, the management skills you need is multiple. If you have those, join the retail. Otherwise, you better start working with an hospital or with another optician, because in time to come, it's going to be more and more difficult to open retail outlets. So I would, that's my say to all optometrists.
Bharti, unmute yourself.
Okay, sir. Okay, sir. This is another question for all the panelists from the audience. If we consider revenue or financial expectations, would it be fulfilled or turn into reality, whether in hospital, retails, or IVR industry?
Rajesh, you go. I'll ask.
I think to my mind, the answer to this is in astrology, not in this panel. Ajit sir, please take over.
Mike, repeat the question. Let me hear it again.
Okay, sir. If we consider revenue or financial expectations, would it be fulfilled or turn into reality, whether in hospital, retail, or IVR industry?
You see, retail or eyewear industry needs capital. You have to understand that, you need money to start a business. So that is very important to take that decision. Because if I tell you there's a lot of money in retail, but if I don't tell you how to get that, you don't have that kind of money, it's not going to work for you. So my call will be, yes, there could be good money in retail if you have investment to make. Number two, if you don't have money to invest, I would suggest that if you are looking for a job, there could be good money working or collaborating with ophthalmologist. And yes, then if you have attitude, because some optometrists, what I feel is that the very few of us are cut out for a job which is with MNCs. That's a very, niche job. Not many people can do it. Not many people, because I know that if I don't have that attitude to go to different opticians to sell a product, even if you give me any amount of money, I may not like to do that. So it all depends whether what you are made of, what is your skill, what is your strength. Do you like to see patients only in the clinic? I know of a friend of mine who was offered a job in a optical chain, and he was given a salary much higher than what he was getting in the hospital. But he preferred to work in a hospital. The reason is, in the hospital, your responsibilities are absorbed by somebody else. Your responsibility is taken by your superiors. If a mistake is happening, you are not responsible for that. But in a retail outlet, even if a spectacle breaks after 6 months, it is the responsibility of the optometrist who sold it. If the glasses, may lose the balance and the person does not see, you are blamed for each and everything. So it all depends, what exactly do you like. Some people may like more money, so they like to go more in retail. But some people like professional satisfaction, and they like to work in hospital, which works for them. So don't go where the money is. Go where your core strength is. What do you really like? Do you like to sit in a clinic and behave like a doctor and see patients? Or you don't mind, compromising that and sell glasses outside? Because some optometrists, they come to me and they tell me, sir, main chashme nahi bechunga aapke. I said, very good. If you don't want to sell it, then you improve your customers' inflow in your clinic. You improve the expertise in the clinic. So some optometrists, they are very particular about that. So you have to decide whether you want to do that or not. So I think it's the individual has to take a decision on this rather than me telling you, okay, you do this job or that job.
Thank you so much, sir. Pavan sir, Rajesh sir, and Ashish sir, would you like to add something in this?
Yeah, so like Ajit sir said, the revenue is directly proportional to the investment. The amount of investment is the directly proportional to the revenue what we can get.
No, and the risk also.
Yeah, risk. Yeah, no.
Not necessarily if you have revenue,
Yeah,
you
all
will
your
get
risk
out of
is-
it. I've seen many people pulling a lot of revenue and failing out of it also. So, and let me tell you, as I mentioned, the business is so dynamic that whatever you are thinking today, whatever strength you have today is going to change. Like when we started, we had a different setup. We had different investments. And within 20 years, we find ourselves that those tricks don't work. Every 20 years, you have to reinvent yourself, think of new ideas of how this retail, because retail changes every 20 years. Those businesses which were there when we started, they no longer exist. And same thing will happen to optical practice also. The practices which were old, they are outdated now. So you have to constantly reinvent, add new things to your businesses to make sure people start and patronize you and take you that you are current, so that investment has to be regular, and there need to be, reinvention of your skills. Everything has to be updated and very frequently in retail. So it's not necessary that if you have money, you will make it. No, you may lose it also, that money.
Thank you so much, all the panelists, for such a wonderful and informative discussion. I hope audience must have got a real insight into the optometry industry. Thank you all. It's a time for a short break.
Thank you. Thank you very much.
Thank you,
Thank
sir.
you. Thank you all.
Good afternoon, everyone. Now let's move forward. I would like to invite Dr. Sanjay Mishra sir for his talk on challenges and prescription of glasses in the children. He is presently working as the scientist at Dr. RP Center, AIMS, New Delhi. He worked as the optometrist at Shroff Eye Center. He has completed his fellowship in the optometry from LV Prasad Eye Institute, Hyderabad. Welcoming, sir. Over to you, Mike, sir. Sir, are you listening?
Yeah. Am I audible to you?
Yes, sir, you are audible. But sir, your screen is not visible. Yes, sir.
Is it visible now?
Yes, it is visible. Also audible.
Okay. And my video is there or not?
Yes, sir. Your video is very clear.
Okay. So thank you, Ruxana, for the introduction, and I'll thank OSA for giving me the opportunity to deliver this lecture. As we all know, dealing with children is always a challenge. Therefore, in this talk, we'll be discussing about what are the challenges when you deal with the kid and what are the prescription guidelines for glasses in children. So why do you want to refract a small kid? Globally, uncorrected refractive errors are the leading cause of visual impairment and of course the second leading cause of blindness, affecting more than 108 million people. If you talk of India, Rakhi Dandona et al. In their APET study concluded that refractive errors are causing visual impairment in 61% of children, leading to amblyopia in 12%. Clear vision is essential for the overall physical and mental development of any child. So if there is a refractive error which is uncorrected, it might lead to amblyopia and squint also. Amblyopia, if it is detected early, may be treated or reversed completely. And the squint might be partly or maybe completely due to uncorrected refractive error. So if you correct refractive error, you might completely correct squint also sometimes. So if we correct refractive error, we can take care of amblyopia and squint to some extent both, because there's a large amount of plasticity in the visual system of a child. So what are the challenges? What are the challenges in pediatric refractive management? Getting children for screening is a big problem in a country like India. And also correct vision assessment is a big problem because of the child's age. Accurate refraction is a problem. Many times subjective refraction is not possible for toddlers and infants and all. So we have to rely upon our objective refraction findings. Many times refractive error is also associated with strabismus, as discussed earlier also. That also has to be keep in mind while prescribing glasses, and compliance and follow-up, regular follow-up is also a problem. So when to examine a child? The first examination of a child, if a child does not have any problem, should be done at the age of 6 months, because this is the age when child's axial length grows from the 17 millimeters to 23 millimeters, and emmetropization, large amount of emmetropization takes place. So earlier the detection of the refractive error, its correction, and better the management of the vision. So second examination should be taken at the age of 2 to 3 years of age, because at this age, if you do not correct hypermetropia, it might lead to accommodative esotropia, a kind of convergent squint, And if you do not correct the astigmatism, it might lead to meridional amblyopia. Third examination should be undertaken at the age of 5 years, because this is the age when child starts going to school in our country, and child is in first grade or so. So optimal vision is required for learning. So at this age, if you correct the refractive error, if child suffers from the refractive error, and if you correct, you can uh, you can you can save the child from impacting its learning. Thereafter, 6 months to yearly examinations throughout the school years are required, because this is the time when the visual demands are changing, and visual demands are very high also. Children are preparing for various competitive exams and all, and refractive error changes throughout their childhood. So here are a few tips to get good cooperation from a small kid. Children, as you know, can't sit calmly, can't wait for longer when you call for examination. So it's better to have a space, something like this, in your clinic for children. So if they enjoy the ambience, definitely they are going to come back for follow-up to you again. So one should always avoid schedule an appointment when the child is alert. Alert child is required for many tests. So if you are trying to wake up the child when child was sleeping, this happens. So child should be alert like this. So you should always avoid a nap time while uh, examining a child. And one should also work quickly, and also to prioritize testing, so that the important testings are not left undone, because child's attention span lasts for only 3 to 5 minutes. So within this much of time, you have to do all the important tests. One should avoid wearing white lab coat, as children memory is sharp, and they know they must have had experience of getting immunization shots from a person wearing white lab coat. So therefore it is advisable, actually children get frightened looking the doctor. So no white coat when you are dealing with a child. You can also engage the child through conversation throughout your examination, and you may also in between crack child appropriate jokes to them. And you can use brightly colored fixation targets like hand or finger puppets, colorful stickers, small pictures, etc. You can also keep like uh, Dr. Sharma is keeping in his uh, attache some toffee or chocolates, and it should be offered either during when the child is crying, or toward the end of the examination, to remain good, maintain good rapport with them. And also you may allow bottle or crackers or a toy when you are examining the children in their hands. And it is seen like we are using adult sized examination chair when we are examining children, so they are not able to reach up to the slit lamp or autorefractometer. So it is always better to use a booster seat or pillow underneath them. Kneeling down on the examination chair is not a good practice. You may allow children to sit on the parents' lap, or rest over their parents' shoulder for better cooperation. One should always use pediatric trial frame, which is lightweight, and the one with the Velcro strap is the best, as due to weight, as the child's nose is underdeveloped, and because of the weight, the trial frame sits down on the nose. So it is better to use the Velcro strapped lightweight trial frame for child's refraction. You may have to start examination even in the waiting area itself. And if you were to dilate the child, it is better to not to dilate on the first visit itself. You can defer the dilatation for the second appointment, because most of the dilating drops, they irritate the eye, and then child will not cooperate. And also, if you were to dilate in the same visit or in the subsequent visits also, if you have to dilate, it is better for you not to put the dilating drops in the patient's eye. And you may ask your secretary, or you may ask parents to help you in putting the drops. They will put the drops. That way you maintain the good rapport with the child. So as you all know, there are various types of refractive errors, and how to diagnose them by means of performing refraction. There are, broadly speaking, there are two types of refractions: the objective refraction and the subjective refraction. Objective refraction techniques include auto refraction. The portable auto refractometers are used in children, and also adult size refractometers in teenagers and little older children. So retinoscopy is of two types: the static retinoscopy and dynamic retinoscopy. So I'm not going into great details of these types of retinoscopies, because I know you all are well versed in performing retinoscopy. Broadly speaking, there are two types of retinoscopies done: the dry retinoscopy or manifest retinoscopy, and the cycloplegic retinoscopy. So in children, mostly cycloplegic retinoscopy is done. So, but the retinoscopy is not only a science; it's an art also, and that you need to learn over a period of time by keep on performing retinoscopies. So, when to perform a cycloplegic refraction? If child has hypermetropia, it might lead to accommodative esotropia or amblyopia. So, if there is a hypermetropia, you have to refract a child using cycloplegic eye drops. If there is esotropia and convergence excess esotropia, then also you have to do a cycloplegic refraction. So if there is an isometropia, anything more than one diopter might lead to amblyopia. So if there is a significant amount of anisometropia, that also is an indication for cycloplegic refraction. And if there is a accommodative spasm many times mimics the known as pseudomyopia. It mimics pseudomyopia. Then if there are signs and symptoms of accommodative spasm, then also cycloplegic refraction is indicated. If child gives the symptoms of headache and all, especially for near work, then also cycloplegic refraction should be undertaken. And if you find like the pupil size is fluctuating, or there is a fluctuations in the end point or neutralization point of retinoscopy, then also if there is a variation, variable readings are coming at the time of neutralization, then also you must subject the patient to cycloplegic refraction. So retinoscope, preferably streak retinoscope, a trial frame, a trial box, fixation target, which should be non-accommodative, large sized, and a dark room are the prerequisites for retinoscopy, performing retinoscopy. This is the normal setup for performing retinoscopy, and this is the setup for performing retinoscopy under sedation or under general anesthesia. So as you all know, greater the working distance, lesser the chances of error while performing retinoscopy. So coming on to subjective refraction, many times subjective refraction is not possible because of the child's age and child's cooperation and all. So you have to rely upon the objective refraction findings. And like for ROP patients and all, you have to prescribe the calculated amount of number, and also guiding with the guiding principles of prescribing glasses, which we'll be discussing in subsequent slides. So once the refractive error has been determined, then the decision is made about whether to prescribe the glasses or not to prescribe the glasses. So if there is no squint, then this decision is based on magnitude or the amount of error. If error is high, then you should prescribe the glasses. And also it depends upon the visual needs of an individual and the risk of refractive and anisometropic amblyopia development. So if squint coexist along with the refractive error with squint or abnormal AC by ratio, a full cycloplegic refraction is always to be prescribed. And if there is a esotropia and for near, then executive type of bifocals are prescribed. If it is not possible to completely correct the squint, then you might have to also refer the patient for squint surgery. So what are the guidelines for prescribing glasses in different types of refractive errors? If there is myopia, what are the guidelines for myopia? If the child is very small, like toddler, less than 1 year of age, there is no need to prescribe even up to 5 diopters of myopia, because child's attention is not does not go far away. For 2 to 3 years old children, myopia is corrected if it is more than 3 diopters. For school-going children, that is more than 4-5 years of age, anything more than 1 diopter of myopia should always be corrected. And what should be the aim? The minimum minus number to the maximum vision, which many times we are able to achieve only through cycloplegic refraction. And in older children, contact lenses may be prescribed if the amount of hypermetropia, amount of myopia is high, to avoid any minification with the spectacle glasses. What are the guidelines for hypermetropia? If hypermetropia is there, but there is no esotropia or there is no asthenopic symptoms, then there is no need of correcting small amount of hypermetropia, because small amount of hypermetropia is common and it is being overcome by the accommodative efforts of the child. So what when there is astigmatism? So if there is a simple astigmatism, like a simple myopic astigmatism or simple hypermetropic astigmatism, there's no need to prescribe the cylindrical number until unless it is more than 1.5 diopters. These are the recommendations. But if there is cylinder and also coexistent spherical number, so sphere and cylinder, that is the compound astigmatism is there, compound myopic astigmatism or compound hypermetropic astigmatism, then you should always prescribe the cylindrical power, even if its amount is very small, very less. Because anyway you are going to prescribe glasses, there is no need to prescribe the spherical equivalent in these cases. Okay, and if there is a oblique astigmatism, the close follow-ups are required. Whenever there is anisometropia, anything more than 1 diopter, especially in anisohypermetropia, there are chances of getting amblyopia in the eye which is having more power. So it is better to always correct the anisometropia if it exceeds 1 diopter. Okay, and you can also consider prescribing contact lenses when the amount of anisometropia exceeds 3 diopters, and in such cases close monitoring, close follow-up is also required. Here are few guidelines for making spectacles in children, like spring-loaded frames, and these are better quality frames. They do not get dislodged or distorted easily, and the nose pads, those with the silicone nose pads are best suited, and comfortable temples or straps are the choice of frames for children. So plastic lenses and especially high index and polycarbonate non-breakable lenses are advised for children. and all sorts of coatings like impact resistant coatings, scratch resistant coatings, anti-reflective coatings are, and also during the post-COVID era, children are spending more and more time in front of the monitor. So it's better to prescribe blue cut lenses to them, because we don't know the long-term effect of blue rays in blue ray damage of the macula. So thank you so much for your kind attention. Thank you.
Thank you, sir. Thank you, sir, for your wonderful talk. Now it's time for a short break. We will be right back at 2 p.m.
Yeah, good afternoon. Can you hear me?
Sir, we will beginning right 2 o'clock. Hello everyone, I am Sumit Jadon, Treasurer of Optometry Student Association. Welcome you all in AIMS Optometry Explorer 2021 with the theme Emerging Technology and Culturing Excellency in Eye Case. I'm extremely honored to have this opportunity to address Dr. Rohan Chawla to make us understanding newer I'm extremely honored to have this opportunity to address Dr. Rohan Chawla to make us understanding newer paradigms in OCT, optical coherence tomography. Currently, he is serving as Assistant Professor of Ophthalmology in Dr. R.P. Center for Ophthalmic Science, AIMS, New Delhi. He is a specialist in vitro retinal and uveitis. He has many in national and international publications in his name. Over to you, sir.
Thank you, Sumit, and thank you very much for making me part of this conference. So as Sumit has said, I'll be talking on OCT. So let me go to the presentation directly. Okay, can you see the screen?
Yes, sir. Yes, sir.
Okay. So what is OCT? OCT is a non-invasive technique which gives us a very high resolution morphological analysis of the retina. Initially, we started with time domain, then we moved on to spectral and swept source. And as the technology has improved, so has our ability to see the micro details. So now with swept source, we have a resolution of about 1 microns, and the field of view is also keeping on increasing. So we can take about 12 millimeter scans, and in the future, although it's already become a reality, even ultra wide field OCT is now available, where you can even take scans of the peripheral retina. And other things being added up apart from the standard B scanner, on-fast imaging and 3D imaging. I'll show you those images. So it helps us not in just evaluation of the retina, but the subcomponent layers of the retina, the vitreous as well as the choroid. And all of this information helps us in establishing a correct diagnosis and deciding the correct line of treatment and giving a prognosis to the patient. So you see, earlier we used to see just the fundus like this using a fundus camera. Then came time domain OCT, where you can see the individual layers, but not all the 10 layers of the retina. Then we moved on to spectral domain, where individual layers like which I have marked with this arrow could be seen, and even better with a swept source. So once we could see all these layers, we have come up with an international classification. So this is easily available on the net. You should all know this. So what does each line represent? Which sublayer or layer of the retina? Only then you can properly describe the OCT. So the white ones, which are the highly reflective ones, are generally composed of the plexiform or layers which have fibers. And the hypo or the less reflective black layers are mostly composed of structures which have loosely packed structures like cells. So the outer nuclear layer or the inner nuclear layer. So, but you should know all these subcomponents. So, and the outer 4 layers are actually nothing but sub parts of the rod and cone cells. Okay, so such micron detail we are seeing, and any disruption in this will directly corroborate with the change in visual acuity of the patient. So these 4 lines out, the outer 4 lines are very important. Starting from the retinal pigment epithelium, you have the interdigitation zone, then you have the external limiting membrane. So disruption of these lines definitely change the visual acuity of the patient. So that was about the image, which you must know, but how to capture the image. So most of the machines, it is very easy these days. Basically, you have to ask the patient to fixate either at the macula or the disc or at some other particular point. And generally, once the machine tells you that the image quality is optimized, you can just click and take a photograph. But you should know which scan to do. So there are a lot of options available. Some machines give raster scans that are multiple horizontal lines. Some machines give radial scans, and some machines give on-fast scans, which will also give you a 3D view. So, but the main point is that you should try to cover as much as possible of the retina. And if some ophthalmologist has marked a particular point, say the lesion of interest in the retina is say nasal to the disc, then you have to shift the scan there, or temporal to the macula, then you have to shift the scan. So you should capture the area of interest and take maximum number of scans. So the shorter the size of the scan you keep, say 6 millimeter or 4.5 millimeter, the higher the resolution. The larger you go, the resolution falls a bit, but still it depends on how much area you want to capture. So that was for one machine, Topcon. This is for another machine, Zeiss. I have no financial interest, please. But they give you various options of protocols, and you should select the one which best helps you characterize your lesion. And then once you've taken a scan, it will also give you various protocols to analyze it. So whether you just want the thickness of the macula, you want ganglion cell thickness, or you want RNFL thickness, and or so on. So you should also know about the protocols. And in general, it will give you a cube analysis of with an ETDRS sort of chart, in which it will give you the thickness of the central 1 millimeter of the retina, 3 millimeter circle, and 6 millimeter circle. So these are some standard things. So after capturing on the images, you should know how to describe it. So generally, for the macula, we would tell something about the foveal contour, whether it is normal or not, then the status of each of these layers and sublayers, which I just told you, whether they are continuous, disrupted, or you are seeing any abnormal reflectivity in any of these. And then the central macular thickness can come either manual measurement or from that ETDRS chart. And what are the changes at the vitreoretinal interface? And with the newer machines, now we can see the choroid also. So the thickness of the choroid and whether the vessels over there are normal or pachy. And you should not base your diagnosis on just one scan. So like here you see we have done a raster scan, so we have done so many line scans. Now if you just see one scan, you might say that this retina is almost okay, but if you shift the scan, now you see I've brought the scan down here, then you will start seeing that these hypospaces are present, and then someone might conclude that this is cystoid edema, or someone might say this is schisis. But if you shift the scan further down, now see what you see. There is a total macular hole here, total disruption of layers. So your diagnosis absolutely changes. So if you had not seen all the scans, you will make a wrong diagnosis. So it is very important that you see all the scans and then give your diagnosis. So this is a macular hole with adjacent cystoid changes in the retina. So those cystoid changes, this is a B scan. And now what I told you was the on-fast scan, which is the new technique where we can take flat images, 3D horizontal scan. So here you can also get the horizontal extent of these spaces and how far this edema is extending. We can also do 3D reconstructions. So here is a case where you see this yellowish lesion under the optic disc. You see the B scan, there are some hypospaces in the choroid. So what are these? You see them better in the 3D. You see that they are actually these cavities in the choroid. So you can do 3D reconstructions to analyze it better. And then coming to further newer concepts with these scans, we have come to OCT angiography, which is dye-less. And here, because of the large volume of data, we can evaluate the vascular pattern of the retina and a bit of the choroid as well. So this is standard angiography, fluorescein angiography or ICG angiography, where you can see the vascular pattern of the retina. But what is the problem with this? You see here there is an overlap. So you can see the retinal vessels, you can see the choroidal vessels, but everything is overlapped, and only in one photograph you have to analyze all of them. Whereas with OCT angiography, the main advantage is that we can segment it. So we can separately see the retinal layers, retinal vessels. We can separately see deeper retinal vessels, and then we can further separately see choroidal vessels. I'll show you. So what is the principle? As the red blood cells move in the blood vessels, the OCT signal that they sent back changes. So this change or this decorrelation of the OCT signal is detected, and that is converted into a flow map. So if there is decorrelation, it is marked as flow, that is white lines. If there is no decorrelation, it is static, then it comes as black. So wherever there is flow, you will get these white lines, and that is how you will get the image of the vascular network in the retina. So like I said, we can segment it. So retina has generally two vascular layers. So you can see the superficial vascular layer separately. You can see the deep retinal vascular layer separately, whereas in standard angiography, all of this will be overlapped. Then you go to a section deeper in the retina, you can see deeper retina, nothing much is white like a vascular pattern because this layer is avascular. So nothing here. You go further deep, you can get the choroidal vasculature, you get further choriocapillaries, and deeper you can also see the larger medium choroidal vessels. So how do you segment? So each scan has this color box, and this is an orange box. So there are two orange lines here. So that means that this box is showing data between these two orange lines on this OCT-B scan. If you shift to the next box, you can adjust these lines and take them deeper. These are standard machine segmented, but there is also an option of manually segmenting it. So you can select two lines and only the vasculature between those two lines will be shown to you on these on-fast maps. Just to give you example of how this technology helps OCT and OCT angiography. So this is a fundus image of a patient where we can see that there is some grayness here. So maybe some fluid here. The first person who did the OCT saw that there is fluid in the subretinal space and made a diagnosis of CSR. A second person saw another cut and he said, no, there is fluid extending up to the optic disc and some cystoid spaces here also. So that person made a diagnosis of optic disc pit causing fluid in the retina and under the retina. But then we also did OCT angiography, and what we found is that this area here is having flow. So actually this is a new flow vessel here. So it's a choroidal neovascular membrane which is causing this flow into the retina. So the diagnosis totally changes once you see the OCT angiography. It could have been picked up with standard angiography, but here the advantage is it is totally non-invasive. So we have done a lot of work on this, characterizing these idiopathic choroidal neovascular membranes using OCT, and we have found it to be a very good technique. Now, just to show you more clinical examples. So here there's a patient with all these cysts here. So case of cystoid edema. And when you give this patient injections, intravitreal injections, anti-VEGF, it subsides. So near normal foveal contour with much less foveal thickness. So you see how OCT is helping us to assess the response to therapy also. And it also helps us classify the edema into various forms. So there are cysts here, there is spongiform total thickening, and there is a neurosensory detachment here also. So there are different types of macular edema which can be classified. Again, OCT is showing you how there is a response to therapy. Now this is a new type of edema being detected by OCT where you see these white lines. So these are vitreous traction bands. So this is pulling up the retina. So this is edema with vitreomacular traction, and here our management will change from medical therapy to surgical therapy, where we have to remove the membrane to improve this edema. Now again, OCT can confuse you also. So sometimes you see this OCT, you can maybe again make a diagnosis of central serous retinopathy considering this hypospace here as fluid under the retina. But if you see the fundus, you see the picture is totally different. It's not just a grayish area, it's a yellowish patch there, which is not generally seen in CSR. And if you see the other eye also has a similar yellowish patch and fluid with this thumb-like, finger-like projection here. So this actually is a case of vitelliform dystrophy. So even vitelliform deposits can have this hypo sort of pattern. So the main objective of telling you, don't make your diagnosis just based on OCT scans. You have to also correlate with the fundus image and the clinical picture of the patient. Now, this patient was having little diminution of vision, but if you see the gross fundus, you don't see much. You maybe see a yellowish dot here, little small one, but you don't know what is happening. So again, OCT technology helps us a lot here. You do a scan and immediately you know that the outer layers are disrupted. So this is a case of basically outer lamellar hole, and that is why the patient is losing vision. We have published this also. This patient developed this because he was viewing the solar sun after cannabis consumption. So, and unfortunately, the patient lost this central vision over here. But the exact diagnosis could easily be established by OCT. So OCT helps us characterize various lesions, like in age-related macular degeneration, these yellow spots are drusen. So you can actually make out that this retinal pigment epithelial line is becoming bumpy, and these are drusen there. And OCT has shown us that there are another type of drusen called pseudo drusen, where the retinal pigment epithelium stays normal, but these deposits are above this line. So these are called pseudodrusen, although on fundus they might appear similar. Then that was about dry ARMD. Coming to wet ARMD, this is one sign which all of you must know, which is called a double layer sign. So subretinal fluid, you will all be able to detect, many of you. Then if this RP is becoming bumpy like this, most of you will be able to detect a pigment epithelial detachment. But what you should not miss is that in some areas you might find that this retinal pigment epithelium gets separated from the underlying Bruch's membrane, and there is a hyperreflectivity in between. So normal OCT, the retinal pigment epithelium and Bruch's is attached. But if this gets separated, we call this two layers. So it's a double layer sign. And if you are seeing a double layer sign, it is highly suspicious that there might be a branching vascular network here, and it might not be just a simple case of pigment epithelial detachment, but rather a case of vascularized pigment epithelial detachment or polypoidal choroidal vasculopathy, and these need separate treatment by anti-VEGFs. So people have classified, if you see thumb-like PEDs with double layer sign, it is more likely to be case of polypoid choroidal vasculopathy, whereas if you see flat trapezoidal PEDs with intraretinal changes more rather than subretinal changes, then it might be a case of type 3 neovascularization, which is also called RAP. So this OCT technology is so good now that despite so much of blood here, the OCT beam can penetrate, and we can even see the subretinal blood, and we can see how much extent it is and whether it is just under the retina or also under the pigment epithelium. So it can even show you under the blood. So that patient, we gave C3F8 gas injection, and after injection, see the blood has shifted. So now the OCT is telling us that the retinal contour is becoming normal and the amount of blood has decreased. So this patient is responding well. So in this sort of picture, if you have sort of atrophy here, sometimes you may not know what is happening, but the OCT will tell you that this is a rip. So you see this continuity of the retinal pigment epithelium has gone. Retinal pigment epithelium has just broken here. So it is called a retinal pigment epithelium rip. So these micro details are better seen on OCT. Even in inflammation, these dots seen in the vitreous, these are cells in the vitreous. So it tells you that these are cases of inflammatory pathology. So those were some retinal lesions. Now coming to choroid. So in this scan, you see the retina overlying is almost normal except some fluid here, but the choroid has become so much elevated. So this was actually a case of systemic malignancy with a metastasis to the choroid. This is again another case where retina is normal, but you see these choroidal layers here, the sclera has been pushed back, and you can see these lamellae here and whitish lesion in the retinas. This is a case of choroidal osteoma. So this can help you diagnose various different types of choroidal tumors. So this is a case of, this is pinkish lesion, orangish here under the disc. So here you just see a bump here, and the choroidal vascularity sort of is maintained. So this was a case of choroidal hemangioma, treated with laser, and now you see that the retinal fluid and all is absorbed. Another yellowish lesion in the fundus, what is it? Is it retinal lesion or is it choroidal lesion? You do an OCT and you see the choroid is totally elevated. So this is basically a choroidal granuloma with some this hyperreflectivity going into the retina because of the inflammation spilling into the retina. But actually a choroidal lesion. This was a case of choroidal tuberculoma. We treated with anti-tubercular therapy and see how nicely it has resolved. The fundus is still showing those yellowish changes, but OCT tells you that all that choroidal hump has gone. Retinal layers are normal, and this patient recovered about 6/9 vision. Another yellowish patch here, is it retinal, is it choroidal, will always be in your mind. But when you do an OCT, you see overlying retina is normal, but there is this hypospace in the choroid. So this is again a case of choroidal granuloma, but this was a case of sarcoid granuloma. This was only treated with steroids. And again, though the fundus spots are there, but OCT shows you that hypolucency is gone and the choroidal inflammation has subsided. So it can also help OCT in vascular pathologies. In this case, you see there is gross whitening of the retina with so much tortuosity and dilation of the veins. So it is a case of CR view, but OCT also shows this high reflectivity of all the layers. So this tells you that this is not just a simple CR view, but this is also a case of branch retinal artery occlusion along with central retinal vein occlusion. Another entity here, we see whitish areas in the fundus with some images. Now, is it again arterial occlusion total? Now, this is a new entity which only came to be described with OCT, but here you see this whitish hyperreflectivity where my arrow is pointer is not throughout the retinal layers, but only in middle part of the retinal layers. So this is an entity where only the deeper plexus is probably more affected than the superficial, where these circles are. You can see the hyperreflectivity. So this has been described as paracentral acute middle maculopathy that can be associated with various other forms of retinal vascular diseases. So you see how you get a quick diagnosis with OCT. This patient actually has these yellow spots. He came with a complaint of decreased vision in this eye, in the right eye. But right eye, when I saw the OCT, I saw that there is just small hump here, but nothing much. But what was of interest to me was the left eye, because when I saw the left eye OCT, apart from the small amount of fluid here, I could also make out a double layer. I hope you can see this double layer happening here. So although the patient is not symptomatic, but since the OCT is telling me there is something happening, I did an OCT angiography also. And when you see the OCT angiography, you can see this vessels. So there is a choroidal neovascular membrane. This is forming here. Patient's vision is 6/6. So this has helped us detect it very early. And now if we treat this patient with anti-VEGF, patient might still maintain 6/6. So another entity called parafoveal telangiectasia, where segmentation helps us a lot. So see, this was the superficial segmentation, which is almost normal. But if you see the deep segmentation, you can see this altered wavy pattern of vessels here. So these are the parafoveal telangiectatic vessels and nothing else in the deeper layers. So this is a case where the fundus is showing just a little bit graying, but OCT angiography immediately tells you, and you don't have to do a fluorescein angiography, inject the patient and take the images. Just OCT angiography is going to tell you that this is a case of parafoveal, confirm the case of parafoveal telangiectasia. These are new vessels arising on the optic disc. If you see the fundus photo here, disc, if you don't see it carefully, you might say this optic disc is very normal, but it is actually having these new vessels. And so in this, probably a patient of diabetes having new vascularization of the disc. You can also now take montage images of OCT angiography and extend your view. And here you see bunches of new vessels. So you can see new vascularization areas. You can also identify capillary non-perfusion areas. So a lot of function of the normal fluorescein angiography is now being taken up by OCT angiography. So OCT for structural details of retina, choroid, vitreous, and OCT angiography for vascular details. So I think after analyzing all these images and correlating with the fundus, you can get a better understanding of what the actual pathology is happening in the patient and how is the natural course of the disease or how it will respond to various therapies like anti-VEGF injections. And so it is helpful in both, not just retinal, but also retinochoroidal disorders. And it is greatly enhancing our management of retinal patients. Thank you. Thank you very much. I'll be happy to take any questions if you have.
Thank you so much. Thank you, sir, for the comprehensive and nice presentation.
I hope you could get something out of the various images I showed you, some diagnosis and the utility of OCT and the newer techniques.
Yes, sir, absolutely, sir. Sir, there will be question answer round in panel discussion. We will move our on next talk.
Questions.
I'm sorry, but can you take the questions right now? So I might not be able to stay for the end.
Okay, sir. There are no questions from the delegates at present. Thank you. Thank you, sir.
Thank
for
you.
the nice presentation and nice explanation.
Thank you for inviting me. Thank you very much.
Now I request the honor of presence of Dr. Manuel Angel in the event. Dr. Manuel Angel has done his MD degree from Universidad Autónoma de Guadalajara, Mexico. He did his residencies and also his fellowship in retina from Mexican Society Security Institute, National Medical Center, Siglo 21, Mexico. He will be giving a talk on fundus fluorescein angiography, FFA, versus fundus autofluorescence, FA. We welcome you, sir.
Hi, I'm Dr. Manuel Alcantara from Mexico, and I would like to thank to the Optometry Students Association from IIMS. Special thanks to Raul for the invitation to this great event. So I'm going to talk about fundamentals of imaging, fundus autofluorescence versus fluorescein angiography, and let's start with fundus autofluorescence. FAF or AF is a novel, non-invasive imaging procedure that often yields abnormalities that are invisible to ophthalmoscopy and standard color fundus photography. FAF is likely due to lipofuscin, the pigment found in retinal cells, especially RPE cells. So the signal intensity of FAF images depend on the concentration of lipofuscin and to a smaller degree other fluorophores. The normal RPE yields a slightly granular gray fluorescence glow in contrast to the optic disc and retinal blood vessels, which appear black, as we can see here in these images. So there are two types of autofluorescence: autofluorescence of short wavelengths and autofluorescence of long wavelengths, near infrared spectrum. So when we could talk about autofluorescence of short wavelengths, to the ability of the retina to emit light in the spectrum between 500 and 7500 nanometers, and when stimulated by lengths of around 450 to 1500 nanometers. That is called shortwave. This is done through the natural fluorophores of the retina, such as lipofuscin. So lipofuscin is a natural degradation product. Is the result of phagocytosis and digestion of outer segment of photoreceptors, which contain lipids, proteins, and fluorophores. The reflectivity will depend on the quantity and the distribution of the fluorophores present in lipofuscin. As we can see here, there is melanin, lipofuscin, melanin, lipofuscin that are stimulated by light. When we talk about the long wavelength fluorescence, it emits above 800 nanometers when stimulates by wavelengths of 70-87 nanometers. In this case, melanin is found in RP cells, more so in the macula. Currently, most commercial angiographers work in the short wavelength, so they will facilitate the visualization of lipofuscin. Once more, lipofuscin is located in the RPE and is a dominant macular fluorophore that absorbs blue light. So, excitation and emission spectra of common retinal imaging modalities we can see here, and we can see fluorescein angiography and fundus autofluorescence operate in blue-green spectra of visible light, while in lucianine green angiography utilizes the infrared spectra. So in this case, for example, the crystalline lens, a common source of interference, has emission peaks similar to lipofuscin. Those are the machines now available on the market for the take of the images. And let's start with the interpretation of autofluorescence imaging. So we have the term hypoautofluorescence when the accumulation of lipofuscin results in increased autofluorescence and suggests RPE dysfunction or stress. This results in areas of bright white signal, as we can see here. Those are perilesional hyperautofluorescence patterns in geographic atrophy in age-related macular degeneration. So geographic atrophy can be classified based on perilesional phenotypic fundus autofluorescence patterns, which represent areas of ongoing RP cells dense function, vertical superimposed RP cells, and variable progression to atrophy. And we have the term hypoautofluorescence, when there is a decrease of fundus autofluorescence that suggests loss of RP cells as well as possibly photoreceptors. And this correlates to the reduced levels of lipofuscin. This results in areas of dark gray or black synapse. So this is a fundus autofluorescence of Stargardt disease. Well, fundus photography and clinical examination may have a non-specific findings. Fundus autofluorescence show hyperautofluorescence flecks with peripapular sparring, characteristic of this disease. The flecks surround hypoautofluorescent central macula, corresponding to significant chorioretinal atrophy. So we have two types of hypoautofluorescence. When we have light blockage, so artifact in vitreous of retinal, as we can see here, a patient with subhylar hemorrhage, we have a great area of hypoautofluorescence due to light blockage. And in this case, we have a patient with dry age-related macular degeneration. As we can see, as a halo of hypoautofluorescence that is due to RP atrophy. And then we have hyperautofluorescence. In this case, we have the bleaching effect of relapsing. Immediately after obtaining 30-degree fundus autofluorescence, the 50-degree fundus autofluorescence shows a discrete area of hyperreflective hyperautofluorescence corresponding to an area of bleached photoreceptors resulting from the first imaging acquisition. So this effect is called photobleaching. Then we have unmasking, hyperautofluorescence, when we have outer retinal loss in cases of posterior uveitis. And when we have subretinal deposits, as we can see here in vitelliform dystrophy, the accumulation of the lipofuscin at this level, it's going to be hyperautofluorescence and optic disc erosion. So those are causes of hyperautofluorescence. Increased RP lipofuscin, as we saw in lipofuscinopathies as a Stargardt disease and parent dystrophies, RP tear only in the retract border. Then we have retinal autofluorescent material like vitelliform dystrophies, central serous chorioretinopathy. When we have window defect, it is due to loss of luteal or photopigment, and other autofluorescent material like optic disc drusen and astrocytic hamartoma. And those are causes of hypoautofluorescence. So when we have reduced or absent RP lipofuscin, RP atrophy, the most common geographic atrophy, RP tear, reduced visual cycle, and when we have blockage from material anterior to the RP, media opacities, macular pigment, and intraretinal and all subretinal hemorrhage, fibrosis, and scar tissue. So fluorescence abnormalities have a mirror, that is vitamins, vascular infection, inflammatory, trauma, toxic, autoimmune, allergic, metabolic, high-red, neurodegenerative, endocrine, and semial stress. Those are causes of changes in the fundus autofluorescence. And the pathologies that are more common use now, fundus autofluorescence in combination in multimodal imaging, it's atrophic age-related macular degeneration, high-red chorioretinal dystrophies, Pachycori disease, and posterior uveitis. In this picture, we can see some of those diseases that can cause changes in fundus autofluorescence. we can see here geographic atrophy, central serous coronopathy, and multifocal polyps. So the fundus of the fluorescence in recent years has become an important tool in those cases where the clinical findings are not very clear. And then let's talk about fundus fluorescein angiography. And what is the purpose of this study? To highlight retinal and choroidal circulation to detect early vascular pathologies and confirm diagnosis. This is an image of the choroidal flush in early stages of the study. And how does it work? The characteristic of fluorescein is champagne derivative. The molecular weight is 376 kilodaltons, and it absorbs 465 and 490 nanometers and emits 520 and 530 nanometers. It binds to plasma proteins, especially albumin, and the expression is by kidney in the majority. So the fluorescence is the emission of light by a substance that has absorbed light or other electromagnetic radiation. So the characteristic and uses of fluorescein angiography is to show the flow characteristic of blood vessels. It records fine details of the pigment epithelium and retinal circulation that may not be otherwise visible, and it provides a clear picture of the retinal vessels and assessment of their functional integrity, normally impermeable. The indications of FA is a chorioretinal vascular disease like diabetic retinopathy and wet age-related macular degeneration. To assess intermediate or posterior uveitis, macular disease like central serous chorioretinopathy, planning of retinal laser procedures, unexplained visual loss, choroidal melanoma, and hereditary retinal dystrophies. This is important, the side effects of fundus angiography, fluorescein angiography. So the side effects are extravasation and local tissue necrosis, inadvertent arterial injection, nausea, and vomiting. But the most important and most common, it's a temporary decoloration of skin or hair and allergic reaction that can cause anaphylaxis. So the contraindications, it's an absolute contraindication to use fluorescein angiography when we have allergy in the past, as well as patients with renal failure, pregnancy, asthma, and cardiac disease. And this is the sequence of the procedure where we have the passage of the dye after injection. 10 to 15 seconds, the dye is through the short posterior ciliary arteries, and it starts the choroidal flush, the optic nerve head, and ciliary artery. 11 to 18 seconds, it starts the retinal circulation, arteries, capillaries, and veins. 20 to 25 seconds, it starts juxtafoveal and perifoveal capillaries, and the maximal fluorescence around the fats. So the best time for peak phase imaging is between these seconds, 20 to 25. At the 30 second is the first passage complete and the recirculation starts. And after 10 minutes, the total disappearance of the dye of the retinal vasculature. And the interpretation of the findings of fluorescein angiography, we have the term hypofluorescence, where we can see here, and there were two types of hypofluorescence, by blockage and by vascular filling defects. In this case of a patient with subhyalid hemorrhage, we have hypofluorescence image by blockage media opacity. And in this case of the patient with vasculitis, we have hypofluorescence due to vascular filling defect for capillary non-perfusion. In case of hyperfluorescence, we have like abnormal vessels in early stages like angiomas, tumors. We have leakage in cases of neovascular membranes or phlebitis, and we have pooling in this case of central serous chorioretinopathy, the accumulation of the dye. And then we have stain in cases of Fisk drusen, in this case of a chorioretinal scar due to a choroidal rupture. So I hope it helps you. I think those stories help us in the study of disease population in the era of multimodal imaging. So thank you very much. I hope you all okay in these pandemic times. And when we pass all of these, we are waiting for you with open arms here in Mexico City. This is Paseo de la Reforma, MIG Avenue in Mexico City. And those are my email and my Instagram account. So thank you very much and see you soon.
Thank you very much, sir, for such an amazing and nice talk. The talk was fun from Hole of Professor Monica Chaudhary in the session of low vision is being continued here. So it's my pleasure to invite Professor Monica Chaudhary for her talk to deliver her talk on future of low vision management. She is presently working as a director at Shushanti School of Health Sciences. She has an experience of more than 3 decades as academic and clinical experience. She also served at All India Institute of Medical Science. Yeah, I'm continuing. She had an academic experience with the school, IGNOU University and Amity University. She has been awarded Seshri Award by Delhi Citizen Forum and Australian Leadership Fellowship Award in 2012 and also got ICAL Contact Lens Educator of the Year Award in UK in 2015. It's over to you, ma'am.
Thank you so much. I'm apologizing initially to everybody for being late in this session because there was some commitment due to which I got late. And of course, thank you to the association. Are you all seeing my screen? Is everybody?
Yes, ma'am. Yes, ma'am. It's
yes. Thank you so
yes,
much. And I mean, one of the best things I would say, I would appreciate before I begin my talk, the Students Association, who's actually been doing a wonderful job. There is, I think, no other place other than AIIMS where students have been so actively involved and organizing such a wonderful show. And I myself identify myself as a part of AIIMS because I graduated from AIIMS, I'm its alumni, and I took my retirement from there, following which I had stints of academic and other involvements in other universities also. So next 12 minutes, I'm going to just be talking about few things which are going to be probably changing your attitude in low vision, because I feel most of us have not understood what low vision is. It's simply because I see that whenever we are talking about a low vision eye exam, most of it is happening in the clinic, where all of us in our mind are fixed at the thought of the visual acuity charts. And we talk about 618, 624, 660 and these kind of things, or N18, N10. And we always consider this as our benchmark of 6x6 or 20x20 vision. But low vision assessment, truly speaking, is not 6x60 or 6x6. we have to understand the functional abilities of this patient. This is low vision. Had I to do a real low vision eye exam and prescription, I would have done it right in his house where he wants to work in the kitchen, or he wants to do his personal grooming, or a student going right there into the classroom and doing a low vision management for him. So before understanding or reading through the books, I would suggest each one of the audience here that please understand low vision means understanding the disability and the needs of the patient. For all of us who deal with low vision patients, it's hardly seen that any one of us would be really working on the perimetry or the field effects of this patient. So there are grossly two field effects. One is the peripheral field loss, and the other is a central field loss. Then there is overall blurring or isolated scotomas. So one needs to understand one thing, that you are dealing with a low vision patient, a visually impaired patient. On top of that, most of the disorders are going to come across these kind of peripheral or central field losses. So understand, considering whatever residual vision the patient has, what is his difficulty in near tasks, his day-to-day activities, is he independent, can he communicate well, can he be employed? This is what you all have to find out and work on. And many times when we are prescribing these, or we are talking to our patients and measuring the vision, we are visual acuity. We are only considering a black and white Snellen's chart or these Logmar charts. But the life is not like that. The real life scenario is multicolored with different shades and hues of grays. So it is the contrast acuity and the glare acuity which should be rather enhanced if you really want to work on the residual vision. So if you do not have a contrast acuity chart or a glare acuity meter, it's fine. But you can understand by the clues the patient having these problems, and you need to enhance the quality of visual acuity by enhancing the contrast and glares. So far, what have we seen? So my talk here was just to make you understand what's coming new into this world. In fact, my books which I've written in low vision, it totally, I feel, is getting outdated. It needs to be revised. Lot more things have changed in terms of low vision devices. We are still talking of those hand magnifiers, stand magnifiers, or different non-optical devices, but that's not the scenario now. The world has digitalized, and that's what we see each other today. Sitting in my home on a Sunday afternoon, I'm attending a conference. I'm being part of it where I'm doing it. The whole world has turned digital, and so has the low vision management also. We are moving into electronic devices. We are moving into augmented reality devices, by virtual devices, and lot more things which are beyond those optical devices. So those optical devices may be reserved in Indian population for somebody who cannot afford, because the cost of those devices is a little higher. But as far as possible, move beyond those optical devices now. Even in terms of distance vision telescopes, Ocutech or the bioptic telescope is my favorite. It's much sleeker, it's much advanced, and it's much more acceptable to the patient than those monocular handheld telescopes. Then we're talking about optical devices again. We realize the disadvantages. The optical devices, higher the magnification, smaller the field of view. You're bending close to it. You have to go smaller by smaller alphabets. The aberrations and the quality of that optics of the lens matters a lot. So what's come in? We all have been seeing this for years now in our country. These are these portable video magnifiers. They're like a mobile phone. You have 4-inch, you have 5-inch, you have 7-inch screens where you can just charge it like a mobile phone, put it over the reading text, and you can even change the color contrasts. You can change from the letters to be white over black. You can change it from blue to yellow to black, or yellow over black. And you know, it sounds that these changing colors, what does it mean? It means a lot to a low vision patient. Just let them play with those, and you'll find the patient's comfort in reading with these video magnifiers which change the colors. And you can actually automatically zoom in, zoom out, 4x, 16x, 40x. That's the kind of magnification you can play with these video magnifiers. Suppose the patient has a variable visual acuity. It works wonderfully. You can actually then, the patient can just zoom up, zoom in, depending upon the kind of font and the visual acuity. A single device can work for any power. You don't have to do those typical formulas for magnification and calculation. And this looks so much acceptable to the patient. And I would say they're not too expensive. However, make in India, we really need devices to be made in India. And I don't think it's going to be as expensive as what we import them nowadays. There are a lot more devices in the market where you have a student who wants to read these kind of magnifiers, which can project it on their laptops and they can see through it. You know, these devices, look at the child who's visually impaired. His whole career, his life, his growth depends upon that education. And they're only worried how I can see through it. Using these telescopes, focusing a small portion in the blackboard, reading and copying is not practical. They're electronic devices now. Advise these. Let them be promoting this, and they can work on the laptop with the whole blackboard being put in front of these patients. There are text-to-speech synthesizers. Even in our phone nowadays, we talk and we type. It's enough of WhatsApp, typing whatever we do, or even in these children. They can read through it. And these are inbuilt softwares. You don't need special softwares for this. Prescribing a glare cutting enhancement is something which is very, very important for any child, any patient to be done. And last two slides are going to be the videos of showing you the devices which are now latest for a peripheral field loss patient and a central field loss patient. This is developed by Oxite, which is the spin-out of Oxford University, and they have worked on partially sighted people, Stephen Hicks, the scientist, and others. And I had been part of their prototype trials also. And I'm going to run through the video of the trials when these patients who are using these glasses have been.
What I could see 20, 30 years ago, well, I never imagined that I'd be able to see that again.
So this is the patient when they were actually using this device in a peripheral field loss. See the reactions. So this is the prototype trials. And this is actually seeing what the patient is seeing.
Yeah. That's quite wow. Nice. Wow, that is really impressive. It is actually quite amazing to get so much more detail on their face. Without my glasses, I'm looking at kind of pink blobs, really.
I've just zoomed backwards. Now that's much, much better. I'm wondering whether it's the sort of thing I could wear walking into the cinema. It sounds silly to think that, you know, a registered blind person would even attempt going to a cinema.
can you see more now in this colour mode than you can normally?
Oh, different one.
I just love it. It's amazing to be here today and see what I saw years ago is just life-changing.
So that's how it is. It's life-changing for many patients. We may just think, imagine these patients were tubular field, 5 degree, 7 degree, 10 degree field. And for us, it may be 6/60 maximum improvement, but it's life changer for them. The next video, which is the last slide, is the latest device which they have developed for central field loss patients. And this is how Onyx, that was Prism and Crystal slide. So this is the real trial which has been done on a patient. And this is the prototype. It's not as big as this, the final device.
I can close my eye and I can see your lovely face, your tat and your beard. Even on my right eye, and I can't look, and I can see your teeth. It just flashing out of it. It's nowhere near as good as my eyes. Wow, all I can say is fucking wow. This is absolutely wow. I can see why that guy on Facebook was absolutely, he was just blown away. Oh my goodness. Fantastic. See your face clearly. I see your face clearly. Absolutely. Divorced now. I can't find the face.
Don't have one of those. The diamond child. I can't afford a divorce.
Absolutely incredible. I've not seen a face like that for a long time. Absolutely amazing. I can't tell you if I feel bad.
You'll see how tidy your study is.
I'm just so thrilled to be able to see a face again.
Fantastic. I'm really pleased. And if that's the kind of reception you're getting from the prototype, then you know it's really exciting what it's done.
Yes.
Ordering for the bank.
Oh gosh, yes. Yes. Absolutely fantastic. I'm just absolutely bowled over. I am absolutely bowled over.
Okay, so I would like to say that, you see, these are the reactions. This device was launched in UK and India simultaneously. Unfortunately, last year, March, we were supposed to have this device with us. But the very same time this COVID and the disruption happened and the lockdown came in, and the device, we couldn't work on the patients beyond that. But it has given so many examples in UK and has been a real successful device. So you see, seeing a face even means a lot for a patient. It is a life changer for many. So that's what we have to understand and prescribe. So we have this Center of Sight Enhancement, and we take up many courses and other things. If anybody is interested, we can really work on it. So thank you so much. Thank you, and congratulations to the Student Association for a wonderful show. And I can see my teacher there now, Dr. Titial, in the screen. Thank you so much, sir, for being here. Thank you. And over to you, sir.
Thank you very much, ma'am. Thanks for your amazing and wonderful talk. We are very pleased to have a talk of you. Now, I don't think that we have a queries from the audience side. So we are ending the session here. Going to the next speaker. Thank you, ma'am.
Thank you, Vite. God bless you.
Good afternoon, everyone. I am Jivesh Singh Kutial from Optometry Students Association. The next feature talk will be on the topic Optometry in 21st Century by Professor Jeevan Singh Titial. Professor Jeevan Singh Titial is Professor and Head of Cornea, Cataract and Refractive Services, RP Center, AIIMS, New Delhi, and he has more than 400 publications including 280 PubMed Index publications, 4 textbooks, 52 book chapters. He has presented international and national conferences more than 200 times and has presented more than 100 live surgical demonstrations, more than 1,000 lectures, and he's the first Indian to perform live surgery in ASCRS, USA. He's a pioneer in modern day cataract, corneal, and refractive surgery in the country. He has done exemplary work in IOCT guided anterior segment surgery. He has been conferred with Padma Shri for outstanding contribution in the field of medicine ophthalmology by President of India in 2014. The Senior Achievement Awards from American Academy of Ophthalmology, and he has received Achievement Award by Asia Pacific Academy of Ophthalmology and Certified Educators Award by Asia Pacific Association of Cataract and Refractive Surgeons. He has presented over 30 orations and keynote addresses. He has been given Distinguished Teachers Award by Delhi Ophthalmological Society and Deccan Ophthalmic Association. He has presented a TEDx talk on my journey in keratoplasty and has over 20 Best Paper, Best Poster, and Best Video awards, and international and national. He is the current chairman of National Eye Bank and past president and general secretary of Delhi Ophthalmological Society, and the current president of Indian Society of Keratorefractive Surgeons. Back to you, sir. Sir, are you there?
Okay. Thank you very much, Jivesh, for such a nice introduction. And first of all, like to thank entire team, organizing team for invitation, and hope that this conference goes in the same way. In last 5 years, you have done wonderful conferences, and I understand your gatherings is in a huge number. And this year also being a hybrid, I am pretty sure it will be a success for all of you. So my talk today is not really based on any scientific or educational lecture. So this is basically, I thought, let me share some of my thoughts on how should optometry be there in our country for today, for tomorrow, because optometry is the life changer in terms of a vision impairment, which is so prevalent across the world nowadays. From my side, there's no financial disclosure. As you all know, I work in All India Institute of Medical Sciences, which is the premier institute of this country, and heading the Department of Cornea Cataract in the apex institution of ophthalmic practice of this country, that is Dr. Rajendra Prasad Center for Ophthalmic Sciences. You all know the history and evolution of vision correction by spectacles. It started way back in 14th century, where first handheld glasses were used. In 18th century, you had spectacles and use of bifocals for presbyopic people. In early 19th century, that is 1910, first university course of optometry started in University of Columbia. And you'll be surprised, just 100 years back, 1921, optometry was recognized as a specific separate discipline in the United States. So in fact, your conference today is after 100 years of recognition of this particular specialty in USA. Who is an optometrist? So you all know, you people practice optometry. Basically, you are the primary healthcare practitioner of the eye and visual system, who would provide a very comprehensive eye and vision care that includes refraction, dispensing glasses for different reasons, detection, diagnosis, and co-management of disorders, disease of the eye, and more importantly, rehabilitation of patients who have these vision-related problems. The last word is very, very important, rehabilitation. Whichever patient comes to us, let it be with any sort of ophthalmic problem, they come for getting their vision correction. If we can correct the vision, they can be rehabilitated in their daily activities. Therefore, vision and rehabilitation is combined together, is going to make not only the vision improvement, but the life would also be improved as we talk about improving the quality of life. So vision is one important system which will definitely change the life of a person by improving their quality. So how did things would have changed in last so many centuries? We talk about 21st century here. Dispensing glasses, yes, it is an important part of correction of vision. But see this chart here, which I have just thought about. What all areas optometry would be a definitive, comprehensive care giving part of a team of people, because whenever we talk about giving a treatment, giving a solution to a patient with symptoms, signs, and problems, is always a teamwork. A teamwork is basically with the people who are in the same grounds or same background of that particular field of expertise. To see how we have evolved, right, from looking into a refraction or contact lenses, which is a major part in the vision correction of our patients. We look into a large area of orthoptic workup. It's not only the orthoptics, which includes the binocular vision, which includes the squint workup, not only the simple squint, we are looking for paralytic squints, the subsequently their assessment after a correction, which is so important. So apart from that, this is one area which is very, very important, low vision aids and rehabilitation. You just saw Professor Monica talking about various devices. Now we have such a devices which can make a blind person see. So you have to be a part of these innovations, which is going to be there for the 21st century. And other important areas which you people have been a part of system is refractive surgery workflow, because no surgery can be done without the help of optometrists or people who are doing assessment of these patients. The refractive workup has not only the refraction part of it. We are not looking for a manifest refraction of these patients. We are looking for a entire ophthalmic analysis, right from a lid margin to tear film to corneal topography assessment to a refractive analysis, looking for a posterior segment, retina, macula of these cases. And most importantly, you would be checking the wavefront aberration of these patients. So imagine what was the initial feature, just giving the glasses. Now we are looking for a correction, not only the visual impairment because of refractive error, we are looking for a distortion of vision by aberrations. Those are normally higher order aberrations, and those have to be picked up and subsequently can be corrected. Now, not only by refractive surgery, by laser refractive surgery, people are working with the contact lenses and spectacles, which can give you wavefront corrections also. So that is what we are looking for, improving visual outcome for these patients. Other integral part of you people being there is patients suffering from a corneal disorders, cataract, glaucoma, retina, all other ophthalmic scenarios. You are the part of a system to make appropriate initial workup, appropriate investigations, then getting into a diagnosis and helping the ultimate treatment of these patients. So we are looking for a basic outpatient department analysis for these patients, right from the vision to corrections. Then other important part which you people have been part of is getting into the surgical aspects. So you people have been posted in ophthalmic operation theaters, which can be interventional areas like fluorescein angiography or a laser refractive procedures, or areas where we give a lot of emergency treatments, or a main surgical OR also. So you have to understand what is the basic ways to sterilize the instruments, sterilize the operation theater, disinfect the instruments which are there, and most importantly, look for a waste disposal, which is such an important part nowadays in any area of work. Then you have to learn what are the basic principles of operation theater, and more importantly, you can devise, you can check the basic requirements of patients getting inside the OT or before preparation, after they come out, by having a various checklist and making sure no error happens in the surgical scenario of that particular patient. So these are very, very comprehensive assessment you people will be doing to get a comprehensive outcome for all patients. Why optometry is a global need nowadays? Yes, we know that a large number of patients will be suffering from a visual impairment. This is a WHO estimate, 285 million people will be suffering from a visual impairment, and almost around 42 or 50% of cases will have uncorrected distance refractive error. That means these people are deprived of some sort of spectacle corrections, therefore they could be improved. And this is a large significant chunk. And almost more than 500 million people are now presbyopic. And as I understand today, we do have a large number of people with presbyopia. We do not have a significant surgical modalities to correct presbyopia. Therefore, spectacles, good spectacles and contact lenses are the major option for these people, which are a significantly large number of our population. So that has to be taken care of. Therefore, optometry, the course, the people who graduate from optometry or subsequently they get into taking care of a community have a huge role in taking care of a largest population of people coming with this asymptomatic disease, which is a refractive error. So if you see this particular chart, as I said, uncorrected refractive error and the cataract, two important things which can constitute almost 70 to 80% of people would require optometry help. So that's a very, very significant chunk in these cases. What about our country, India? This is not a recent survey, but yes, it is still applicable. Almost 456 million people in India require vision correction. So that's a huge number. And around 37 million people are children, that is less than 16 years. You can understand if you don't give a good refractive correction, how many children will become amblyopic, how many people would subsequently grow up to the age where they go for jobs and they would know that their vision is not appropriate for that particular job. So this is a very important area we have to look after, and the children should not suffer because of uncorrected refractive error. So around 133 million people, including 11 million children, are blind because of visual impairment. As I talked about, it may be amblyopia, it may be anisotropia, it can be a cataract, glaucoma, so many things which can contribute into glaucoma, refractive error in the pediatric patients. In this scenario, there is a definite imbalance between the rural and urban India scenario, not only in optometric field, in all medical fields, there's a definite different distribution of manpower to serve these communities. Therefore, we are looking for a primary healthcare in professionals in urban area. And in the rural India, you will be a secondary level resource limit people to take care of those areas. And this has to be, this bridge has to be gapped very, very fast. So this is a 2012 study, 2010 study published in IGO by Dr. D'Souza. They have labeled, there are around 9,000 four-year trained optometrists available in India. The target at that time was 11,600 people required to tackle this problem of huge manpower requirement to take care of this community refractive error problem. If we analyze the availability of people, if we see the requirement of optometrists in the country is maybe at least 2 to 4 folds to an ophthalmologist. At present, requirement for ophthalmologists in our country as per the population is almost, there should be a 1 lakh ophthalmologists practicing in this country. In that regard, we require at least 2 to 4 lakh qualified optometrists to serve this country in terms of population wise. So you can imagine how much is a gap in producing the skilled optometrists for our country. This is what qualification would be. People would graduate with a 4-year degree, or they do a postgraduate degree, which is for 2 years after graduations. And it is basically those university which is recognized by UGC as per the 1956 Act should have a proper uniform courses to give well qualified optometrists for this country. So you have three steps of looking into education point of view. Many of you do a B.Optom, then go for a master's, or you can do PhD subsequently. And bachelor degree is, I think, is sufficient enough to provide the care for a people, basic care. And masters will give you opportunity either serve as a teacher or do a research, or improve the skilled manpower for a country. And holds true for a PhD, doing a vision science research, which will further enhance the knowledge and the implementation of research into a betterment of our society and public. This is what all you people have been doing. What should you be performing? That is well known. Apart from doing a basic eye examination, you should be doing a proper prescription of glasses, contact lenses, low vision aids, which is such an important part, and most importantly, the binocular vision assessment and giving the treatment for people having a orthoptic difficulties is a major part during your bachelor's degree. Other area which I've been talking about is your role in iBanking system, where everybody can be a counselor, motivator for improving donations, because we have a large number of people requiring corneal transplant surgeries, and the backlog is significantly large enough which cannot be tackled by the available resources nowadays. And you people can be a good counselor for these cases. This is what chart shows. You can do all these. Most importantly, you should understand what is the morbidity in that particular case. What does a patient require, why the patient has come to hospital or a center or a optometric dispensing area, and accordingly manage these cases. If needed, these people can be referred to a right areas, right places, right institutions, so they can get a good treatment for their ailment. And sometimes managing the primary care area like PSC and area district hospital is another important area as such. Master's degree, you people would be graduating to higher areas. You can say in 21st century, every section of optometry has become a subspecialty. So people have to ultimately graduate to these areas. You can be working in a research area, you can be working in a orthoptic area, or you can just be doing a refractive areas. So every subspecialty have become a major areas for you people. And for that, you require additional skills, which can be achieved by doing a post-graduation or a PhD. For academic, teaching optometry people is another way of looking. Research, clinical instructors, or you can do a higher center for giving a specialized contact lenses, vision therapies like looking for ortho-K to correct myopia or early keratoconus. So these are specialized areas where you people are going to be of real help for a community as such. Then you can be a part of industry, develop professional manpowers, have contribution in developing economy of our country. Occupation wise, I know that it is a unit group optometrists would be labeled as a skill level 4 category, where you're looking for various opportunities. So this is a small chart where I think this is my understanding, but you people have much better knowledge where all you can be have require your job opportunity wise. I look into areas where you can be a real help, like eye care hospital and institutions. You can be a part in the educational sector, as I talked about masters and PhD. Then you can work in various areas like private practice, optical chains, and more importantly, public health is the area which is the, I think, future of healthcare people, because that is where the entire economy, industry, the government sector is going to move in the public areas, and ultimately look for a corporate sector or a scientific research which can be done. Some sort of ethics should be there in any medical practice, including optometry also. Always look for doing good for people, minimize harm for people coming to you. Once you think of other person, you are always going to be a better person yourself and never going to put a harm to other person if you think the other person requires your help. Respect the choice and decision and the makeup for other person. The person coming to you may have a different thoughts. You might counsel him, but ultimately you have to respect what he wants. Always make sure you do a justice to your resources, never harm people. And confidentiality is one important thing in medical practice. You should always respect the person's confidentiality. Never disclose things which are not required for that particular patient. So that is a privacy is very, very important in the medical services. Lot of ethics, lot of medical legal aspects are attached to this. Then standing up for your people, your society, your friend should be a teaching for all of us. And mutual respect. It's only not only for your colleagues for respect, it's for a respect for people coming to you. It may be patient, relatives, and most importantly, which I always talk about, is respecting the institution where you're working. The institution where you have gained your initial, never forget your institution, which is given you the starting point for your journey. Then ultimately, counseling of patients is the major factor nowadays. The surgeons may not have time, the clinician may not have enough time to counsel. So who are going to do counseling? It is the most important point in terms of decreasing patients' complaints, patients' problems, decreasing the post rehabilitation chair time for you. If you do a pre-surgery or pre-treatment counseling, the post-op or a post-treatment counseling period decreases. So you're looking for areas which I personally feel important for us, apart from the dispensing contact lenses for a specialized regions in cataract surgery, which has become a very, very important area, especially with premium IOLs, where do a multifocal toric lenses, laser vision surgeries for a cataract. So there, the role is very, very important for assessing these patients. The counseling is not only speaking to patient, it is understanding the requirement of the patient. Then you have to do a proper investigation, proper checkup for these patients, then give advice as per the records you have in your own hand. Then in refractive surgery, I think major game changer is optometry in terms of refractive surgery concern, especially looking for all the modern day laser, femtosecond laser refractive procedures. The counseling part is very, very important. Other important thing I talked about is a public health program. You can be part of an NPCV program or a Vision 2020 programs. Spread the awareness of a visual impairment, improving quality of vision in a right from the birth of child to the person who's become a old person also, because everybody requires sight. That is right to sight, and that can be provided by us. So as I said, awareness program, occupational academic optometrists can join various colleges, schools. Then you can be a community optometrist looking after community services. And most importantly, young people like you should always have a research in mind. Take out something which can change the life of an entire optometry in our society. So this is what the role in Composite. I've talked about everything, right from scientists to opticians can be covered by you. The future, I think there should be a uniformity optometric courses in India. Earlier, we had 1 year, we had 2 year, we had 3 year, 4 year. So these has to be uniformly made. Maybe the optometry council has to look after this and make sure you have a standard teaching program, not only for taking classes, having a clinical apprentice in a good institution where you have access to various devices, investigative modalities, and patients. Because without patients, you can't train yourself. Then we have to build up resources, infrastructures to improve the requirement of trained people in the country. And most importantly, there should be a very good career options for all you young people, so that there should be incentive to people to come into this field. Then look for other areas, ocular pathology, especially population remote. You can have especially now we have internet services across the world. You can approach people within a second. You can counsel them. You can advise them, which has become a very important aspect in a COVID time also. Research, develop better things. So this was my initial slide. I had come to that in 21st century. These are 6 or 7 options we have. So all these comprehensively going to give us few things. That is, we have to serve the community and our society, because they are the one who are going to come to us for their problems, their difficulties. That has to be solved by us and make their life better. And second important part, as I said, we are not in the number in terms of required to serve the society. So we have to build up the infrastructure of country. And infrastructure is built not only by buildings, by a skilled man power. So therefore, we need to have more teachers, more educators, more facilities to build up our optometrist area, so that we can go together and serve our community. And lastly, never forget research. Research makes the thing better for future. So unless research would have been there, we would have never reached in this position of such a high level, high super specialized care in the ophthalmic area. That's because of research. And it is only the mind which can think of research and application to appropriate way to get something new for our community is the final goal for research. So I would again like to congratulate all of you, especially the Student Association of AIMS and your team of explorers for organizing this beautiful conference. And thank you for inviting me. If you look into this last paragraph, which I picked up, recently the World Optometrist topped a list of most Googled science, technology, engineering, at mathematics worldwide. So this is a branch which is fascinating for public, and they are the actual public servers. And thank you and wish you all the best.
I would like to thank you, sir, for taking out time from your busy schedule and for presenting such a wonderful and illustrative talk on optometry in 21st century. Thank you, sir.
Okay, thank you. Thank you. I wish you all the best.
Thank you. There will be a short break right now. Thereafter, we will start with quiz competition. All the participants are requested to enter Hall B to enter quiz contest. So there will be a short break right now, and after some time, we will be back with a quiz competition. All of you are requested to enter Hall B to enter the quiz contest. Thank you.
A very warm and pleasant good afternoon to one and all. This is Darshita Sroi, Vice President of Optometry Students Association. I am extremely privileged to address Optom Nilesh Thete sir. He is postgraduate in optometry with over 18 years of teaching experience. He has 3 years of corporate experience and over 5 years of experience in managing educational programs globally. He is a fellow of International Association of Contact Lens Educators, British Contact Lens Association, and American Academy of Optometry. He has been an inspiration for all of us and has given us a path to follow to make our dreams come true. So please apprise us about the future prospects in optometry.
Hi Darshita, can you hear me?
Yes, sir.
Awesome. And who all are there? How many audience? How many attendees are there? Because I don't get to see anything. I just know there are a few people
Yes,
here in
sir.
the
You can
room,
only watch the panelists.
right?
We have 600 plus attendees currently.
Awesome. And where are these people?
These are all connected online with us, sir.
And they're from all over India?
All over India. Yes, sir.
Wonderful. And just to know a little bit more, so do we have a lot of students attending this particular
Yes, sir.
event?
Yes, sir. Yes, sir.
Good. And is it the last session or do we have anything after this also?
No, sir. This would be the last.
Oh, so shall I say you saved the best for the last?
Yes.
I'm just kidding, but I just hope that the program so far went on really well, and I'm sure because AIMS Optometry Explorer has been a landmark event actually, and I really appreciate the way the students organize everything and the alumni support them, and there's a team which works on this, and all the seniors and all the alumni help the young talent. It is a very good example of how you can achieve great things when you work together. So I always wish you luck, and I want to also congratulate to this year's organizing team for organizing this fantastic event. So you and the entire team, first of all, my sincere, genuine congratulations to all of you.
Thank you so much,
Before I
sir.
even proceed. So I understand we have around 500-600 people who are attending this event, and this is a 1-hour event.
Yes, sir.
Yeah, and I have a few slides which I will take you guys through, and those who have questions, I understand they will type the question in the chat, and then we can have some interaction going forward, right?
Yes, sir.
Okay, so just to set the tone again, I have been a part of each AOE since the inception. So I'm
Yes.
really honored and privileged to be, a part of this particular event. So I call myself as a lucky mascot for this event, who's not an alumni of AIMS, but still associated with this event for such a long time.
So we are grateful to you for always joining us and
No, no.
supporting us in this
No.
venture.
Pleasure is all mine, trust me. So let me just share my slides and then
Yes, sir, sure.
we can get started. Darshita, are you going to be here all the time?
Yes, sir.
Okay, so what I'll do is you can keep yourself unmuted because I may have a few questions to ask, just to get the feeling, because otherwise I don't get to interact with the audience. So at least I can ask
Okay,
you
sir.
questions whether I'm audible, I'm
Sure,
visible,
sir.
and things like that. So can you see my slide first of all?
Yes, sir.
Awesome. Let me just try something different. What do you see right now?
I'm watching a slide of Nirvan, and then the second slide is career options in optometry.
Okay, good. So let me just go back to my previous slide. Okay, now just one slide.
Yes, sir.
Wonderful. So let's get started. So as I said, I'll just take you through a few slides first, and then we can have a Q&A and interaction going forward, right? So
Sure.
this entire session is about career options in optometry, and I don't consider myself to be probably the ideal person to talk about this. However, having tried a few things in the field of optometry, I have some experience. I have learned a few things, some insight during my course, and I've also seen a lot of students excelling in the field of optometry. So I can probably share my experience and whatever insights I have got from my almost 25 years of experience now, so silver jubilee of experience in optometry. So first of all, let me congratulate all of you who are attending this session, who have taken optometry as a career, who have chosen optometry as a career. I want to congratulate you. You are in a noble profession. You are in a primary healthcare profession. You are in a profession which can directly change people's lives. And I want each one of you to take and consider optometry that way. It's not just a profession which will, pay your bills. It is something with which you're going to change people's lives. And when you start thinking like that, you feel a lot better about yourselves, right? Now, even if you look at optometry as a career, there are definitely certain things I want you to understand. First of all, we say that generally we get more than 100% placement. What do you mean? This means that there are many optometrists who are doing one more than one role. For example, I can be a private practitioner at the same time I can be an academician, I can be a researcher, right? There are people who are academicians and they also have their own practice, uh, and so on. A private practitioner is also a key opinion leader and works with the industry as an educator. So there are many people who do multiple roles within optometry, and that's why I like to say that the placement is more than 100%. It's in demand. There's a lot of prestige and respect because we actually change people's lives by changing their vision, by giving their best possible vision. And that's why the patients actually respect us. There's a lot of prestige in that, right? And when you do that, when you change people's lives, when you enhance people's lifestyles, automatically you feel satisfied, you sleep well because you've done something good for the society. Also, I like to think about optometry as a creative profession because there are many things within optometry which you can try. You can try certain new things within optometry. Whether it's a private practice, you can consider a different stream of private practice, something like, let us say, sports vision, which may not be a very common practice, but someone who's interested in that and try to do something creatively in that particular arena, you can do that. So I like to think of it as a profession which allows scope for creativity. Now I just want some of you to answer this question. uh, while you're watching this, you can open another browser and type polev.com. Open another browser, internet browser, and type polev.com, polev.com. It will ask you to enter the room or name. Just write Nilesh Thite 258 in that. Type NILESH THITE 258. Once you type that, it might ask you nickname or something. Just skip that and directly you get a question like this. You'll see a question like this on your web browser. So why did you join optometry? And there are 5 options. I want you to pick your choice. You can write A, B, C, D, or E, whichever you want. I'll give you a few seconds to see if this works. If it doesn't work, never mind, we can still continue. So I'm going to wait for a few seconds. So you have to type polev.com in a new browser, then enter Nilesh Thite 258. After that, skip, and then you get a question, why did you join optometry? If you can do that, please go ahead and answer this question. Did you join because you had a family background? Did you join because you didn't have anything else to do? You could not get admission to the course of your choice, or you joined because your parents wanted you to do this, or you found this is something new, let me try this because this is interesting, this is new, or something else which is not mentioned here. I'm not seeing any answer, so I'm not sure if you're getting stuck here. Anyway, so if you can't answer here, you can actually type your answer in the chat window and we proceed. Uh, are they allowed to type their answers in the chat window, Darshita?
Yes, sir.
Okay, so can you see any answers typed there? Because I can't see.
No, sir.
Not yet? Okay.
Not yet.
No issues. So there are people who have joined optometry for different reasons, and we tried to understand this particular one, and we we actually presented a poster in American Academy 2015, and I just want to show a couple of interesting insights from that particular poster. So majority of the students who joined optometry, like more than 90%, they thought that they made a right decision by choosing optometry. And I really feel happy when I see this particular statistic. Most of them are happy that they joined optometry. And again, 85% of the students found the course interesting. To be very honest with you, when I joined optometry, I had no clue what optometry was all about. I joined because probably I did not know anything better than this. I did not find any other course as exciting or interesting, so I joined optometry. But the moment I joined optometry, the moment I started studying various subjects in optometry, it started getting more and more interesting, like optics, binocular vision, later on contact lenses and things like that. Very, very interesting. Even refraction, patient examination, all those things. And I think most people agree to that once we start seeing patients, it gets more and more exciting, right? So yeah, let's move further now. Scope of optometry, right? So I'm going to talk about what you can do after completing your optometric course. And we'll start with private practice and optical retail, because we've realized most of the optometrists, once they graduate, they do either of these two. They either join up on optical retail, someone else's practice, or they start their own practice. So I would like to see more and more entrepreneurs and private practitioners own private practice, independent personal private practice. To be able to do that, of course, you need to have good clinical knowledge, but as much as the clinical knowledge, you also need to have good knowledge of the business, and that you start getting when you start getting into the practice. Along with that, there has to be a little bit of risk taking ability. If you want to be playing very, very safe without any risk at all, then you may have to think twice before starting your own practice. You need to have a little bit of willingness to take risk. Now you can start your optical outlet. Along with that, you can start your optometry practice, and you can offer so many different things. It could be disease diagnosis and co-management. You can have your contact lens clinic, a low vision clinic, binocular vision, vision therapy, prosthetics, and something which is more uncommon, which is occupational optometry and sports vision. So all these things you can offer, and you can after starting your own private practice. Coming to retail industry, sometimes I've seen many students who just graduate and who say, I want to start my own practice, but before that, I want to gain a little bit of experience. Of course, there's nothing wrong with that. No harm in doing that at all. So you can join a retail industry, understand how it works, understand what the patients require, how to manage the inventory, how do you talk to the patient, um, you know, what makes patients buy a particular optical device, etc., etc. So you can join the retail industry. It could be a regional retail industry, it could be a national chain, and so on. You can start by working as a clinical optometrist, where your job is mainly to see patients, right? Also, you get involved in optical dispensing. There are other I would say avenues within the retail industry, which is store optometrists, where apart from managing the clinical practice, you manage the entire retail store. The responsibility of the entire business of the store will be on you, right? And as you climb up the order, instead of managing one store, if you are more experienced, you can manage the entire cluster, means a few stores instead of just one store, and then region, and probably at a national level also. Now along with that, you can become a trainer optometrist also, where you can train the staff, the optical staff who are non-optometrists, and also the optometrists who get on board and start and join the retail industry. So trainer optometrist is another avenue within the optical retail industry. The other common one and popular one, which is clinical and hospital-based practice, where you join a hospital as an optometrist. There are big tertiary hospitals. At the same time, there are, I would say, independent hospital also. You can work along with the ophthalmologist with that. as a consultant optometrist, and you could have your own, I would say, niche within the hospital practice as well. For example, in a hospital, you can be the contact lens consultant. You could be the one responsible and managing the contact lens department uh, of that particular hospital. You could do all the workup related to LASIK. You could be specialized in pediatric optometrists, like, binocular vision, vision therapy, etc. Low vision and rehab consultant. Ocularist, that's another area. Not too many people are doing that, but I think it is a very, very interesting domain within the clinical practice. And you could be a sports vision consultant as well, or occupational optometrist within that. Okay, now coming to corporate. Now, generally, when you look at a corporate person, you feel nicely dressed, wearing tie, suit, using a laptop. So it's like, the glamorous field within optometry. I generally call it as a Bollywood of optometry, right? So you can join the national and multinational companies. It could be optical lenses, contact lenses, instruments, any of these. Your main job is most of the optometrists who are working in corporate domain, they are working in either professional services or the training departments. So basically that you are hired there because of your optometry knowledge, and your main job is to train people about what is so good about your products, what is the science behind your product, and so on. So professional services is an important domain within the corporate optometry. Uh, there could be sales or marketing also. So some of you who are more interested in things outside optometry as well, where you can be involved in marketing and you can be involved in sales, where you are actually involved in selling of the product and not just talking about the science behind the product. So those who have a good business acumen and who are interested in doing that, there's definitely an opportunity. In fact, if you have optometry knowledge plus if you have business knowledge, that's a great combination. It's like having best of both the worlds, because you understand both elements, right? And if you have these two, then you are a very unique combination, and many industry would really want you on their side. Even within corporate, you can also work as a researcher. So there are optometrists who are working as researchers or scientists in development of products, etc. And even once the product is developed, they have to do some clinical trial and do the testing on patients as well. So that's another one. The commonest one, as I kept saying, is trainer and professional services, where you can be training your own team. जैसे काफी इंडस्ट्री में उनके खुद की सेल्स टीम होती है, दे हैव देयर ओन सेल्स टीम. सो एज अ professional services person, you have to train your own sales team about the technical features of your product and how they actually help the patients. So that's training your own team or internal team. External training means going and training the eye care practitioners about what is so special about your product. Why is it important for them to start dispensing your product, right? And that also comes, that's where we also come to medical messaging, where again, what is the science behind the product? Why should I dispense this particular contact lens? And to whom should I dispense this particular contact lens? What are the benefits of dispensing these contact lenses to my patients? This is something called as medical messaging. And nowadays, and not nowadays, the right way of medical messaging is using scientific evidence. So we need to look at what is the published data about one particular about the particular science or a particular product and how it performs well on certain patients. So instead of just saying, I feel this product is great, you need to show why you are saying this product is great, because it was tried on so many patients and so many patients got benefited. So that's called as scientific evidence, or you're talking based on published research, right? Coming to sales profile, those who have technical knowledge and those who also like business, who have good business acumen, who understand the selling part of it, the business part of it. And I mentioned earlier, it's a great combination to have, and there will be many industry who would be waiting for you to join them if you have understanding of both these sites. Coming to academia, one of my favorites, and I feel these are the people who actually create all the difference in the society, the teachers, the academicians, right? So you can join as an educator in academic institutions. Today, I think almost every institution requires at least a postgraduate, at least an MOptom, uh, to be able to teach undergraduate or BOptom students. If you are a PhD, it's wonderful. And I personally feel, and when I discuss with various institutions, it seems that it is becoming more and more important that you get your doctorate, you become a PhD, uh, to be continue as an academician in this particular domain, right? So you can start as an assistant lecturer and so on, and eventually you can head your own optometry institution. If you don't want to become a full-time lecturer, but you love teaching, the other option is you can have your other domain. For example, you can have your own clinic, and once or twice a week you can be associated with an institute and go there as a guest lecturer or a part-time faculty. If you don't want to do that, you can also offer your center as an externship center, because many institutes require their students to be sent to various optometry centers for hands-on experience, actual optometry experience, and you can offer your center as an externship center, right? Research, and I'm very happy in the last decade or so, optometry research is really picking up. There are many researchers coming up. Even when I interact with students, I feel so happy that there are so many of them who want to do something in research, and I think that is one way the profession will get recognition. People will understand the importance of the profession when you have, evidence, when you have more and more research coming through. Now, if you look at what are the current areas of research, I would say the top one would be myopia control. If you look at, any optometry magazines or even ophthalmology magazines, there's a lot of work going on in myopia. Of course, there are other fields like contact lenses, binocular vision, and all those things which are mentioned on the slide. The couple of things I want to mention here, which people generally don't consider for research, would be market research. Not many optometrists venture into that, and also education. So research related to education within the education domain. For example, if I teach my students in this particular way, what would be the impact of this teaching? This thing I feel not too many optometrists are working on. So maybe these are some of the areas for research going forward. Okay, there you go. Now, when you want to select a career path, you need to understand that it could be a little difficult. And I've seen people who forget how to smile because they are so tense. They are so worried about, what do I do now? I'm about to complete my graduation in optometry. Well, there are a few things you can definitely do. I always advise students to just take a walk in nature, and that frees your mind, that declutters your mind, and that helps you answer some of your questions. And the questions are like, what do you really like? Do you like to see patients? Do you like to talk to people? Do you like to train people? Do you like to teach students? Do you think, your concepts are very clear and you like explaining concept to students? Or you like to meet different people, travel, you want to interact with people? That could be a good beginning or a starting point for corporate, right? So what do you really like doing? So try to find that out. And also remember, there is no ideal job in the world. There is nothing ideal. Whatever you do, there will be 70% of the things you would like doing, and there will be 20-30% of your profile which you don't like doing, but you have to. So you have to maintain a balance between what you like to do and what you have to do. Okay. Now, once you decide where do you want to reach, then it is easy. Then you can find out how to reach there. And there are a few questions you need to ask yourself is, do I have it in me? For example, if I just dream of becoming a cricket player, can I do that? Do I have the basic skill required to play cricket? And if I don't have, then I think I need to reconsider. I need to start thinking again. Fortunately, once you have done a B optometry course, your basic overall knowledge of optometry is there. So if you want to, let us say, become a contact lens specialist, you need to ask, do I have what it takes to become a contact lens specialist? Can I fit various type of lenses? Your answer is yes, wonderful. If the answer is no, then the next question is, okay, where do I get to learn? And I have to go back and do certain things to gain that, right? So as a clinician, if you want to become a clinical practitioner, there are certain prerequisites. You need to be a good listener, because when your patient is telling you certain history, certain complaints, you need to understand. You need to be empathetic to the patient first, and then understand what could be the reasons, and then you can start, connecting the dot. So that is the next skill, which is clinical decision making. And of course, you need to be confident. When you're speaking to your patient, your communication needs to be crisp and clear, so there is no misinterpretation. And the most important thing, I feel, the base of any optometry domain is your optometry knowledge. Coming to researcher, if you think you want to become a research, I personally feel these are the prerequisites that you should have. The first and foremost is you should have a curious mind. You should be able to ask questions. Why is it like that? And if you keep challenging the norms, that means you have a curious mind. And that's the first prerequisite if you want to take up research as your career. And then the other things like analytical skills. Can you think analytically? Can you connect the dots? And then you have knowledge. You need to be passionate about it. And finally, patience, because you don't get an answer straight away. You have to spend days, months, sometimes years to find out an answer to your research question. So you need to be patient, right? Coming to academia, again, as my favorite, a ton of reading does not equal one good teacher. So there is definitely a scope for good teachers, right? So what do you need to have in you if you want to become a teacher? Well, you need to be passionate about teaching. This is what I personally feel. If someone says something else, it's okay. But this is my personal opinion. Unless you're passionate, it's very difficult to be a researcher, because it's not a profession which pays you really well in financial terms, right? But it pays you really, really well in terms of satisfaction. So if you're passionate about teaching, if you feel that I have knowledge and I want to share it with people, uh, if there is something difficult, I have a knack of simplifying it. It's like a commentator, sports commentator, right? So the sports commentators understand the sports, the difficulties and the nuances of the sports, and they bring it in simple language so that an average sport fan can understand. Same logic applies here in teaching. You have to have a knack of simplifying complex things. Then you need to enjoy interacting with the students, understand their psychology. And as I said earlier, nowadays, post-graduation is becoming mandatory. Coming to the plus and minus of teaching, as I said, very high satisfaction, great respect. In financial terms, sometimes you may not be as happy as with other profession. Corporate, I think we have discussed that. I don't want to spend too much, but just the plus and minus of corporate. Growth wise, you get rapid growth, vertical and horizontal. Vertical means in the same domain. If you are a trainer, you can grow as a trainer. Horizontal means, suppose today you are a trainer, but tomorrow you have gained enough knowledge in business and you want to enter sales and marketing domain. You can do that as well, provided you have it, have what it takes to be there. So vertical as well as horizontal. Generally, financially, it is rewarding. There are certain things you need to understand is business integration. So if you are very highly clinically oriented, and if you like to see patients day in, day out, then this may not be an option for you, because you won't get that opportunity to see patients so often. You may get once in a while to troubleshoot a patient, but not more than that. Sometimes the job pressure is too much. It is target oriented, so it is demanding. And sometimes, not sometimes, always it needs good management and leadership skills, good interpersonal skills, right? Now, these are the common qualities that everyone needs, every optometrist would need, right? You need to have the right attitude and positive attitude and passion to do well in your particular field. Your knowledge as an optometrist is important, essential in everything you do which is related to optometry. Trust me. You will be known for your knowledge first and then other things, right? So technical knowledge or optometry core knowledge and skills are very important. Communication skills, I mean, there is nothing in human interaction which does not need communication skills. Every human relation require communication skill, whether it is mother and child, whether it is spouses, whether it is friends, patient and doctor. All these relationships require good communication skills. And finally, how much willing are you to learn new things? That is important, because this is a very dynamic world. Every now and then there are new things coming up, and you need to be willing to learn new things and apply, right? So as Albert Einstein had said, once you stop learning, you start dying, right? I don't want to get into this, but we've gone through certain domains of optometry, and you can think which is appealing more to you. I generally feel if you are in the first 2 years, you don't need to worry too much. What you need to do is just learn whatever your teachers are teaching you. Read as many books as possible. uh, See patients if possible, start interacting with your patients if possible. Just expose yourself to everything that optometry offers. In third year and in final year, you will start understanding your likings better, because by then you would have been exposed to most of the domains. Towards the end of your final year, you would have seen patients, you would have seen contact lens patient, you would have seen binocular vision patient. So you would understand that particular aspect better after seeing patients. Until then, it's just in your mind. You just think you like contact lenses, but unless and until you've seen a few patients, you don't know what contact lenses are all about. So don't make your decision too early. Give yourself time to expose yourself to different domains within optometry, and then you can take a decision as to what you want to do, right? So this I like this particular one, that what matters is how you see yourself, and not what others are seeing in you. And finally, I like the last couple of slides where, these are the headlines you get. Sometimes they are depressing. You don't like them, right? Negative headlines, COVID-19 and losing jobs, and, is this the end of the world, and so on. And as I said, it's my dream that I want to see a newspaper headline looking more like this. So this is my dream, and this dream can be realized if each one of us does our best, and one of us thinks from the patient's point of view as to how I can give my best to help my society, to help my patients see better and have a better lifestyle, right? So very soon I want to see this, that optometry rules. Okay, thank you very much for your attention, guys. I'm not sure if I've taken more time or less time, but this is what I wanted to share with you in terms of slides and in terms of what I wanted to speak. Now we are open to interaction. Darshita?
Thank you so much, sir. So you have all covered all the the questions we have. What are the future prospects of a job? What tasks we'll be doing? How much we'll be making? You have covered all the prospects of the career counselor.
Okay.
One query what we have is, how do we network more effectively?
Yeah, I think it's a very important question. And fortunately, nowadays it's so much easier for you to network, right? Because there are so many platforms to network. So you have Facebook, you have Instagram, you have LinkedIn, and so on. So I personally feel you just need to be a little confident and a little professional when you want to network. I can see Anand also. Hi, Anand.
Hello, sir. How are you?
Good to see you, man.
I was listening to you for the last half an hour.
Oh,
it's always amusing to listen to you.
Thank you so much, man. So I'm just answering a question: how do we network, right?
Yes,
so,
sir.
So I think one thing you're already doing in terms of networking is attending a conference like this, right? This is, the easiest thing to start your network. When you start attending events like this, now this is online, this is virtual, but very soon we'll get back to meeting people as well. So when it is possible for you to attend conferences, you need to start introducing yourselves to speakers once the lecture is over. You need to start being proactive to introduce yourself to students from other institute or the optometrist whom you think share similar interests. So I personally really enjoy if someone comes up to me and says, I'm this, and I'm also interested in contact lens, or, I also like education and so on. So that really impresses me. Let me be very honest with you. If a student comes up to me, walks up to me and confidently introduces himself or herself to me, I really appreciate that. And I remember that as well. So this is one thing, the first thing you can start doing, right? If it is difficult to meet in person, you can always get, email IDs, or you have Facebook profiles, etc. And you can nicely introduce yourself there as well on your Facebook chat or LinkedIn. It's a very professional networking, I would say, social media platform. So introduce yourself very professionally and confidently that I am a student of this, and I would like to connect with you because I have a couple of questions to ask you on contact lenses and so on. So I think it's very easy today, and there are many multiple groups also where you can be a part of those groups, and then you can, once you become a part of the group, you can start talking to them individually as well. So not very difficult. Just be confident about yourself and be proactive in approaching. Fortunately, today's optometrists are very, very happy to, I would say, get connected. They're very happy to respond. So I can definitely tell you on my behalf, for myself, but I'm sure if someone contacts Anand and, asks a question or tries to approach Anand, I'm sure he would be happy to answer. Am I right, Anand?
Definitely, sir. Why not?
Yeah.
But
So
if
that's
you are there,
exactly.
you are a better person.
So in fact, we like people to approach us so that, we see the confidence in their eyes. We see that they want to do better in the optometry domain, because we want to see optometry grow together, all of us. So feel free to interact. Feel free to approach any one of us on any of the platforms.
Thank you so much, sir. The next question we have is, for a student who has just graduated in optometry, how should he or she identify her skills?
How should you identify your skills, right?
Yes.
I think once you're through with your 4 years of optometry program, you should be fairly aware of what your skills are.
Yes.
After 4 years of optometry, I'm not sure if you don't know anything about yourself. I'm talking about specific to optometry, not as life and human being, but optometry skills. You know that I can see contact, I can assess a contact lens fit well or not. You know it for yourself. You know if I can assess soft contact lens fitting, GP contact lens fitting, or scleral lenses or not. So by then you should be aware of your own skills. If you're really not aware, then maybe you can have a colleague or a friend, and you can seek your colleague's help in trying to understand your skills better. The next level is you can speak to your educators, your teachers, that, sir, how do you think I am performing in this particular skill? So during your this is why you have your internal assessment and your practical assessments, that after those assessments, there should be a one-on-one session with your educator, with your examiner, where there will be free exchange of feedback. So, sir, what do you think I performed well in, and where do you think I need more practice? And that's when the examiner or the educator gives you feedback that you've done well in these 1, 2, 3, 4 areas, but you need more exposure and more practice in this particular area. So get in touch with either your colleagues or your teachers. They are the best guides. They will help you understand your skills and knowledge level better. Anand, feel free to add to this whenever you want.
Definitely, sir. I agree with your points, sir. Actually, if a student is not aware of his interest after second or third year, I think he has missed classes or counseling, because everyone should be aware of their interest.
Yeah.
Okay, thank you, sir. The next question we have is, every candidate has to go through a vigorous screening or an interview in every job. So whom to approach for a feedback on a resume or CV?
मस्त है, एकदम तैयारी करके आए हैं क्वेश्चन पूछने के लिए. Yeah, so I think it's a very relevant question. It is, and suppose tomorrow if I have to apply for a particular job, I will also have to go through the same process, right? So the first thing comes is your CV. If you look at today, Google helps you a lot. So if you just type the format for CV, you'll get a few formats of CV. So the first thing is, in your mind, think of what you have done and what are your plus and minus and what is your educational qualification and what are your skills in optometry. Think of those things first and write down on a piece of paper straight away. Then look at various formats of the CV and you'll get top 2 or 3 or the formats that you like and you feel connected with. Pick those formats and then you start working on that. That's your first step. Once you have drafted something, then give it to your senior, or if you are comfortable with your teachers, or if you know any senior colleague within the field, you can ask their feedback, and I think they would be happy to do that. Someone who has some experience in interviewing, either he has undergone himself herself, or a person who has interviewed a few people. So go to them and get their feedback as to how do you think I can work on this particular CV, and then they will help you do that. But again, just to quickly summarize, your own self and whatever you see on the Google and other search engines, that's your first step. Second, maybe a colleague of yours or a friend of yours who you're comfortable with. Third, your teachers whom you were more comfortable with. And fourth, your senior colleagues within optometry whom you know a little bit at least, and whom you think have a little bit of exposure in that particular field. So this way you'll get some feedback from these people.
Thank you so much, sir. The next query we have is, whenever we are selected in an industry, in an eyewear industry, mainly I talk about, competency is something which we are always judged for. So what is the criteria for judging the competency of a professional?
What is the criteria of judging now as a student or as a passing out student, I'm sure you would be given you have a list of skills that an optometrist needs to acquire. In fact, there is a document by by ASCO, which has common minimum optometry curriculum and which also has ILOCS, Indian entry level optometry competency skills. So these documents are ready. They are there in public domain. If you want, you can write to any one of us and we can share those with you. So at the end of third year, 1, 2, 3, 4, 5, these are the skills I need to acquire. It's clearly mentioned. At the end of final year, at the time of graduation, an optometrist needs to acquire 1, 2, 3, 4, 5. These skills are very clearly mentioned. Okay, that's one. Secondly, it will vary with your job that you are applying for. For example, if you are applying for a place as a clinical optometrist, they would definitely want you to be very thorough in patient examination, which includes history taking, refraction, and maybe contact lens workup. So this is where they will not compromise at all, because that's the core competency required for that particular job. They would also want you to be good in conversation and interaction with your patients. So these are the skills they want you to be extremely good at. Now, suppose you're not very good at indirect ophthalmoscopy. For that particular domain, they may not be very hung up on that. They will be like, okay, I don't need my optometrist to perform indirect ophthalmology anyway. So I'm not going to test that particular competency of this particular candidate, provided the other things are really good, right? So it depends on what you are applying for. If you are applying to a contact lens industry, they may not want you to be extremely good at clinical optometry, right? If you don't understand too many eye diseases, they might be okay with that. But your contact lens knowledge, they want to be very thorough. Your contact lens skills like fitting assessment, use of slit lamp, and so on, they would not compromise there. So depending on which industry you're applying for and what job you're applying for, they will be very particular about those skills. While as a graduating optometrist, you need to have a baseline level of all the optometry skills that are mentioned in the ILOCS, which is Indian Entry Level Optometry Competency Skills. Have I answered that?
Yes,
Darshita?
sir. So can you please explain the criteria in corporate firms and
Okay,
the corporate
in
industry?
specific to corporate. Okay. So
Yes, sir.
typically, if I am to interview someone in a corporate, I look at certain things. The first thing I look at is attitude. How the person comes across. Is the person confident? Is the person someone who wants to learn things? Is the person polite as well? Then the second thing is communication skills, because in corporate, it's extremely important how you carry yourself and how you interact with people. You can't compromise on that. So how well are your communication skills? I would try to judge that. Coming to optometry knowledge, if I am interviewing someone for let us say an ophthalmic lens industry, then obviously I would ask questions, technical questions related to ophthalmic lenses. I would ask questions like, what is Abbe number, right? What are the various materials? What are the advantages, disadvantages? Um, what is polycarbonate and what is Trivex, etc. What are the various lens design? What are the various types of progressive addition lenses? What is free from lens? And all those things I will ask. So it will be very specific to that particular industry. But apart from the technical things, what other things I would judge is the attitude of the person, the communication skills of the person, how the person responds when the person is in pushed a little bit, right? So if you're not very comfortable, how would you respond to that situation? This is something what we try to understand, because in life you will be seeing such situations, you will be in these situations, so we would like to know how you respond to that. That's what we try to understand.
Thank you so much, sir. One more query. How do we create a margin between the sales department and the optometrist in corporate sector?
Say, could you just repeat that, Darshita?
So how do we create a margin between the sales department and optometrist in corporate sector?
So how do you draw a line between the two departments?
Yeah.
So as an employee, you don't have to do that, because the industry itself, your employer would have a clear-cut job description that is given to you. So when an optometrist or when anyone is hired for a particular position, the job description is very clearly mentioned, and it is well within your right. If you don't understand that, it is well within your right as a candidate to ask, so what do I exactly have to do in my profile, in my this particular job? So you don't have to worry about that. It is already given in your job description. Now, there are some profiles where you need to do both, and that's a requirement from the company. You can't help that. You can either say, no, I won't do it. That's the best you can do. But if the job requirement is like that, you need to be clear about it. If you don't want to get into sales, you need to be upfront saying, sorry, sir, I wanted, a job which was purely professional or training related, and I won't be involved in a sales related job. But fortunately, there are enough jobs which have only professional services or only training related requirements also. So before going into the job interview, you need to understand the job description, only then appear for the interview. That helps you to prepare also.
Sir, I believe we should be ready for both the options. Like there should be amalgamation of sales and like technical knowledge, both the things, because both the things run side by side in every profession.
Yeah, to be very honest, yes. I mean, if it is corporate, it is obviously an entity which is based on business, right? So if you have business knowledge, that will always help, definitely help.
Yes.
But I have seen some people who are very particularly trainers who don't really want to do much about the business. Of course, they understand it's a corporate industry and main job is business, but their own profile is only training, right? And they're happy doing that only. They don't want to step on anything else. So what I'm trying to say here is, it will always help if you have more knowledge of multiple disciplines, it will always help. But by chance, suppose you are just specifically expert in only one domain, you might survive there as well. So don't worry too much. You will find something that you want to do.
So thank you so much, sir. Here we are concluding the session. We have no more queries.
Okay.
Thank you for having joined this AIMS Optometry Explorer 2021. Your active and dynamic participation has made this conference a successful event. I'm grateful to each and every one of you. Thank you so much.
Thank you so much. And once again, congratulations to the entire organizing team for organizing such conference, and all the very best, guys. Take care.
Thank you.
Thank you, sir. Thank you, team.
Hello. Hello everyone again. Being Vice President of OSA, me Darshita Siroi, let me again at this closing instance, thank you all for having joined this AIMS Optometry Explorer 2021. Your active and dynamic participation has made this conference a successful event. I am grateful to each and every one of you. During these tough times, these 2 days, we have been nourished with brilliant presentations from some of world top experts on matters related to optometry. I wish to thank all the presenters who took time to prepare the impressive presentations which we had the privilege of listening to. During this forum, we had in-depth discussions and communications on various major topics such as myopia control, orthoptics and vision therapy, teleoptometry, low vision, contact lenses, etc. Next, I would like to express my gratitude to all of you who have come together on this platform from various states and countries for your cooperation and which has enabled us to conduct a highly fruitful conference. AIMS Optometry Explorer is not only a conference now, but it has become a tradition that makes AOE a national event, a national platform, and a forum which brings together optometry fraternity. Last but not the least, I would like to extend most sincere gratitude to the joint efforts of all the participating leaders, experts, guests, sponsors for their extreme support, and our organizing committee, which has taken numerous sleepless nights to synchronize the program and ensure the last 2 days seamless flow of events. Hope this conference would be the most memorable one for a long time to come. Thank you very much. All the e-certificates to the participants will be provided within the 30 working days. So be patient and we'll be joining you back next year. Thank you guys for your support.